Good morning, everyone, and thanks for joining us today. I, Ankit Dogra, along with my teammates, Dr. Deepika Chhabra, Mr. Amit Saxena from Medical Services, Jagsonpal Pharmaceuticals Ltd, are delighted to welcome you all to the second day of the two-day academic conference, Abhilasha Saving Mothers, organized with a very noble intent to reduce maternal morbidity and mortality by Haryana Associations of Obstetricians and Gynecologists, powered by Jagsonpal Pharmaceuticals Ltd, makers of LycoRed soft gel capsules of lycopene, zinc, and selenium, EndoReg dienogest 2 mg tablets for the management of endometriosis and endometriosis-associated pelvic pain. We are thankful to Haryana Association of Obstetricians and Gynecologists for taking Jagsonpal Pharmaceuticals Ltd as the digital partner for the program. A warm and hearty welcome to all the esteemed faculty members and attendees. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the chat or the Q&A box. Please note this webinar is streaming live on the Facebook and the link is shared in the chat box. Also note for future reference, we'll upload this webinar on our YouTube channel, Jagsonpal Medical Insight. Now, let us start the program with the blessings of the Almighty. Now, we welcome the organizing chairperson of the conference, Dr. Ragini Agrawal ma'am, founder, president, HARObGyn, and the conveners of the program, Dr. Jyoti Malik ma'am, secretary, HARObGyn, Dr. Saroj ma'am, treasurer, HARObGyn, and Dr. Promila Malik ma'am, the past president, Gurgaon OG Society. We also invite the office bearers for the lamp lighting. Now, we request Dr. Ragini ma'am to kindly take the proceedings further.
A very good morning to all of you, and thank you so much for joining on a Sunday morning. It's a family time, but we as a gynecologist, we have dedicated our life for the saving mothers. And this CME is totally to prevent and reduce the maternal mortality in the state of Haryana. With the intent, we have formed this society. And Abhilasha is one of our major projects. And under that project, we have doing this CME. Just to recapitulate, we have three major projects under HARObGyn. One is Abhilasha, to reduce the maternal mortality in the state and to make our doctors safe medico-legally, ethically, clinically, and from the public also. So we have joined the hand, come together and form this platform. UDAN is to provide adolescent health services and mainly to prevent non-communicable diseases, cancer prevention, and STIs. Today's program is under the banner of Abhilasha, and here we have our own Haryana faculty in the way this platform is to promote the intellectual property of Haryana doctors. So most of our faculty is only from Haryana. Yes, we have few national faculty from other states also to carry on the program. And most of the advisor has joined us, Dr. Sonia Malik, Dr. Sunita Malik, Dr. Manjupuri Madam, and Dr. J.B. Sharma to give an insight of how to save the life of our maternal patients. So with this, a little introduction, I invite Dr. Saroj Kumar, who is my right hand and the real person behind the organizing this conference, to start the academic session. Over to you, Dr. Saroj.
Thank you, Dr. Ragini, for giving me this opportunity. And good morning, everyone. On behalf of Haryana Obstetrics Gynae Society, I welcome you all the eminent speakers and chairpersons for today's conference on shaming mothers. First of all, I would like to congratulate Dr. Ragini for all the hard work for women's health of Haryana. And she is working on this project since long in the era of COVID also. And coming to the first session, the workshop is on fetal medicine. Our worthy speakers are Dr. Aditya Garg and Dr. Moni Bhatia. For this session, I would like to invite Dr. Ragini Agrawal as chairperson. As we all know all about Dr. Ragini and her deeds and act as founder, president of Haryana Obstetrics Gynae Society, as well as many more societies. She is vice president Foxy. Welcome, Dr. Ragini. And our other chairperson is Dr. Deepika Deka. She is also a very renowned name and everyone knows her as senior consultant in fetal medicine of Obs and Gynae department of Cloud9 Hospital, Sector 47. She is president DGS Dwarka. She has many awards and publications to her credit. Welcome, Dr. Deepika. Our next chairperson is Dr. Seema Thakur. She is DM in medical genetics and has over 21 years of experience in the field of genetics. She is recipient of title of Professor 2016 to 2019 by Apollo Hospital Education and Research Foundation. She has many publications to her name. Welcome, Dr. Seema Thakur. Our next chairperson, Dr. Meenakshi Chauhan, has experience of 30 years in the field of Obs and Gynae, master trainer of emergency obstetrical care, ex-secretary and vice president of Rohtak branch of Foxy, and she has many awards. Down Award for best paper at the AICOG at Agra in January 2004, and AN Down Award for the best paper of AICOG Guwahati, prize for best paper at 59th AICOG. She has more than 100 publications to her credit. Welcome, Dr. Meenakshi. We are very happy that you are here today. Thank you, Dr. Meenakshi, and welcome.
Thank you.
Over to Dr. Ragini.
Thank you, Saroj. So our first workshop, fetal medicine, is being conducted by Dr. Aditya Garg and Dr. Moni Bhatia. Both are the fetal medicine expert from Haryana. We are very proud that Haryana has so many fetal medicine expert, which is fetal medicine, we all know, is a subspecialty of the gynecology, which is becoming day by day very, very important. And there are few patients which we have, and we have to refer them in time to the experts and take their second opinion also. Not only it is important for the mother, the coming baby, and it is important for us also. Every step in today medico-legally hostile world, we have to be very, very vigilant and save ourselves medico-legally also. So, Dr. Deepika Deka, welcome, Dr. Deepika Deka. Professor Deepika Deka has just joined, and we know she is the father or mother of the fetal medicine in India. There was a time when everything, when we are in thinking anything wrong, whether it is a torch infection, whether it is RH immunization, the only person where we have looked upon is Dr. Deepika Deka, the professor, AIMS. Now, we are very proud that she has come to Gurgaon and joined here in a corporate hospital.
So, good morning, everyone. First of all, I would like to thank Dr. Ragini ma'am, Dr. Moni, and organizers to give me this opportunity to interact with the obstetricians of the Haryana and Obs and Gynae. So, it's my pleasure to invite Dr. Moni for the talk on the cell-free fetal DNA in the clinical practice. And she has done her MBBS from Lady Hardinge Medical College and MS Obs and Gynae from Safdarjung Hospital, Delhi. And she is also alumni of the same medical college where I done the DM in medical genetics. She is ex-consultant Sir Gangaram Hospital, New Delhi. And currently she is working as a chief clinical geneticist and fetal medicine specialist at the Noble Hospital, Rohtak. She has got numerous publications in various national and international journals. And she has reviewed articles in international journals. She has got a special interest in recurrent miscarriages, fetal medicine, dysmorphology, and skeletal dysplasia. She has authored chapters in the textbooks of the neonatology, gynae textbooks, and the genetic clinics, and taken numerous faculty lectures in AOGD, Society of Fetal Medicine, IAMG, IMA, and IAP. She is co-chair Fetal Medicine Committee, Haryana Obs and Gynae, and she is life member of the Haryana Obs and Gynae Society. So welcome, Dr. You give your talk.
Thank you so much to Haryana Obs Gynae Society for giving me an opportunity to speak on this platform. Special thanks to Dr. Ragini ma'am. Thank you, Dr. Seema, for this nice introduction. Now I'll start my presentation. So I'll start with my talk on NIPT. Basically, it was by Dr. Aditya, basics of aneuploidy. But anyways, we'll go from newer to the previous biochemical screening, whatever is available. So I'll be discussing on non-invasive prenatal testing in which cell-free fetal DNA is used to identify Down syndrome, which is now the method of choice used by many obstetricians for aneuploidy screening. So basically, what exactly is aneuploidy? The presence of any abnormal number of chromosomes, if it is present, that is called aneuploidy. On the left-hand side, we can see the euploid chromosomal complement where the normal chromosomes are present. And on the right side, that is a case of trisomy 21, where there is extra chromosome 21, that is a case of aneuploidy. The common aneuploidies are Down syndrome, trisomy 13, trisomy 18. Down syndrome is the most common form of aneuploidy, in which there is a live-born baby is born. The other aneuploidies, trisomy 13 and 18, are less prevalent as compared from Down syndrome, but these are also very important because these are the conditions where a live-born baby may be born. So screening for them is available. So this will be covered in detail by Dr. Aditya. But anyways, just to give you a recap of what aneuploidy screening is all about, it all started in 1970s where maternal age more than 35 years alone was used. Then came the era of AFP, then triple marker screening, quadruple screening, then the double marker test, then finally the combined test. And now in 2011, cell-free fetal DNA was introduced into clinical practice. And in December 2012, it came in India. And now it has taken up by various companies, and it is every other day new companies coming up and promoting this non-invasive prenatal testing because of the huge load of newborn babies being delivered in India. So the biochemical screening will be covered later by Dr. Aditya in his talk. So basically, what exactly is non-invasive prenatal testing? Basically, what happens in the maternal blood, both the free fetal DNA from the mother as well as from the fetus is present. Mostly it is a maternal DNA, but some component is from the fetus. It is a fragmented DNA, and it ranges from 150 to 200 base pair. It does not truly represent the true fetal karyotype because it is from the placenta. So there is a remote possibility of confined placental mosaicism, which can be there because whatever DNA we are extracting, that is from the placenta and not truly the fetal karyotype. And as the gestation advances, the amount of the fetal DNA increases. It is around 2 to 20% depending upon the gestation whenever the test is being carried out. And it is detectable after 7 to 9 weeks of gestation. Some says that it can be detected as early as 4 weeks of gestation, but usually we offer testing after 12 weeks of gestation so as to reduce the chances of no call rate. Another important thing here is that it disappears within hours of delivery. It is important because if it would have been present even after delivery, then it would have interfered in the next pregnancy. But the good part is that it disappears within hours of delivery. So if it is done in the pregnancy, it does not interfere with the previous pregnancy. So the techniques, there are 3 techniques which are being used. The massively parallel sequencing, the whole genome and the chromosome selective MPS approach. The other is the SNP based approach. We'll not go into the detail of it, but massively parallel sequencing has a higher sensitivity and it can give results at a lower fetal fraction. Vis-a-vis SNP requires a higher fetal fraction. But if SNP based methodology is used, it can detect triploidy, which may be missed by massively parallel sequencing. So whenever we are ordering the NIPT, we should ask the vendor which methodology they are using for the analysis of NIPT. The SNP has the advantage that it can detect uniparental disomy, consanguinity, non-paternity, and also in case of donor egg, it cannot be used. In those cases, massively parallel sequencing is a better methodology. Basically, what questions do we need to answer about NIPT? There are various prerequisites whenever the NIPT is being offered. First and foremost, the ultrasound should be carried out so as to detect the gestational age. Correct gestational age should be mentioned. If there is any vanishing twin which is present, then it is not a good test. The number of fetuses also makes a difference because the amount of the fetal fraction would depend upon that. Or if any abnormality is present in the ultrasound, then it is not a good test because it can be due to any other chromosomal abnormality. So prior ultrasound is required to diagnose all the associated problems which can be present, in which cases NIPT is not a good test. Also, prior to offering NIPT, pre-test counseling should be done. In pre-test counseling, we should tell the family that it provides information regarding common chromosomal aneuploidy, and it is not a diagnostic test, but a high-efficiency screening test. This should be very much clear in the mind of all the obstetricians, because if positive, it requires invasive testing, and it is not an indication of direct termination of pregnancy. Also, the negative test does not ensure an unaffected fetus because it only rules out common aneuploidy, but not all genetic disorders. And follow-up second trimester ultrasound is suggested to evaluate pregnancy for structural abnormalities. It is not a good test for cases with recurrent miscarriages, family history of any genetic disease, or if any malformation, increased nuchal translucency or nuchal fold thickness is present, it is not a good test. Then another question which is very important in the mind of obstetrician, why NIPT cannot replace any other biochemical screening. Either it should be used as primary screening or it should be used as contingent to positive screening. Both have pros and cons. If it is used as a primary screening, it is good, it is best, but it is expensive. Also, in the adjunctive benefits of the first trimester screening are lost. Like if PAPA is low, we would suspect that the patient can develop preeclampsia, IUGR, so monitoring for that is also required, which will be lost if we go ahead directly with the non-invasive prenatal testing. Another is the secondary NIPT, which is offered once the combined screening or any biochemical screening turns out to be positive. In those cases, it is a good test, but if any ultrasound abnormality or any positive family history is present, in those cases, it is not a good test. Another important point is, what if ultrasound abnormalities are present or if there is family history present? So if any ultrasound abnormality is present, it is not a good test because anyway, we had one case where there were previous 2 miscarriages were present. In the next pregnancy, there was a case in which the cleft lip palate, echogenic bowel, echogenic focus in the left ventricle and choroid plexus cyst was present. NIPT was normal. The patient continued the pregnancy and the baby which was born had mental retardation, and when the karyotype analysis was done, it was a case of unbalanced translocation between chromosome 10 and 15. So if any ultrasound abnormality is present, if any history of recurrent abortions is present, it is not a good test. Another point is family history important? Yes, family history is very important because if any family history of previously child with mental retardation, epilepsy or any other genetic disorder is present, it is not a good test because there was a family in which there was a previous child who had microcephaly, microarray was done, it turned out to be normal. The treating obstetrician advised NIPT because there is a previous child with mental retardation. NIPT was normal. They continued the pregnancy and the next baby also had intellectual disability with microcephaly. So important point here to stress is that the proband diagnosis should be made prior to offering any test, and also NIPT cannot rule out all genetic disorders. Then the next is what gestation should it be done? It can be done anytime starting from 7 weeks till term, but it should be offered after 12 weeks of gestation because fetal fraction is very important. If the fetal fraction is less than 4%, it is not a good test. So gestation is important whenever we are ordering the test. There are few modifiers of the fetal fraction, like if there is an obese woman is present, or if the patient is on heparin, or the patient is having SLE, then we may not get the adequate fetal fraction. In those cases, the test should be done later in pregnancy. And if NIPT comes out to be positive, then what next needs to be done? If NIPT is positive, then diagnostic testing is required because anyways, all these tests have a positive predictive value of means if it is positive, it means it is truly positive. It varies for different trisomies. It is around 50% for Down syndrome, and for sex chromosomal abnormality, it is very less. So basically, we had a case in which NIPT was offered. It turned out to be no call was obtained, means no result was obtained. Then it was repeated again after 10 days. It turned out to be positive for trisomy 18. The pregnancy was already 20 weeks, so they decided to terminate the pregnancy before undergoing any amniocentesis. So when the fetus was evaluated, when the autopsy was done and the karyotype was performed, it was found that the karyotype was absolutely normal. So positive NIPT does not mean that the fetus will be affected. Confirmatory testing is required. So these are the fetal fraction modifiers that if in obese women, also in trisomy 18, 13, digynec triploidy or Turner syndrome, in those cases, the DNA amount would be less because of the smaller placenta. Also in maternal medication exposure, like if the patient is on heparin, the test should be taken as far as away from the last dose of heparin, because heparin also interferes with the fetal fraction. The next is if NIPT is uninterpretable or no call, what next needs to be done? It is found that it can be due to blood collection is inappropriate, low fetal fraction, or assay failure. Some says that repeat sample can be taken and results are available in half to 2/3 of the cases. ACOG says that if no call is obtained, we can directly go ahead with amniocentesis, because in one study it was found that in 8% of the cases in which no call was obtained, 22% of the fetuses were aneuploid, because we know that if there is low fetal fraction, it can be due to trisomy 18, 13, triploidy, Turner syndrome, etc. Another is, does NIPT exclude all genetic disorder? No, NIPT cannot exclude all genetic disorder. We'll rule out only the common aneuploidies. For that matter, nowadays, NIPT has taken up the market in such a big way that all the obstetricians are directly offering NIPT if the patient can afford. But we have to tell the family that yes, it is only a screening test, and also that too for common aneuploidy. It cannot guarantee an unaffected fetus. We had one case in which the NIPT was performed at 14 weeks. Later on, the fetus developed short, long bones. The genetic testing for achondroplasia and the chromosomal analysis was done. It was normal. But anyways, we were not able to identify the cause in that case, and the patient was lost to follow-up. But NIPT was normal. It cannot guarantee an unaffected fetus. So there are a number of causes in which false positive NIPT can be obtained. As we have already discussed that it is not truly the fetal sample, it is from the trophoblastic cells. So it can be positive in cases of confined placental mosaicism. Also, if vanishing twin is present, that may be aneuploid. Because of that also it can be positive. So it is said that if there is a vanishing twin present, it should be taken at least 8 weeks after that vanishing twin report, whatever is available with you. It can also be due to maternal aneuploidy, mosaicism, or copy number variations in the mother. Also, if the mother is having any malignancy, also in cases of fibroid, also it is known that it can give false positive results. There are a number of advances in non-invasive prenatal testing. It includes whole genome NIPT, where all the chromosomes are being studied. The other is the NIPS for common microdeletion syndromes and NIPS for single gene disorders. Though NIPS for single gene disorders is not available as of now, but for the whole genome and microdeletions, it is available. But the ACMG, ACOG guidelines do not recommend whole genome in the testing for all the microdeletion, because the positive predictive value is less. If you want to go ahead with a microdeletion, then the better test is to undergo diagnostic testing. So the recommendations by the ACMG and ACOG says that NIPS should be performed at 12 weeks of gestation or later to reduce no calls due to low fetal fraction. NIPS cannot be used to detect all chromosomal abnormality. It does not diagnose congenital malformation like spina bifida, congenital heart disease, for which detailed ultrasound is required. Also, it cannot predict abnormal pregnancy outcomes like growth restriction, preeclampsia, neural tube defect, or steroid sulfatase deficiency, which you can suspect once you order biochemical screening. If PAPA is low, or if AFP is raised, or unconjugated is low, then you would suspect that these can be one of the reasons. NIPS is not a good test for single gene disorder, and the important point is it cannot replace imaging by ultrasound studies. Now, many companies are promoting it for rare autosomal trisomies, for microdeletion, and the whole genome CNVs. The ACMG guidelines do not promote any of them. They say that the positive predictive value is less, and they have a high false positive and high false negative rates. This is from the ACMG guidelines, and the ACOG guidelines also states the similar thing, that it is not a good test for microdeletion, also mosaic trisomy, and for the whole genome cell-free DNA. Important point is NIPT versus diagnostic test. What needs to be offered to the family? We have to do pre-test counseling, explain everything to the family. The final decision is of the patient, what they want to go ahead with. NIPT will rule out common aneuploidy. If we go ahead with a diagnostic test, we can rule out all chromosomal abnormality, because in the amniocentesis, you can go ahead with a microarray. If the family is not willing to take a risk of miscarriage, then you can offer them NIPT. But the important point here to stress is it should be a non-directive counseling. All the points should be made clear to the patient, and the final decision is for the patient to decide whether they want to go ahead with the non-invasive or the diagnostic testing, once any biochemical screening turns out to be positive. So the take-home messages from this presentation is, it is a screening test, and that too for common aneuploidies. Pre-test counseling should be done, and finally the decision should be made by the patient what they want to go ahead with. The cost and outcome should be discussed with the patient. It does not exclude all genetic disorder. If it comes out to be positive, confirmatory test is always required. And if NIPT is already been done, then biochemical screening or soft marker screening is not recommended because these screening tests are to detect Down syndrome. Thank you.
So thank you, Dr. Moni, for such a wonderful message to the obstetrician that, when to do the NIPT, how to implement in the clinical practice. So the most important point from the, from the medical genetics point is that, this has to be done, after NT scan in our, particularly in our setups. So it has to be, it should not be used as a primary method of screening, which we have realized that many of the, the cases undergo as a primary cell-free fetal DNA, bypassing the, the first trimester screening. So the message should be very clear that it cannot replace our first trimester screening, because in our country and for that matter anywhere, the cost is a big concern, but definitely it is also important to rule out the structural abnormalities, increased NT or the low PAPE, increased beta HCG. And these are the indications which we will only identify by the first doing the first trimester combined screening. Because when these are present, like any structural abnormalities, NT beyond 99 centile, PAPE less than 0.2 mom, beta HCG greater than 5 mom, there are increased chances of aneuploidy, and then the NIPT is not a good option because this is still a screening test only. So in all these cases, the invasive testing is indicated. So first important message is that we should not bypass the first trimester screening, and this has to be done first. We have to use this in our setting as a contingent method, that any woman who has a risk between 250, 1 in 250 to 1 in 1500, they should be offered NIPT as an the intermediate grip which we are highlighting. So one important message is that. And then the second message is that, there should be no termination if the NIPT is positive, like Dr. Moni has already highlighted that case didn't have trisomy 18. So many a times we get the, the pressure from the, our group that, we can terminate. Why can't we terminate? NIPT is 99%. But still we have to remember that, this is a very, this is not a confirmatory test. This is still a screening test only. And after the no call rate, one has to do the invasive testing only, rather than just doing the ultrasound and counseling the women. So these are the important messages which Dr. Moni has already highlighted and we have shared with you. So wonderful, Dr. Moni. So anybody?
I think Dr. Moni has done a very good job.
Yes.
One more thing that you need to tell is the contraindications. Which are the cases you will actually not do NIPT, because when you find that the nuchal translucency is very big, and when there is a congenital malformation which is really suggestive of a chromosomal abnormality, don't waste time on doing an NIPT. You will directly go in for an invasive testing. So whenever the obstetricians find that there is a case where you want to do between NIPT or invasive testing, you should actually refer to the fetal medicine specialist.
Yeah, this is a very powerful, highly sensitive and a specific test, but this has to be used very judiciously. The ultrasound abnormality has to be excluded first. So any questions? I think we will have more questions in this biochemical screening, because that is not as straightforward as, the NIPT. So I think if we have no questions, we move on to the next session. So.
Yeah.
Put the wall.
So before moving to next session, let us have this empowering and empathic quote. It says, "I am powerful being. I am the creator of my feelings. Irrespective of the stimulus, no one can hurt me. I create my every emotion and I always have a choice. I forgive myself, but not blaming them for my hurt. I take personal responsibility. I heal myself. I forgive myself." By the very renowned life coach, B.K. Shivani ji. And this is the thanks to our sponsors. And a very short video from the LifeCell. Yes, ma'am.
that contribute to 80%
Yeah.
of fetal deaths.
It's playing.
Diagnostic space, we once again pioneered the expanded QF-PCR diagnostic test in India. This test detects several additional trisomies that contribute to 80% of fetal deaths.
So now we can move to our next session, ma'am.
I will introduce Dr. Aditya Garg. He is a consultant Garg Maternity and Surgical Center, consultant at ABS Ultrasound Center, approved Center for Invasive Genetic Testing, ex-consultant fetal-maternal medicine, Sussex University Hospital, UK, ex-senior registrar, St. Mary Hospital, lecturer in OBGYN and Manchester University. So we can see that his experience is very, very extensive. And we are really going to get benefited here. I have requested and again requesting to all speakers, please, you have to finish in time. So everybody will enjoy and we will not late. We will have to finish this program by 5:30. Maybe we have to cut our 1 or 2 minute very crisp message to all practicing gynecologists. With this word, I invite you, Dr. Aditya Garg. Floor is yours.
Ma'am, thank you so much.
I'm Dr. Aditya Garg. I'll be talking about prenatal screening for employees. I'll just be talking briefly about basic principles and some practices. Dr. Moni has already given us a really wonderful talk about the advances. So I'll skip that from my presentation. We all know what Down syndrome is. This is an extra copy of chromosome 21. So the reason why Down syndrome was selected as a screening disease was because it is one of the commonest causes of non-lethal trisomy, and the incidence is 800 per live births. So it's a genetic disorder, and it's the most frequently occurring chromosome developmental retardation and developmental delay in the world. A targeted scan for anomalies will only pick up about 50 to 60% fetuses with a false positive rate of 12 to 15%. And that is why we need screening for this. Causes of Down syndrome, as we all know, 95% are trisomies due to non-disjunction, around 2% are mosaics, 3% are translocations. If you have a Robertsonian translocation of 1421, if you are a carrier mother, you have a 10% risk of having a baby with Downs. If you are a carrier father, you have a 1% risk of syndrome. The other risk factors include family history, previous baby with Downs, a woman who herself has Down syndrome, the baby has got a 30% risk of having Down syndrome. And the last but not the least is the advanced maternal age. In expert in fetal medicine, the report of screening is still awaited. But what exactly do all these numbers actually mean? This is what basically screening is. This is a whole set of population. We apply a screening test to this population to identify this subset of individuals who are at a high risk of having the disease or a condition. Now, this population is then further subjected to a diagnostic test, which is represented by the C. So after the diagnostic test, most of the people will be told that you do not have the disease and you are normal. Some of them will have the disease and will be given a diagnosis. So screening allows us to target our resources at the high-risk population. Some basic assumptions about screening is that screening test is easy, reliable, non-invasive, and widely available. It should cost much less than the diagnostic test and should carry no risk to the people who are unaffected. Test for diagnosis, however, has to be accurate and less hazardous than the disease itself. So in a population which has got a mixture of individuals, this is what an ideal screening be. It should select every affected and should not select any unaffected individual. But in real world, the screening test is not perfect. It will always some non-affected individuals and some affected individuals. So some basics of screening. For a term called sensitivity, which means the proportion of actual positives which are correctly identified as positives. Second is specificity. This is the proportion of negatives which are correctly identified as negatives. So a perfect screening test would be 100% sensitive and 100% specific. But nothing in life is ever 100%. The second terms that we need to talk about during screening is a priori risk and MOM. These are very important. A priori risk is the background risk of a woman with the fetus having at that particular gestation. This may be calculated just by age or on other maternal characteristics. And every screening test will give us a likelihood ratio, which is multiplied by the a priori risk. And this will give us the final risks. Priori risk multiplied by the likelihood ratio of the test will calculate the new risk. If we go on to sequential testing, the a priori risk from the test will the final risk from the test will become the a priori risk for subsequent testing. The second term is multiple of median. Now, in a perfectly distributed bell curve, median, mode, and the median value is always the same. So multiple of median means how far an individual test deviates from the median of that population. So MOM of 1 means that the result is exactly what the median value is. MOM of 2 means that the result is double of the median value, and MOM of half means it is half the median value. So the first screening test we had for Down syndrome was how old are you? If you are 35 or older, a woman was offered invasive testing. Some serum markers that we use now are PAP-A and beta-HCG. These are first trimester markers. PAP-A usually increases with gestation and it is produced by placental syncytial trophoblasts. In Down syndrome, it is reduced. Beta-HCG is produced by placental syncytial trophoblasts as well, and it is raised in pregnancy by Down syndrome. And the second trimester serum markers that we commonly use include AFP, which is produced by the first levels in pregnancies affected by Down syndrome, estriol, which is produced by placenta and fetal adrenals, and we see reduced levels in Down syndrome. Inhibin A, because it is produced by placenta, has raised levels in pregnancy. So one quick sentence about the placental markers is that any marker that is produced by the placenta is usually raised and by fetus are usually decreased. So this is what happens to MOM in the ideal bell curve, the unaffected and the Down syndrome. So we see that the average value for HCG in Down syndrome affected pregnancies is better than normal pregnancies. Similarly, in PAP-A, the average value of PAP-A in Down syndrome pregnancies is lower than the unaffected population. With NT, where the ideal distribution curve shows this, and the Down syndrome pregnancies have a raised NT. This is about AFP. Again, it is lower in Down syndrome pregnancies. Estriol is lower in Down syndrome pregnancies, and inhibin A is higher in Down syndrome pregnancies. So this is a slide to summarize what happens to all these serum markers in Down syndrome. And please remember, trials distinguishable on the first trimester screening. So once we have done a good serum screen, we also want a sonographic screening for aneuploidies, purely because combination of sonographic screening and serum screening improves the sensitivity and the outcome of the testing. So in a first trimester genetic sonogram, what we look at is nuchal translucency, nasal bone. We also look for major structural anomalies. Ideally, we should also look for ductus venous Doppler and tricuspid regurgitation if we are certified. The detection rate with NT alone is only about 70 to 75%, but it increases to 90% when nasal bone is added. So this is what scan should look like. This is your nasal bone, and this is the NT. This is what a tricuspid regurgitation flow should look like for all of us who scan for our own NT assessments. Be across the tricuspid valve and not in the one chamber. This is what ductus venosus looks like, and this is what an abnormal ductus flow will look like. This fallacy why we get normal ductus venosus result is not a problem with the fetus, but the fact that it and the hepatic artery flow is similar to a reversed A wave on ductus. So if you have these, magnify your image, put the gate exactly on the ductus and recheck it before you give a report of a reversed A wave on the ductus venosus flow. Second trimester anomaly scan in case of a major structural defect like Dandy Walker's, cystic hydroma, omphalocele, the aneuploidy risk is almost 50%. In case of non-immune diseases, there's a 30% chance of an aneuploidy. Second common term is a soft marker. If there is just a single soft marker present on scan, but the risk increases with the number of signs identified. Commonly used soft markers that we use in our terminology are nuchal fold thickening, renal pyelectasis, echogenic bowel, is aberrant right subclavian artery, ventriculomegaly, and short long bones. In the absence of aneuploidy or major malformation, these do not have any significance in the prognosis. So when we talk about first trimester screening methodologies, just doing a dual marker and a maternal age has got a detection rate of only 60%. If we fix up the false positive rate as 5%. Adding NT to this whole thing increases the detection rate to 9%, and if we add nasal bone and NT, the detection rate would be 95%. However, this data is from Professor Kypros Nicolaides, and in real terms, my personal opinion is that first trimester screening will have a detection rate of around 90%, not more than that, even if you include the other scan markers. The concerns with the first trimester screening, however, are that fewer fetal medicine specialists perform CVS as compared to amnio, and there's a higher miscarriage risk associated with CVS as compared to amnio. The advantage, however, is that a lot of women will get a confirmation in the first trimester itself, and the termination will be very easy and less traumatizing to the couple. In second trimester screening, which is done between 15 to 22 weeks, currently the best option is quad test, which is got a detection rate of 70 to 80%. And if we add an anomaly scan and a quad test done adequately, the detection rate becomes 90%, which is almost equivalent to a pure first trimester screening. The advantage of a second trimester screening is that many abnormal fetuses would be spontaneously aborted, and a lot of structural anomalies would also be diagnosed on the scan. The disadvantage, however, is the biggest disadvantage is that more physical trauma and psychological trauma to the woman. And till a few months ago, MTP was not allowed after 20 weeks. So in an ideal world, what we want is we want a combined first and second trimester screening. The disadvantage of a combined first and second trimester screening is that the patient has to wait for the second trimester results before it is confirmed. Contingent screening basically means that women are divided into high, intermediate, and low risk first trimester screen. High risk group receive a diagnostic test. Low risk will not be given any further testing, and the intermediate risk group will receive a second trimester screening test. The using NIPT instead of a second trimester screening. However, if you are using this strategy, please remember that the high risk does not mean the normal 1 in 250. It actually means 1 in 10 or a best of 1 in 50. Otherwise, you'll end up doing NIPT on almost everyone or an invasive on almost everyone. So it is, if used properly, it is the best cost-effective method for detecting Down syndrome, and it will lead to fewer procedure-related euploid miscarriages and unnecessary terminations, and it has got the lowest cost per case of Down syndrome detected. So which path to choose depends upon the population covered by your practice. If you work in a small city where the facilities for NT scanning is not adequate or not available or not up to the mark, then it is best actually to use serum screening alone rather than rely on NT measurements. So basically, aneuploidy screening. Aneuploidy screening is basically just a computer software with a memory. The software has been approved by Fetal Medicine Foundation. What we put into the software is priority risk, variables, markers, and values. And what we get out of that software is a risk calculation. Now, this risk calculation obviously is very good, but it is not as simple as that. The sonographer who's done the NT scan should be FMF approved or certified. And please remember, getting certificate once does not mean that you are licensed for life. Annual licensing is done. The lab also has to be UK MCAS certified. The analytical kits have to be approved for use for screening in Down syndrome. And the software which uses FMF database has to have, and it is approved only by the organization. So just some examples of the software used which are FMF approved are Astraya, Viewpoint, Delphi, and LifeCycle. Please remember the commonest used software in India is Prisca, which is actually not approved by FMS. So before you are using a lab, it is your responsibility to check the scan image, check the lab performance and the software used. Only then should you advise clients about screening. Most important is counseling of couple prior to testing, getting their informed consent, and information and implications of both positive and negative results should be given to the couple prior to the test. This is a slide about the information that is required by a lab, and without all this information, if a lab is giving you a report of screening, that report actually is not valid. So labs also need to ensure that the whole blood is received with them within 48 hours of collection and serum samples within 72 hours of collection. Measurement of free HCG in samples collected beyond these limits are unreliable. I will come to some interesting cases where the lab actually did some mistakes in my next part of the talk. But some effects of variables, these are variables which are correlated negatively with maternal weight. So basically, the more the maternal weight, the lower the serum markers. Smoking of PAPA and HCG and an increase in inhibin level. And we know that African women have an increased PAPA, AFP and HCG, but South Asian women, which covers India, Pakistan, Bangladesh, also have an increased estriol and HCG. So in an ideal world, the lab should incorporate the local population into account. And I'll skip these because of the shortage of time, and I'll come back to them in the second part of my slide. So basically, key points to remember is that pre and post test counseling is absolutely essential. You should not do any screening test before counseling the couple first. The first requisite before embarking on any screening test for Downs is to confirm the dates with first trimester scan. Some maternal parameters can affect the measurement of serum markers. For example, maternal weight, smoking, diabetes, multiple pregnancy, IVF conception, and these should be notified to the lab. The best option is that in case you are worried, speak to the lab first before you send the sample. And please remember, all these are only screening tests, and a negative test does not guarantee a normal baby. Most labs will check for other aneuploidies also other than trisomy 21. And my recommendations to everybody is that all pregnant women, regardless of age, should be counseled and offered screening for Down syndrome before 20 weeks. The performance of Down syndrome screening post 20 weeks is very poor. Combined NT and dual screen should be offered to women presenting at less than 14 weeks and quad test after this time. And all positive tests should be followed up with proper counseling and diagnostic tests. So basically, I'll just talk about some special cases that I've seen in the last 2-3 months or so. So we all know in multiple pregnancies, what happens with diagnostic normal fetal placental unit can produce adequate markers to mask even the abnormal fetuses markers. So personally, I only use scan marker for twins. In monochorionic pregnancy, serum markers can be used after adjustment. But and the problem is false results due to mosaicism. And in triplets or higher order pregnancies, there is no known protocol for serum markers, and NT is the only thing which is relied on. So in case of any reduction that is planned, please always select the fetus with the highest NT if there is a significant discrepancy. So I'll put this case up. This was a patient who was sent to me for being high risk for trisomy 21, and her risk and all that stuff was calculated from a local lab, which was not approved. So basically, the advice from the lab was amniocentesis is advised for confirmation. And so scanned her, we found that, from her initial NT scan, I had monochorionic twins, and the lab had not catered to the fact that these are monochorionic twins. The second thing why I put this result is if you look at this scan report, you will find that both these twins, in spite of having different NTs and the same risk, fetus 1 and fetus 2. This is because in monochorionic twins, we expect them to be having the same genome, and it is always the higher risk which is assigned to both the twins in case of a mono. So points to remember in case of multiple pregnancies is always confirm the information that you are sending out to the lab, and also cross-check it when the report is out. And in case of twins, please do not rely solely on serum markers, except in cases of NL, which Dr. Moni has already talked about. And for monochorionic twins, the risk is always going to be the same. So if a lab gives you differential risks, it is not possible. Higher risk is always assigned to whatever is calculated to both the twins. The second special situation is in cases of bottoming serum results, diabetes. In cases of diabetes, PAP-A and AFP levels are decreased. The low MOM of PAP, in case of very low MOM of PAP-A, please remember to be vigilant for gestational diabetes. And in the second trimester, markers and E's can be lower, but not very significantly. So this was a patient who was referred to me for being high risk, and the risk was significantly increased from an age-related risk of 1 in 250. The risk was 1 in 50. If you look at this, PAP-A actually had a very low value, and the lab was not informed about the fact that it was recalculated, was found to be lower 700. So points to remember, again, always confirm the information on the report. Diabetes affect the screening result. And in case of insulin treatment, it is even more pronounced. So once recalculated, this patient was low risk, but she still opted for NIPT because of all the concerns that were told to us with a positive report. And it was only after a negative result that the couple were satisfied. And they later told me that the 2 weeks from their initial report to the final one were very, very tense. Information required by the lab and common fallacies. Again, I'll come to my slide from the original presentation. Obviously need a fetal CRL. We need the ultrasound scan date. We also need a blood sample collection date, weight of the patient, smoking status, ethnicity, any history of previous trisomy, patient's date of birth. We also need her NT levels and the number of live fetuses. Without this, the report of screening will not be valid. So I'll put up my next slide, and the highlights of the case for the next slide is please note the MOMs, and please also need the dates for scan and that of serum collection. And it took me 2 hours to find out what was happening with this patient. So this was the patient. If you look at the MOMs here, both her HCG was 0.44 and PAP-A was 0.05. Looking at this, the lab had given a very high risk of more than 1 in 5, which was above their cutoff rate of detection for both trisomy 18-13. And at the first instance, everything looked absolutely routine, no concerns. Every information was provided to the lab except for pregnancy type. She was a non-smoker, diabetes was no, and this is what it was. So if you look at the scan date carefully, she had an ultrasound scan on 7th of May, and sample was collected for serum on 14th of May. What had happened with this particular individual was that MOMs were very low, but also 1 week difference between the scan and the serum collection, which is not actually true. The date on her scan report was 1 week early because the patient had paid in advance for the scan 1 week ago. And that date was erroneously put on the screening report. So she actually had a fetus which was only 11 weeks. So once that was taken into account, the lab was able to recalculate the screening parameters, and all the results were low risk. So basically, this is one slide that I wanted to highlight really, that please cross-check every information that you send to the lab and on the report as well. Do not rely on the lab to make sure that they've transcribed the information correctly. So points to remember again, pre and post-test counseling are absolutely essential. Maternal parameters can affect it. I've already talked about this slide. And thank you so much. Now I leave the floor open for Dr. Moni for her case. Thank you.
Dr. Aditya, it was a wonderful talk and a wonderful cases you have taken. So I'll now discuss my cases, and the things would be easier for me because you have talked almost everything. So it'll be easy for me to discuss my cases now. So basically, as we have already discussed, NIPT and biochemical screening and Down syndrome, how to go ahead with. So I'll be discussing a case of NIPT. This is a case of a 33-year-old lady. She was a 4th gravida. She had a 7-year-old boy, and thereafter she had another boy baby who had Down syndrome, and then that boy had expired on day 17 of life, was diagnosed to be having trisomy 21. Thereafter, the doctor advised medical termination of pregnancy next time because she had 2 CT scans done in pregnancy because due to COVID, and then she came to us in 4th pregnancy. In the 4th pregnancy, her NT-NB scan was normal. The doctor advised double marker test, which was low risk. Here, important point to stress is that first, though it is not in the scope of this aneuploidy screening, MTP was offered with 2 CT scans, which is incorrect because with the 2 CT scans also exposure, there is no risk to the baby. The next is double marker screening was offered with a previous child with Down syndrome. If there is a previous child with Down syndrome, the risk of recurrence automatically increases to 1%, which is high risk, so double marker testing should not have been offered. Thereafter, when the double marker was low risk, then the family was offered NIPT without any pre-test counseling. In the NIPT, it turned out to be positive for Turner syndrome. It was a high risk for XO. Then the family came to us that what next needs to be done in this case, because this was a case of Turner syndrome. They wanted termination of pregnancy. With the sex chromosomal abnormality, the positive predictive value is less and the sensitivity is also less as compared from the Down syndrome testing for NIPT testing for Down syndrome. Further, the testing was offered. Amniocentesis was done with the qFPCR and karyotype. Ideally, fish analysis would have been done because fish is a better test of choice for mosaicism, but it was not possible due to some technical reasons. The qFPCR testing was offered and it turned out to be normal. The karyotype was also offered of the fetus. That also turned out to be normal. So the fetus was totally unaffected. As we have discussed in a previous talk, that false positive can be due to some maternal CNV or maternal mosaicism chromosomal abnormality. The karyotype of the mother was also offered and it also turned out to be normal except just a polymorphic variant. So the family is continuing the pregnancy. There's another similar case of a 35-year female. That was a doctor couple. She was a 4th gravida. She had 1 6-year-old daughter. The second and third were spontaneous miscarriages. They went ahead with the analysis of the third abortus and the microarray showed trisomy 22. Thereafter, the karyotype of the couple was offered and it was normal. Because they had previous 2 miscarriages, they got direct NIPT done in the next pregnancy. And again, in the NIPT, it turned out to be positive for sex chromosomal abnormality. Monosomy X was detected. They got it repeated from some other lab. Then also it was a high-risk situation. Then they went ahead with amniocentesis. And in the amniocentesis, a low-level mosaicism for XO was identified. It was 4%. XO and 96% was normal. So the family was concerned how to go ahead with this pregnancy. So counseling is very important. We need to tell the family about the ascertainment bias in the prenatal samples, how is going to be the outcome of the baby. These all things needs to be discussed with the family. But here I would just want to stress is that in NIPT, sometimes sex chromosomal abnormalities can be identified and the positive predictive value for these sex chromosomal abnormalities is low. It is lowest for XO. For Turner syndrome, it is the lowest. This is the two tables from 2 different papers, which says that the positive predictive value is 14% for Turner syndrome. And for Klinefelter, it is comparatively higher, 50%. And another article also says that it is 21% for Turner syndrome and for Klinefelter, it is as high as 90%. So it should be clear in the mind of all of us. And we need to counsel the family that once we are ordering the test, even for Down syndrome or for the common aneuploidy, we may be able to identify something unusual and you may need to undergo invasive testing, though not for Down syndrome. Pre-test counseling is very important in these cases. All available options needs to be discussed. We should tell the family what abnormalities can be detected whenever we are ordering NIPT. It is not a good test, which I've already discussed, not a good test for cases with recurrent abortions, family history of any genetic disease, or any malformation in the ultrasound. Also in vanishing twin, many a times what happens in the early gestation, there is a case of vanishing twin, then also the NIPT is offered. In those cases also, it can come out to be positive and then further testing may be indicated. In vanishing twin, ideally it should not be offered because the aneuploid fetus may be, the vanishing twin fetus may be aneuploid and it can turn out to be false positive. This is another case of a 28-year-old primary gravida. She had normal nuchal scan. Her quadruple marker test was positive for trisomy 21 and the risk was 1:187. Her biochemical analytes were markedly abnormal. AFP of 4.29 mom, estriol was normal. SCG and inhibin were also very high to the range of 4.16 and 8.86 moms. Level 2 scan done somewhere outside showed echogenic bowel and early onset IUGR. Based on this report, we counsel the family that these analytes are markedly abnormal. So with these analytes, there is high chances of abnormal adverse pregnancy outcome in this pregnancy, but they wanted an answer for the mental retardation. They wanted to rule out aneuploid. Thereafter, when the scan was done, there was a minimal pericardial effusion present. Echogenic bowel was there. There was placentomegaly, and also there was reversal of flow in the umbilical vessel. The family was told that all these are the poor prognostic markers and there is high chances that this pregnancy may not continue. And they got the testing done and amniocentesis turned out to be normal. They had a normal microarray report. When the family was informed about this report, we asked them to get a repeat ultrasound done. She got the ultrasound done somewhere outside after 2 to 3 days of this report, and it was an intrauterine demise. So it was comparatively easier for us to counsel the family because prior to doing the procedure, we had told the family that with these abnormal analytes, there is very high chance of abnormal adverse pregnancy outcome in this pregnancy. So coming to the obstetric outcome with these analytes, low PAPA and low HCG in the first trimester, less than 0.5 moms, is associated with high risk of preeclampsia, preterm labor, spontaneous abortions, and low birth weight baby. Low PAPA is also seems to be associated with Cornelia-de-Lange syndrome, as it was mentioned in one of the articles. With a high PAPA in the first trimester, as high as 5 moms, also has no effect on the baby. Likewise, high free beta HCG in the first trimester has no effect. If we compare the first trimester from the second trimester beta HCG, it is found that as low HCG in the first trimester is associated with adverse outcome, high HCG in the second trimester is associated with adverse outcome in the form of preterm labor, intrauterine death, IUGR, and gestational hypertension. Increased AFP is known to all is associated with neural tube defect if it is more than 2.5 moms. Also, it is associated with adverse outcome in the form of IUGR, abruption, intrauterine death, preterm labor, and spontaneous abortion. There are case reports which mention that increased AFP can be seen in placenta accreta, increta, and percreta. Very low estriol. Low estriol is associated with adverse outcome. If it is less than 0.5 mom, then there are chances of oligoamnios, IUGR, IUD, and spontaneous abortion. Very low estriol, less than 0.2 mom, is associated with genetic disorders like placental sulfatase deficiency, Smith-Lemli-Opitz syndrome, and various metabolic disorders. Likewise, elevated inhibin A in the second trimester more than 2 moms is also associated with adverse outcome in the form of preeclampsia, hypertension, IUGR, and fetal loss. Basically, these analytes, if it is less than 0.5 moms or more than 2 moms and AFP more than 2.5 moms, is associated with adverse pregnancy outcome in the form of oligo, IUGR, preeclampsia, IUD, spontaneous abortion, anything. This is also an interesting table. This says that if there is only one isolated marker is increased, then there is odds of having preterm birth, low birth weight, preeclampsia, abortion is to the extent of 1 to 2-fold. If 3 or 4 markers are present, then the risk of spontaneous miscarriage is 23-fold, which is increased. So as the number of markers increases, the risk of abnormal adverse pregnancy outcome also increases, as was present in this case, as all the analytes were abnormal except the unconjugated estriol. So that is the case that this ended up in an intrauterine demise. From this case, I just want to give a message that whenever we are counseling for aneuploidy, the risk of mental retardation, we always have to discuss the other obstetric outcomes. If it turns out to be normal, then also the common screening, the BP monitoring, Doppler, the high protein intake, whatever we do for IUGR and for the preeclampsia, these things also needs to be discussed, and monitoring accordingly should be done in those cases. So ideally, we should look at the individual mom so as we can counsel the family of the other outcomes apart from aneuploidy. Thank you.
Thank you, Dr. Moni. Dr. Moni and Dr. Abhilasha very clearly actually made the things very clear for general practitioner gynecologist. Dr. Moni, a few queries I have in my mind. Can you come
Yes.
to your third case?
Yeah, wait.
Number one, they did not get a serum screening test in the first trimester, I think. Only
Which one, ma'am?
anti-skin.
First case?
Third, last case. And another query was
this case you're talking about. Yeah.
Only anti is done. Dual marker is not done, I
No,
think.
dual marker was not done. They went ahead with the quadruple
So they
marker.
straight away went for quadruple marker,
Yes.
and here the things were abnormal. So
Yes.
I had just one query. You said that amniocentesis was normal,
Yes, ma'am.
but she had done an IUD. So I just think that if IUD had not occurred, then with these markers only, we wouldn't have terminated the pregnancy.
No, ma'am. If for that matter, if level 2 scan was also normal and only abnormal analytes were present, so it just indicates that there is increased risk of these abnormalities, these adverse outcome in the form of preterm labor. It increases 3-fold, 4-fold, depending upon the table which we have discussed. It does not mean that the baby would have abnormal outcome in 100% of the cases. Also, another thing was because echogenic bowel was also present. So we wanted to rule out infection also, the congenital infection, because of the early onset IUGR and echogenic bowel. But the family was not affording enough to get all the tests done. So we asked the family that get your torch IgG, IgM levels done, so as we can somewhat correlate with it. But the family was not willing because of the financial constraint. And more so because reverse flow was present in this case. So there were very high chances that this pregnancy would not continue.
Yeah.
And also ecogen, as far as the infection goes, the risk of recurrence for the infection is low in the next pregnancy, is negligible in the next pregnancy. So anyways, our main concern was that we should be able to diagnose whatever abnormality is present in this pregnancy, and that should also not recur in the next pregnancy.
Oh, that is my only point, that amnio was not normal.
Normal,
But
yes,
I think there was some problem with the fetus, because that's why IUD has occurred, and
Yes,
so many other things, echogenic bowel and all the other things are also there. That is just my concern.
Yeah, and we had sent the placenta for histopathology also. The report is awaited.
And in the second case, have you what did you do, because it showed XO? So what was done for that?
In the amniocentesis, the mosaicism.
Yeah.
Basically, ma'am, we need to counsel the family. Finally, discretion is on the patient. We told the family that most of the time with low level of mosaicism, the outcome is good. There is normal stature with no other abnormalities present. But there are few case reports which say that with low, based on the level of mosaicism, we cannot differentiate whether the fetus would have a normal outcome or will have any stigmata of Turner syndrome. So basically,
Okay.
Yeah.
Can I just talk here?
Yeah.
Yes. I have had a lot of cases of mosaicism referred to us, when I was in AIMS. These are the cases where you need to do a cord blood sampling, especially if you want to know exactly, then we do a cord blood sampling, and that will really tell you the exact chromosomes, because mosaicism, you cannot take a decision. You might be aborting a normal baby.
Yeah, and what about karyotype, Dr.
And
karyotype is awaited, ma'am.
Okay.
So, and as far as the other patient, the one with the IUD, see, there are many other causes of intrauterine death that are just beyond chromosomal pattern, chromosomal abnormality. So there are so many other cases, and congenital infections, as Dr. Saroj said, Moni said, have to be ruled out. So you have to look for other stigma of infections.
Yes.
But still, this could be genetic. So further, monogenic disorders, if the placenta is normal. So all these things, a complete evaluation.
So there are lots of
along with
causes.
That,
not only that, after the death of the baby, you should do an autopsy. You should do an autopsy and see whether there is something which you have missed on an ultrasound.
Yes, ma'am, but the patient delivered somewhere in periphery. So basically, we have the DNA stored. If placental insufficiency is ruled out,
we are talking about future, pregnancies and basically the academic concerns.
And also, if the placental insufficiency is ruled out, we can go ahead with, because the DNA is stored with the lab, we can go ahead with the further testing if the family is willing.
Further testing is important not only for academic reasons, it is also important for the family
for
reasons.
The next pregnancy.
For the recurrence risk. So actually, we should highlight, that this is important for them only.
Yeah,
But
for the risk
also
of
Short time
these
to
days
refuse.
in cases of stillbirth, it is advisable to get an autopsy
Yeah,
done.
yeah, autopsy,
Yeah.
genetic testing, placental evaluation, all these
Many
are
people do not like an autopsy, so at least you
Mhm.
can do the placental biopsy, and then also you can do an MRI. There's a very important role of minimally invasive MRI for such cases. These are new things coming up, not new actually. I've been doing them for a long time, but not in practice much.
One
Yeah, and one
thing I-
external genetic, external photographs, they would also help us in, deciphering some common syndromes which would have led to this. So when the autopsy is refused, what I advise to them that go for an external close photographs of the face, the hands and the back, and also go for the placental histopathology and DNA storage, because it's quite common
Very
occurrence that
important.
the autopsy is refused. But also it's important that, when the who informs about the utility of autopsy. So it's important that the people who are doing the medical genetics practice or who are doing the fetal medicine practice, they should be, doing the consultation for the utility of the fetal autopsy in such cases. So generally what we would say that by doing the fetal autopsy and the genetic testing and the biopsy, we would be getting the diagnosis in about 70 to 80% of the cases. So once they get to understand that the utility is quite high, then many of them would agree. So I would ask all of you to use this figure that at least we can get the answers in about 70 to 80% of the cases, and people do understand. So it's important that, when we counsel them, it has to be, the utility should be, it's not just that go and get the autopsy done, but because for them, this is only research. But we have to, highlight the idea that this is not only for research, it is for your future counseling and recurrence risk. So that message has to go, because most of the time I realized that it was, people take it like, this is all for research, academic, so they are not opting for all these. So probably the acceptance for the autopsy is low when the counseling happens, at the, the bedside, when the patient goes for the mishap.
Yeah.
Ma'am,
Another
sorry to
thing I would
interrupt,
like to
ma'am.
add. Another thing I would like to add is that, get an X-ray done. And, it
Yes.
should be done in a very right position, not in a oblique manner or something. You should have a baby in the right position. These things can easily be done because
Yes.
we have picked up a lot of syndromes which are not associated with chromosomal abnormalities, and which can have an impact on the future childbearing, in the recurrence risk and counseling.
Yeah.
So we need to move to the next session now, ma'am. Sorry to
Okay.
interrupt.
We'll come up with a complete one-day workshop on the fetal medicine. It is really very, very needed.
Yeah,
Thank you so much.
You have to go into depth.
It's a fast growing.
Thank you so much, Dr. Aditya and Dr. Moni, and many inputs by Dr. Deepika Deka. So we are moving to the next session.
Thank you so much
One minute.
for your kind and patient listening. And I thank everybody, the organizers and the chairpersons, and Dr. Deepika especially for valuable. Thank you so much.
Now, LifeCell is proud to launch India's only first trimester pentamarker screening test with unmatched accuracy and advantages. The pentamarker screening employs the most advanced technology using 5 biological markers to give accurate result and low false positive rates. Pentamarker screening, unlike conventional first trimester biochemical screening, has 3 specific markers to detect T21 with marked up acuity. It benchmarks a 98% detection rate and false positive rate of 1.2% for trisomies. This gives it a considerable lead over the first trimester.
And now we can have the next session.
I will
Yes, ma'am.
introduce Dr. Pratima. Dr. Pratima is assistant professor in our department, and I have requested her to coordinate this 45 minutes program.
Welcome, Dr. Kiran. And we are going to have another very, very useful, wonderful workshop on the CTG, which is another thing which we do in a routine. Over to you, Dr. Kiran.
Yeah.
Rather, Pratima,
Start
to introduce Dr. Kiran.
थैंक यू सो मच मैम सुप्रभातम सुस्वागतम मैं हूं डॉक्टर प्रतिमा असिस्टेंट प्रोफेसर जीएसपी मेडिकल कॉलेज थैंक यू ऑर्गेनाइजिंग टीम फॉर गिविंग मी अपॉर्चुनिटी थैंक यू किरण पांडे मैम फॉर दिस लवली इंट्रोडक्शन सो नाउ वी आर गोइंग टू हेडिंग टुवर्ड्स अ वेरी इंपॉर्टेंट टॉपिक व्हिच इज इजी टू परफॉर्म बट डिफिकल्ट इन इंटरप्रिटेशन सो जस्ट वन श्लोका फॉर माय ऑनरेबल टीचर्स विद्युतं दक्षता शीलं शंकांति अनुशीलनम शिक्षकस्य गुणः सप्तचेतस्वं प्रसन्नता. आदर्श शिक्षक के इन सप्त गुणों से विभूषित हमारे आज के एक्सपर्ट और चेयरपर्सन को मेरा नमस्कार है। हमारी चेयरपर्सन डॉक्टर अलका मैम एंड डॉक्टर वंदना मैम को वी वेलकम यू मैम। और हमारे आज के स्पीकर्स हैं प्रोफेसर डॉक्टर किरण पांडे मैम, प्रोफेसर डॉक्टर नीना गुप्ता मैम, प्रोफेसर डॉक्टर शैली अग्रवाल मैम। नाउ आई वुड लाइक टू इनवाइट प्रोफेसर किरण पांडे मैम, प्लीज गिव अ ब्रीफ इंट्रोडक्शन अबाउट द CTG and its interpretation.
So let me speak for the introduction of the session. I would like to congratulate Dr. Ragini and all the conveners, Dr. Jyoti, Dr. Saroj, Dr. Promila, and Dr. Chandan for this wonderful CME Saving Mothers by Abhilasha. And this session actually is a very important session because CTG we are all using. In our time, CTG we never had. So we've learned over a period of time, and now we can't survive without it. So in this CTG workshop, we have talks by Dr. Neena Gupta, Dr. Shelly Agarwal, and we have a group discussion on interpretations of the various CTG tracings. So the first speaker, Dr. Neena, would speak on intrapartum fetal monitoring. So welcome, Dr. Neena, for this talk.
Thank you. Good morning, everyone. Today, we will deal with this very important topic, which is very important for all the obstetricians, that is intrapartum fetal monitoring. Why this topic is important? Next. Because it detects developing fetal hypoxia. And our goal is to prevent the subsequent acidemia and long-term irreversible neurological damages in newborn. Next, Sally. There are various advantages of intrapartum fetal monitoring. It is very reassuring for the patients. It decreases medico-legal concern. It reduces neonatal seizures also, but there are many disadvantages also, like fewer spontaneous vaginal delivery, more rate of cesarean section, more operative delivery, and uncomfortable for the woman, especially when she is on continuous electronic fetal monitoring. There are various methods to detect fetal hypoxia. Among them, intermittent auscultation and continuous electronic fetal monitoring are the main. Others are fetal scalp blood sampling, fetal scalp stimulation. But in this session, I will especially talk about the intermittent auscultation and continuous electronic fetal monitoring. Next. So, electronic fetal monitoring versus intermittent auscultation. When we compare, compared to auscultation, EFM result in higher operative vaginal delivery rates and increased rate of cesarean delivery also. There are no apparent difference in the perinatal death rate between the two groups as per NICE guideline. So the CTG is a continuous electronic record of fetal heart rate and uterine activity obtained by two transducers placed on the abdomen of the mother and having simultaneous graphic representation of fetal heart rate and uterine activity on paper. Purpose is to monitor fetal well-being and allow early detection of fetal distress and antenatal or intrapartum whenever it is developed. We have to detect it. But there are many criticisms towards CTG, like maternal heart rate artifact, abnormal fetal arrhythmia, pattern varying during sleep, drug effect, inter and intra observer variation, a number of technical pitfall, low validity, high incidence, and large positive findings, false positive findings. Then why discuss CTG? Because it is very, very useful in high-risk cases. And standardized evidence-based guidelines are being laid for correct use, interpretation, further decision-making, and record-keeping. What are the indications for use of continuous electronic fetal monitoring, especially in high risk for fetal hypoxia? The maternal indications are previous cesarean section, preeclampsia, PROM, multiple pregnancy, medical disorder, diabetes, renal, cardiac diseases, etc. APH, maternal hypoxia, fetal, in cases of IUGR, preterm, postterm, breech, oligohydramnios, and twin. And in case of intrapartum augmentation, whenever we are doing augmentation with oxytocin, induction with prostaglandin, there is meconium stain, amniotic fluid, or vaginal bleeding is there, or we are giving regional anesthesia. So according to ACOG and AAP guidelines, the intermittent auscultation and continuous EFM should be offered to both low-risk pregnancy and high-risk pregnancy. And in first stage of labor, it should be done every 15 minutes, and in second stage of labor, every 5 minutes. This A stands for the auscultation before, during, and after the contraction for 60 seconds, and B stands for includes evaluation of tracing every 15 minutes, and C is evaluation of tracing every 5 minutes. ACOG guidelines says that either continuous or intermittent monitoring is acceptable for low-risk uncomplicated pregnancy, and high-risk pregnancies should be monitored continuously in labor, while according to NICE guideline, do not perform CTG in low-risk women, offer intermittent auscultation only, offer continuous CTG for only all the high-risk cases, suspected chorioamnitis or previous LSCS, severe hypertension, oxytocin use, or significant meconium or fresh vaginal bleeding. A continuous EFM should be offered and recommended in pregnancy previously monitored with intermittent auscultation whenever there are evidences of auscultation of baseline fetal heart rate less than 110 or more than 160, or there is evidence on auscultation of any deceleration, or there is evidence of any intrapartum risk factor developed. So continuous EFM is a screening tool for hypoxia and does not replace the need for accurate clinical observation on which decision should be made in conjunction with the CTG according to FIGO guideline. So we can conclude that for the monitoring by EFM to be effective, the test must be performed correctly. Its result must then be interpreted satisfactorily. And finally, this interpretation must provoke an appropriate response. Thank you. And the main part of CTG will be dealt with by the Dr. Shelly Agrawal, and Dr. Kiran Pandey will ask many interesting questions. Thank you very much.
Thank you so much, Neena ma'am, for this nice talk. And now it's time to invite our another speaker. And with great pleasure, I would like to invite an excellent teacher who is a master in clearing all the doubts. Professor Dr. Shelly Agrawal ma'am. She is a professor in Obstetrics Department, GSVM Medical College, and Joint Secretary, Kanpur. Ma'am, please, the stage is all yours. Shelly ma'am.
Thank you so much, Dr. Pratima. And I would like to thank Dr. Kiran Pandey ma'am for giving me this opportunity. And my sincere greetings to my chairpersons. So I'm sharing my screen. So after this brief introduction about the fetal monitoring by Dr. Neena Gupta, I will further deal with this CTG. So we have known why we do CTG, what is the procedure of doing this. Then we learn how to read and what are the various features which are depicted in this CTG. And then after reading those features, how we make an interpretation, or then how we will manage the case. So there are two types of tracing in the CTG. One is for the fetal heart rate, as Neena ma'am has told, and another is for the uterine contractions. In the x-axis, we take the time, and in the y-axis, in the upper half, it is for the fetal heart rate. Each small box is for 10 beats per minute. And in the lower part, it is y-axis for the intensity of the uterine contraction. So how to read a CTG? We should always remember a mnemonic, Dr. C. Bravido, in which DR stands for the defined risk. It is a low risk or high risk. As she has told, CTG should be offered in the high risk cases. It can be a previous cesarean scar, it can be PET, it can be diabetes, it can be IUGR. After defining the risk, then comes for the C, that is the contraction. As we all know, adequate uterine contractions are frequent in 3 contractions in 10 minutes. Each duration lasting for 45 seconds, and intensity either in the millimeter of mercury or in the Montevideo unit. But there are two terms. One is tachysystole, in which there are more than 5 contractions in 10 minutes. And other term is hyperstimulation, in which there is a prolonged contraction for over the 2 minutes time. Then comes the Bravido part, that is the main part, in which BRS stands for the basal fetal heart rate. What is the baseline rate? Then V stands for the variability, A for the acceleration, D for the deceleration, and in last, after understanding all these 4 features, what is the overall risk assessment for that fetus. So we'll learn one by one. So the baseline fetal heart. We all know the baseline fetal heart is normal between the 110 to 160 beats per minute. It is a part of the tracing which we got during the time of relaxation of the uterus. If it is more than 160 beats per minute for more than 10 minutes, it is labeled as a tachycardia. If it is less than 110 beats per minute for 10 minutes, then we term it as a bradycardia. So we should know what are the causes which can cause tachycardia so we can take the appropriate action then and now. So tachycardia, it's more common when the maternal pulse is high in case of maternal pyrexia, or she is having choriamnitis, or it can indicate fetal hypoxia, tachyarrhythmias, mother is having some infection or fetus is having some infection, maternal hyperthyroidism, and some drugs like salbutamol and some parasympathetic blockers. So we should take a history of a mother also. Is she under influence of any drug? The causes of fetal bradycardia are prolonged cord compression, maternal hypothermia, cord prolapse, abruptio placentae, uterine rupture, rapid fetal descent, postterm babies, and congenital heart malformations. So these are the few tracings you can see. This is for the normal, it is between the 120 to 160. So we have a normal heart rate of around 140 beats per minute, as you can see in this upper graph. Then this is a chart showing heart rate, which is initially it was around 80 beats per minute. Then later on in the later part, it has further declined to 60 beats per minute. And this slide is showing fetal heart rate, which is around 180 beats per minute. So we can calculate the fetal heart rate by seeing the graph. Then second variable is the variability. We all know there's a variability in the fetal heart rate. It indicates the fetus is having an intact neurological status. They are the chemoreceptors situated in the carotid arteries of the fetus, which detects the hypoxia, which detects the what is the percentage SpO2 of the blood. They then send signal to the heart to accordingly decrease or increase the heart rate. So when it is the reassuring variability is between 5 to 25 beats per minute. In some cases, when variability is reduced, that is minimal variability, when it is below 5 beats per minute. This is the ominous sign. If it is absent, it is a straight line. We all see in the movie when they are showing a straight line, it is very bad. So it should not be there. And sometimes we can have a hyper variability that is more than 25 beats per minute. So the causes of reduced variability are usually the fetal sleep cycle. Commonest is for 20 to 30 minutes, but maximum is for 90 minutes. Then if the fetus is itself having hypoxia, he is not responding to the changes in the oxygen level, acidosis. Then some preterm babies, if the gestation is less than 30 weeks, they also have the decreased variability. If the mother is under influence of parasympathetic blockade or maternal sedation, like opioids and hypnotics, also can cause this type of picture. So these are the few tracings in which you can very well see the variability. In this, it is the absent variability, a straight line in the fetal heart. Then it is in this, and then there are minimal. It is less than 5. There's small oscillation in the fetal heart. Then this is the good one for 6 to 25, which is normal. And sometimes we can have a hypervariability in the form of more than 25 beats per minute. Now coming to the accelerations. They are the transient increase in the fetal heart rate for more than 15 beats per minute and lasting for more than 15 seconds. If the fetus tracing is showing fetal heart rate acceleration, it is usually a good outcome, means the baby is very well. It is not hypoxic, it is responding to the stimulation. So previously we used to say if we are having 2 or more acceleration, 20 minutes is a reactive trace. In preterm babies, the definition of acceleration is increase in 10 beats per minute and lasting for 10 seconds is considered as acceleration. But the very important point is how if we are not having any acceleration in the tracing during the intrapartum CTG, it is of unknown significance and it does not indicate any hypoxia. So as soon as we are having a normal fetal heart rate, base heart rate, we are having a variability, we are not having any deceleration, we are fine with it. Now coming to the most important, that is the decelerations. By definition, these are transient slowing of the fetal heart below the baseline for more than 15 beats per minute and lasting for 15 seconds or more. They are further categorized into the early, variable, late, and prolonged. So, coming to the first one, that is the early deceleration. When there's a gradual fall of fetal heart and return to normal in parallel with the uterine contractions. We all know when uterus is contraction, there is a compression of the vessels. So slightly there is the decreased blood flow to the baby. In response to that, the baby is showing a decrease in the fetal heart. It is caused by usually by the head compression in the late stage of labor. It is synchronous with the contraction. So it is a mirror image type of. You can see there the contraction, and with the start of contraction, fetal heart start to go down. And with the peak of the contraction, there is a nadir of the fetal heart. And then as soon as the contraction goes off, fetal heart usually regains to normal baseline. So this is the early deceleration. Now coming to the late decelerations, this is very common, in which the deceleration commences after the onset of contraction and ends after the contraction has passed. The onset, nadir, and recovery of the deceleration occurs after the beginning, peak, and ending of the contraction respectively. So you can see there's a contraction, and there's, after the contraction has begun, after some time, the fetal heart will go down, and its nadir of the fetal heart and the contraction peak does not coincide with each other. If along with the deceleration, there is reduced baseline variability, it increases the chances of fetal acidosis. The cause is usually uteroplacental insufficiency, and we get these type of pictures in the chronic hypoxic babies or in the baby which are having acidosis or IUGR babies. Then the variable deceleration. These variable decelerations are intermittent periodic slowing of the fetal heart with a rapid onset to recovery and isolations. They may or may not be associated with the contractions. If we see, this relationship with the contractions, there is no relationship with the contraction. They can come before contraction, after contraction. There is variable time to reach to the normal, but they are basically due to the umbilical cord compression. They can be relieved by changing the position of the mother. And one thing very is important, that is shouldering. Acceleration and deceleration, acceleration before and after the deceleration. So when we are having a shouldering effect, we are happy. Baby is adjusting with its hypoxia, because we know the umbilical vein is occluded first, which causes the acceleration. Then there is the occlusion of the umbilical artery, which causes the deceleration. And after that, the baby is responding to that by increasing the fetal heart. So you can see the baby is adapting itself to that environment. But when there is absence of this shouldering, there is suddenly decrease in the fetal heart without this shouldering effect, then it can be suggest the baby is hypoxic. He or she is not responding to that hypoxia. Then the prolonged deceleration. Any deceleration that lasts for more than 2 minutes but less than 10 minutes. It is termed as a prolonged deceleration, and it is indicative of acute fetal hypoxia. According to NICE guidelines, they take it as for more than 3 minutes. Then one important thing is sinusoidal decelerations. There's a smooth sine wave type of pattern we see in the heart rate. There's a periodical 3 to 5 cycles per minute. The amplitude is between 5 to 15 minutes, but there is you can see a beautiful dancing like sine wave pattern. So there is no acceleration, no deceleration in response to any stimulus. This indicates the baby is having severe anemia. It can be due to RH isomerization, it can be due to fetal maternal hemorrhage, or in case of twin anemia polycythemia syndrome, and sometimes in severe fetal hypoxia. So this is also a very bad feature. Now coming to when we learn what are the features, then how we classify our CTG tracing. We have got two classifications, one is by the FIGO and one is by the NICE. We usually follow the NICE guideline. So according to NICE 2017, which is the latest, there are 3 types of traces: normal, suspicious, or pathological. In normal, if all the findings are normal, then we say it is a low risk of fetal acidosis. When all our 4 features fall into reassuring category. Sorry, this was the slide first slide. So according to the 4 features, baseline heart rate, variability, acceleration, deceleration, we have categorized our CTG testing into reassuring, non-reassuring and abnormal. In the reassuring, when the fetal heart is between 110 to 160, variability is between 5 to 25, acceleration present or absent, not significant, but there should be no deceleration. If we are getting these features, then it is reassuring that baby is not hypoxic at that time. Then there is non-reassuring. If the fetal heart rate between 100 to 109 or it is between 161 to 180. Variability is less than 5 beats per minute for more than 30 to 50 minutes, or it is more than 25 for up to 30 minutes. According to deceleration, if they are typical variable deceleration without any feature of W or that shape, with over 50% contractions for over 90 minutes, or there is single prolonged deceleration up to 3 minutes. It is in the non-reassuring category. Then there is abnormal. If the fetal heart is less than 100 beats per minute or over 180 beats per minute, or there is sinusoidal pattern for more than 10 minutes. Variability, if it decreases for 50 minutes, it is increased for 30 minutes, or sinusoidal for 30 minutes. It is taken as the abnormal. Then deceleration, there are atypical variable decelerations with over 50% contraction for over 30 minutes, or there are late deceleration for over 30 minutes, or there is a single prolonged deceleration of more than 3 minutes. These are in the abnormal category. So if all the features are into reassuring category, we term it as a normal CTG, low risk of fetal acidosis. But if there are one feature in non-reassuring feature, either the fetal heart, baseline heart rate, or the variability, then it is in the suspicious category. It suggests the baby is at a medium risk of fetal acidosis. And then if there are 2 or more non-reassuring features, or there is 1 or more abnormal feature, it will be termed as a pathological. It suggests it is a high risk of fetal acidosis and we need a urgent intervention. So if there is bradycardia or single prolonged deceleration with baseline below 100 beats per minute lasting for 3 minutes or more, it indicates for the urgent intervention. So what we do, just learn acronym. This is given by the RCOG. Look for the mothers. M stands for the meconium. O, whether she is receiving oxytocin, what is the dose of that oxytocin, whether she is having temperature or some sign of infection, if it is hyperstimulation or hemorrhage. E stands for epidural, R for the rate of progress, what to rule out any CPD, and S stands for the previous scar. Then what action should be taken? It's the soil, learn soil. S is for the stop the oxytocin, give patient high flow oxygen, give IV fluid to correct the dehydration or hypotension, and shift the patient in left atrial position to increase the blood flow to the baby. And also there is whenever we are having an abnormal CTG, there is a rule of 3, 6, 9, 12. In initial 3 minutes, you just call for help, call your senior and think the plan of the delivery. If it itself persists, you perform the soil, that is stop oxytocin, give oxygen, IV fluids, and shift the patient to OT. If it persists, the changes are still there, then in 6 to 9 minutes, if she is in OT, the head is low, you can perform the instrumental delivery or you can go for the cesarean section. So this was the a brief about the CTG. Now we will discuss the cases with our findings so that you can answer it clearly.
Thank you so much, Shali ma'am. It was an elaborate talk. I hope all the delegates and the students are benefited. Now it's time to invite our next very dedicated teacher par excellence with a vast experience of more than 35 years and being awarded with Best Teacher Award, Professor Dr. Kiran Pandey ma'am. She is ICSG Fellow, Head of Department and Professor Obstetrics Gynae Department, GSPM Medical College, President of Kanpur Menopause Society.
Thank you, Pratima, for a very, very kind words. But because the time is very, very short, we will shift immediately to the cases. And I hope my PGs have joined. And it was the excellent talk by Dr. Shelley and Dr. Neena. And that has made my job very easy actually. And basically this knowledge about the how to read CTG and what are the objectives, why, when to do which one, and why we are doing this was all very important to understand what we are going to do. So at the outset, I would like to thank the organizers, conveners, chairpersons, and especially Dr. Ragini Verma for having this trust for this very important topic to be discussed, because it's important for every obstetrician. It's a responsibility of every obstetrician to deliver a vigorous and neurologically intact fetus. And there comes the importance of intrapartum fetal monitoring. And, because specifically in those cases where the fetal circulation is compromised because of the uteroplacental insufficiency or cord compression or oligo, and which we daily encounter. So it apparently it becomes that even sometimes normal fetus in the antenatal period may develop distress. So that's why the importance comes. And so we have discussed this, and now coming to the first case. Yeah. So this is a case, like before that I will introduce, we have 3 PGs, Dr. Gunjan is here, Dr. Sudha is here, and Dr. Monica also should have been there. All 3 are there. So we'll take one by one.
Good morning.
Yeah, so and I will tell all the delegates also that we have kept these tracings no other purpose, just to read the tracing and take the decision. No other concern has been taken into this account. So case 1 is a 30-year-old female at 37 weeks of gestation is admitted in a spontaneous labor. She's fully dilated. On examination, the head is 0/5 palpable per abdomen in left occipito-posterior position with minimal caput and no molding. She has made good progress from 3 centimeter to full dilatation in 6 hours as expected. She has been pushing for 1 hour. And now let's start with Dr. Gunjan. You are asked to assess the CTG. I'll show you on the full screen. Now you can see, you read it and then we will discuss it. Have you seen it? Hello?
Yes, ma'am.
Yeah, so let's see.
Yes, ma'am.
Can you study, can you show the important point? Tell me.
Yes, ma'am. Ma'am, as the respected ma'am said, according to Dr. C. Brevado, mnemonic, baseline in the CTG is around 150 beats per minute, as seen in between the contractions. The baseline is around 150 beats per minute. Yes. Then contractions, next we come for contractions. A contraction in 10 minutes are 4 to 5 as seen in the below tracing. These are of moderate intensities and lasting from 40 to 45 seconds. Then next come is baseline variability. Baseline variability is 15 to 20 beats per minute in this tracing, as seen between as seen in between the contractions, the peak and the trough of the fetal heart rate. In this tracing, it is 15 to 20 beats per minute. Then no accelerations are in this tracing.
Yeah, so right, baseline 150. Yeah. Anything else, Dr. Gunjan?
Ma'am, decelerations in this tracing.
Yeah.
Ma'am, for deceleration, as we see in this tracing, these are variable deceleration, as each deceleration are not corresponding to any contractions, and these are variable or in variable shape, and with concerning features seen here, as there is one prolonged, there is one W-shaped deceleration, there is prolonged recovery of deceleration for more than 60 seconds. So the concerning non-reshoring feature here is variable deceleration with concerning features, which are more than 50% of contractions for less than 30 minutes, as the tracing shown is less than 30 minutes.
So very rightly, you have pointed out that about the decelerations, variability, baseline, and contractions. Finally, the variable decelerations with concerning feature, which are more than 50% of contractions, as Dr. Shelley in our lecture told you, in less than 30 minutes. So that becomes a non-reassuring feature. So overall impression in Bravado, according to C. Bravado, is one non-reassuring feature, and that means it is a case of a suspicious category. Now, Dr. Gunjan, what will you like to do into it? Just concerning with the CTG we are talking, no other details.
Yes, ma'am. Ma'am, as the patient, according to question, as the patient is fully dilated and she is in labor, first I would like to exclude the acute events like cord prolapse or suspected uterine rupture. Then we will do the maternal, we will correct the maternal evaluations, like we will correct the hypertension. If uterine hyperstimulation is there, we will correct it. Then we will perform the full meconium stain LycoRed is there, or whether mother is having temperature or any sign of infection, or oxytocin, we will see for oxytocin drip whether it is causing hyperstimulation or not. Then if since patient is in labor, we will go for expediting the birth by either assisted vaginal delivery or by cesarean section.
Yeah, so basically the patient is already fully dilated. She has been pushing for 1 hour. Right, you have done the full maternal evaluation. You have understood that there is a suspicious variety. So in this case, you should do expedite the delivery by either you can use assisted vaginal delivery by any means, or you have to, if you have a otherwise, you can go for a cesarean section. So that was the basic thing. One suspicious case, how you have to go. We quickly move to the second case, and now this case is G3P1L1A1, 28 years old, first one normal delivery, 32 weeks, and she has a PPROM, premature rupture of membranes, preterm premature rupture of membranes. She also has fever, foul smelling vaginal discharge. Her temperature is 101 degree. So, Dr. Sudha, can you see the slide? Can you see the slide? So will you see this CTG and please elaborate the important points according to the, as we have discussed?
Yes, ma'am. In this, first we determine the risk. In this patient, there's a risk of PPROM. The patient is preterm and patient is having fever. And the baseline is showing 200 beats per minute. And the second, ma'am, we come on contractions. The contractions in the 3 to 4 contractions are there, ma'am, but there is no acceleration, and the variability is 5 to 10 beats per minute, and there is a decelerations also. One variable deceleration is present, ma'am. So it is come in pathological category.
Okay.
So the baseline heart rate is greater than 200, and deceleration is also there.
Yes, so one way deceleration is there, and this one is not actually, because it is not completing the criteria. And what about this? What is this tracing, Dr. Sudha?
Ma'am, this is showing maternal pulse rate.
Maternal. So pulse or basically pulsations, yes, they are maternal tracings. One should be very clear about it, that you have to, sometimes you do get maternal tracings and don't get confused with it. Now here you have shown one, yes. So we have the baseline, that is the most important thing, abnormal feature. By that time, I think all the PGs who have been must be attending must be clear about it. Contractions are okay, moderate intensity, 3 to 4, variability. So it's a pathological variety because one abnormal feature is there. Now, how will you proceed, Dr. Sudha, into this case?
Ma'am, in this patient, first we will perform the full maternal evaluation. In this patient, she is having fever. Then first we will start antipyretics. And then we can give intrapartum GBS prophylaxis. We can give, and we can also correct hypotension, and we will put the patient on continuous CTG monitoring.
Yeah.
And
So can you tell me what, I mean, though Dr. Neena has already told, but still, why would you like to have continuous CTG into it, not intermittent?
Ma'am, because it is in the having a high risk. It is a high risk movement, and this chorioamniotis. Ma'am, the patient might go in chorioamniotis.
She's already going to the chorioamnitis. I mean, you have
yes,
not done the investigations. Otherwise, the temperature is 101, and she's having a fever, foul-smelling discharge. So she has established infection. So in this case, it is a high-risk case, very rightly told by, and you need continuous electronic fetal monitoring. Now you have given antipyretic, you have given the GBS prophylaxis. What will you do next?
Ma'am, if this continuous CTG monitoring is still pathological, we can go for delivery.
Still pathological means what? What time? How much time?
Still it is, ma'am. Still it is going for. Still it is showing variable dislocations and abnormal heart rate.
But basically, maybe this temperature rise is the cause of the 200. So if the temperature comes down, the heart rate may also come down. May not? Yes or not?
Yes, ma'am.
The baseline feed, tachycardia may subside. So that is the reason. Then you have to reevaluate the CTG and take a decision what you will do, right? So what next you will do?
Ma'am, we will reevaluate the CTG, and if it is pathological, we can go for delivery. We can go for induction of labor, or we can go for cesarean section.
Would you like to go for normal prefer vaginal delivery in this case, or cesarean section?
We can go for normal vaginal delivery, ma'am.
Which one? Basically, she is a case of chorioamnitis, isn't this? So this you infect, if possible, if the other features do help you, patient is having uterine contraction. So she's in labor or not?
Yes,
Dr. Sudha.
We will perform normal vaginal delivery, because as infection is present.
Sudha, you will not perform, you will help into the normal vaginal, you will prefer for vaginal delivery because she is having contraction. So she is in labor, and if supposing your abnormal feature goes and this continuous CTG and the temperature is controlled, the baseline fetal heart rate comes down to the normal, and there were no other features. So unless and until something else appears, you can wait and may allow for a vaginal delivery so that the infection doesn't become a systemic or overall. If not, she's a case of 32 weeks PPRM, then after you think this antibiotic dose has gone and the effect has come, you can take her even sometimes for cesarean section if very much required only then. Dr. Shelley, will you like to take this case, third case?
Yes, ma'am. Yes, ma'am. So we have Dr. Monica with us. Dr. Monica, are you here?
Okay. Good morning, ma'am.
This is the case of a primary gravida. She is 31 years and she has 39 weeks of pregnancy. She is having a history of gestational diabetes mellitus. It is well controlled on MNT, exercise, and she is not in labor. And she is not on any oral hypoglycemic or insulin. She has come with the complaint of decreased fetal movement in the OPD itself. And then we have advised her for a NST, and this is the tracing. So can you see the tracing?
Yes, ma'am.
Okay, so how will you interpret?
Ma'am, in this tracing, first of all, determine. Ma'am, in this tracing, patient is GDM, gestational mellitus, with decreased movements, and the baseline heart rate is 30.
डॉक्टर मोनिका, आप लोग अपना वीडियो बंद कर दो so that the audio will come.
कोई डिवाइस चल रही है मोबाइल वगैरह, उसको बंद कर दो बेटा.
हाँ, और वीडियो बंद कर दो, ऑडियो से we will work because otherwise the network issue will come.
हाँ, मोनिका.
जी मैम, there is no contractions, exhalations are nil, and reality is less than 5 beats per.
Although the basal fetal heart is between the normal range, but we can see the variability. Monica,
variability is less than
less than
beats
5
per minute. And ma'am, yes, ma'am. Decelerations are nil, ma'am. Overall, ma'am, this non-reassuring feature is present. One suspicious category, decelerations nil है इसमें, variability हम less than 5 है.
ट्रेसिंग का टाइम भी आप देख रहे हो, ट्रेसिंग ऑफ ओनली 20 मिनट्स की ट्रेसिंग आपको जो दिख रही है अभी ना?
जी मैम. There's no exaggeration.
What can be the causes of this decreased variability? क्यों है decreased variability?
Most common cause is fetal sleep. मैम 20-30 minutes fetal sleep में मैम ऐसा feature मिल सकते हैं. और in this case patient is high risk GDM की patient है मैम. First of all, we perform maternal evaluation and then we start the conservative treatment. Like if the patient is dehydrated, we will correct dehydration and fetal stimulation is done. Ma'am, if there is any history of maternal intake of opioids, we will take history for that. And still the patient is not in labor, we will tell the patient for USG color Doppler.
You can do it yourself or you can advise, because we have to evaluate the fetus in toto itself. And with ultrasound, color Doppler should be, and the complete biophysical profile. Okay.
And I think one thing very important, one should remember this: in GDM cases, the sudden deaths are reported. So you should give a lot of importance to the patient's complaint. That is the most important thing. Yes. So what will you do? You have done the colored, Dr. Shelley, complete?
Yes, ma'am. And then, as you can say, कि fetal sleep cycle होता है, so we can review the CTG after
90 minutes. We will review, and still
if it is still the variability is not there, then you should raise the alarm. Okay, you should admit the patient as this was OPD patient, and then further she should be taken. Anything else, ma'am? Kiran ma'am?
I think so. This is okay. So let's go quickly to the 4th, 5th case so that we further, if any inputs we can take from the chairpersons. So the case 4 is, Dr. Gunjan, you can take it again. She is a case of pre-eclampsia with severe features. She is 34 weeks gestation. She also has an intrauterine growth restriction. No color Doppler findings are normal, and she's undergoing induction of labor. I think probably because of her features, complaints. So assess her CTG. Which is Dr. Gunjan.
Yes, ma'am. Ma'am, according to Dr. C. Brevado, mnemonic, first we determine the risk factors in this category. In this case, risk factors are in term is there, IUGR is there, preeclampsia with severe features is there, and patient is on undergoing induction of labor. As these all are risk factors. Baseline in this CTG is nearly 140 beats per minute, with contractions seen in below are 1 in 10 minutes, which are moderate intensity, and then no accelerations are seen in this CTG. Variability is less in this CTG, ma'am. Variability is less than 5. Since the CTG is for 20 nearly for 20 minutes only. So one non-reassuring feature in this CTG is variations of variability of less than 5 beats per minute for less than 50 minutes. Then deceleration seen in this CTG are late deceleration, as deceleration starts after the peak of uterine contraction, and the nadir of deceleration is after the contraction over. Then late deceleration, during decelerations, there are no variability seen in this tracing. This is the concerning feature. So, ma'am, this is the abnormal feature in the CTG, that late decelerations with absent variability with risk factors are present. Overall impression is pathological category.
Yeah. So what will you do? How will you proceed in this case? Yes, very rightly. Late deceleration has been very clearly seen, and the variability during the deceleration is almost less than 5 beats per minute. So how will you proceed? She is a case of preeclampsia with severe features on induction.
Ma'am, as the patient is on induction, continuous CTG monitoring is done in this patient. First, as the category is pathological, first I would like to exclude all the acute events like cord prolapse, suspected placental abruption as the case is preeclampsia with severe features.
Yes,
Then
placental
if
abruption
maternal
is
hypertension is if maternal hypertension is dehydration is present, we will correct the hypertension. Then we will start the conservative measures like we will put the patient in left lateral position, start oxygen and IV fluids. And since the patient is on continuous CTG monitoring, after 15 minutes, we will review the CTG. We can consider fetal blood sampling, not done nowadays, not recommended nowadays, as it is an investigator. If reviewing the CTG, if CTG is still abnormal, we will consider extending the birth.
Yes, initially they were saying that in these cases, you can do further confirmation can be done by the fetal blood scalp sampling if the dilatation is more than 4 centimeter. But now most of, it is not almost recommended by most of the guidelines. I don't know about what others are doing, but we are not doing at our center the fetal blood sampling. So we have to do with the other measures only. So you expedite the birth in this case, and
in case if the membranes are still intact, you can do the ARM just to see the color of meconium, and it will further expedite your process of labor also.
Absolutely, absolutely correct input. If the membranes are intact, okay, that will accelerate also, and that you can see the color of the LycoRed also. Correct. And even if there is a suspected abruption, then you can have the blood stained LycoRed also. So all these things can be done. So we move to 5th case, 23-year-old.
Ma'am, I think we are overshooting the time. Can we go further? I will take the permission from the organizers.
Can we discuss 1 or 2 cases more quickly, or stop it? Whatever the organizers say.
And we can take 5 minutes.
No.
Okay. We'll do just
5 minutes, Dr. Kiran. Excellent discussion, but please wind up.
Right, Dr. Ragini with that. And I will tell my residents to cut short to the main point only. The rest of the things can be in the treatment management. So this is a case, 23-year-old primary gravida at 41 weeks, 5 days, undergoing induction of labor, receiving intravenous oxytocin. She complains that her contractions are very painful and seem to be continuous. Now, this is the tracing. Dr. Sudha, will you just quickly describe it? Yeah.
Ma'am, in this, first of all, the risk is post-dated, and the baseline heart rate is 150, and the contractions are sustained contractions are present. This is hyperstimulation, but there is no acceleration, and variability is 5 beats per minute, and deceleration is there is one prolonged deceleration is present, ma'am. And
yes.
2 variable decelerations are also present.
Yes.
So, ma'am, this comes into the pathological category.
What can be the, the cause of this hyperstimulation?
Ma'am, as the patient is in, she was receiving intravenous oxytocin. Then, due to this, it can be in the hyperstimulation. So first, we will stop the oxytocin infusion, and the IV fluids ringer lactate can be started, and should be in the left lateral position, and the oxygen inhalation should be given. And ma'am, if there has been any event like cord prolapse, it has to be and we can give tocolytics also, like terbutaline or magnesium sulfate or nifedipine, and we will deliver the patient. We will make the preparation for delivery.
Yes, although many a times many guidelines say uterine hyperstimulation, word is they don't use now, but still in practical that gives us a right impression. So in this case, probably the oxytocin infusion was the cause of uterine hyperstimulation, and it has to be immediately stopped and further management has to be done. Dr. Shelley, please take quickly this last case.
Monica, she is 40 years old, gravid 2 para 1+0. She is 41 weeks of gestation and she was on oxytocin drip. She is fully dilated. Head is only 1/5 palpable per abdomen. It is occipito anterior position. Caput is ++ and molding is 2+. She has been pushing for 1 hour. The woman has previous LSCS for fetal distress. Now she is saying the pain is there, pain is not there, and the LycoRed is blood stained. And you have been called to assess this CTG finding. Quickly summarize the important points.
Ma'am, first of all, we will determine the risk. The patient is previous LSCS, and in this CTG, the finding is baseline heart rate is 160. There is no acceleration, ma'am, and there is prolonged deceleration is present, which is lasting for more than 3.5 minutes. This is an abnormal feature, and the patient is in fully dilated caput +2 molding is present, and this LycoRed blood stained LycoRed is present. So it is a case of uterine rupture. But FHS is present, we will shift the patient to the OT for immediate cesarean section.
Yes, that's the important thing. If possible, take it as early as possible to the cesarean section because fetal heart is present yet. We may not miss it. Anything else, Dr. Shelley, you would like to add?
No, ma'am. No, ma'am.
So urgent intervention has been done. So finally, to summarize, I would like to say we have tried to discuss the important how to read the CTG and the interesting cases, because intrapartum fetal monitoring, the message which I would like to give in the end should be judiciously used along with proper interpretation. That is the most important, so that both the sides are, because it has two prongs, unjustified and unnecessary interventions can be avoided. But simultaneously, it is equally important that CTG picks up the cases of fetal distress timely to improve the neonatal outcome. So that one has to use a very balanced approach. Do not jump immediately on one finding. Try to solve it if possible by do the mother's mnemonic and do the soil, and if after continue monitoring and see what has to be done. Just a word about this, the structured the intermittent auscultation in low risk cases, that also is a very, very useful phenomena which we are doing daily. So residents should not become panicked if sometime the CTG is not working. Yes, but in cases of the high risk, continuous CTG is better. And these days, the newer methods which have come, where even the patient can be mobile even after doing the continuous CTG, that helps a lot into giving the right decision and the right outcome and a healthy infant to the mother.
I think, thank you so much, Dr. Kiran. And very nice session, very informative and educative for these PGU students also. So I just want to share 3 points that one is that to prevent and to save us from medical legal point of view, it is very important to save us from the future litigations, that how we have delivered that previous child or previous problems, and decrease the chances of the cesarean as well as the increased chances of the cesarean. So it is a double-edged. Sometimes you go just 2 beats eye or आप cesarean पे चले जाते हो. Sometimes it happens that the baby becomes really compromised and hypoxic. So it is a double-edged weapon. As we are going to prevent the maternal morbidity by giving the misoprostol and teaching the Anganwadi people for the Indian scenario, so CTG has to go a very long way. It needs really good teaching. I will tell you in the private practice that CTG tracings चले जा रही हैं और उसको read करना नहीं आ रहा और consultant घर पे बैठा हुआ है. So that is another point, that how to use it judiciously. I just want to share one personal point here, that I delivered my first baby in year 84 with internal electrode, and that is the thing which has to be in India, and which is very useful when the cervix is dilated for 3 centimeters. Put the electrode very nicely, put it in the CTG, and that is the internal monitoring to reduce the hypoxia. So thank you once again, Dr. Kiran and Dr. Ragini. very important topic. The CTG teaching has to be very important for the, I think, all the practicing doctors also. Thank you.
Thank you so much for your valuable inputs, ma'am.
Excellent, Dr. Kiran. Excellent. What actually I wanted, you have delivered.
Thank you. Thank you very much, right, Dr.
Your
Ragini? That's what
presents
I
are also
presumed.
very good presentation, and Dr. Sally and Dr. Neena.
Yes, thank you. Thank you. So once again, thanks for giving me this opportunity, actually.
So this is a short break for these are our sponsors. We are thanking them. And then with a very powerful quote, nothing is permanent. Don't stress yourself too much, because no matter how bad the situation is, it will change. From the Lord Buddha. We would like to welcome Dr. Saroj ma'am to kindly start for the oration.
Yes, our next very important session is on oration by none other than our own Dr. Manju Puri. And for this session, I would like to invite Dr. Vibha Dua as a chairperson. Dr. Vibha is Vice President of Haryana Obstetrics and Gynae Society. She is a senior consultant, Dua Hospital, Sonipat. Welcome, Dr. Vibha. And our other chairperson is Dr. Kiran Arora. She is experienced gynecologist having more than 30 years of experience. She is director of Sukhmani Hospital, Gurgaon, and has special interest in high-risk pregnancy. She has interest in infertility management also. Welcome, Dr. Kiran, and our two chairpersons.
Thank you. Thank you so much, Dr. Saroj, for the nice introduction. I welcome Dr. Manju Puri to this beautiful session of our oration. And I know Dr. Manju Puri since my student life. She is presently Director Professor and Head of the Department of Obs Gynae, Lady Hardinge Medical College, New Delhi. She is presently Chairperson of Safe Motherhood Committee of AOGD. She has been awarded various prestigious awards. She has written many papers are in her name and 150 publications and many citations. She has written important books and edited many books also, like Clinical Methods in Practical Guide to Clinical Methods in Obs and Gynae, High Risk Pregnancy and its Management. And I now request Dr. Ragini to present a plaque to Dr. Manju Puri.
First, Madam will give the oration.
Okay.
We invite
After that, okay. We invite you, Dr. Manju Puri, for this very important topic, antimicrobial resistance. Please welcome.
Thank you, Dr. Vibha, for the introduction. And I have my oration recorded. Thank you, Dr. Ragini, for inviting me. So I think we can play the video, please.
Yes.
Good morning to the chairpersons and dear delegates. At the outset, I would like to thank Dr. Ragini Agrawal, President, Haryana Association of Obstetricians and Gynecologists, for giving me this honor to deliver this oration. in this very important conference, Saving the Mothers. I bring you greetings from Lady Hardinge Medical College. And the topic which I have chosen for the oration is antimicrobial resistance, hype or fact. For those who have experienced the anxiety of an infection that is drug resistant firsthand, there is a little that is needed to prove the existence and the importance of tackling antimicrobial resistance. For majority of the people around the globe, the threat of drug resistance is either not known or seem a distant and abstract risk. This includes obstetricians as well. The rising antibiotic resistance will have alarming secondary effects on the safety of childbirth, including cesarean section. This is more relevant in the scenario today when the rates of cesarean section are skyrocketing. If antimicrobial resistance continues, much of the progress we have made in reducing maternal and infant mortality in the last century will be at a risk of being undermined. Hence, we need to wake up before it is too late. It was in 1928 that Alexander Fleming, a Scottish physician, a pharmacologist, and a biochemist, who discovered penicillin. And it was after him that Robert Florey and Sir Ernest Chain, both of them isolated penicillin from the mold cultures for use in human beings. And it was in 1945 that they were bestowed a Nobel Prize for the discovery of penicillin. And in his speech, while receiving the Nobel Prize, Sir Alexander Fleming did refer to antimicrobial resistance in case the antibiotics are not used responsibly. It is 2022, almost less than 100 years since the discovery of penicillin. We are talking about antimicrobial resistance. Antimicrobial resistance is a resistance of a microorganism to an antimicrobial agent that was originally effective for treatment of infections caused by the same microorganism. But now, after the resistance develops, the microorganism does not respond to the same antibiotic. WHO in 2001 declared antimicrobial resistance a global public health problem. And it was in 2017 in our national health policy that AMR was flagged as a key issue. Now, looking at the magnitude of the problem, deaths attributable to antimicrobial resistance every year as compared to other major causes of deaths are as shown in this picture. We see that about 7 lakh deaths annually would take place because of antimicrobial resistance globally. This is more than double the number of maternal deaths which occur every year globally. This is to tell you about the magnitude of the problem of antimicrobial resistance. And it is said that if we do not start using antibiotics responsibly, by 2050, we will have 10 million people dying because of antimicrobial resistance every year. And if we look at this 10 million people dying every year, there would be one person which could die every 3 seconds because of antimicrobial resistance. Majority of the deaths will occur in Africa and Asia. So that means we are going to be affected most. And there would be about 4 million deaths per annum in each of these regions. So we are here at Asia, where we are expected to have about more than almost 5 million deaths because of AMR every year. So it is important to bridge the gap between the global perceptions of AMR today and how bad it is likely to become if the current trend is not altered. Now let's understand how does antibiotic resistance occur. We have a high number of bacteria in our body. Most of them are protective, a few of them are pathogenic, and a few of them are resistant, as is depicted by the pink forms here. Now, if we administer antibiotics, either unindicated or if indicated for a very long time, these antibiotics would kill the pathogenic bacteria and also kill the good bacteria in our body, which protect the body from infection. So we would be left only with bacteria which are resistant to antibiotics, which are very few initially. But once all the healthy bacteria are killed, the resistant bacteria now have very conducive environment to grow, and they take over. So our body gets more and more of these resistant bacteria. And these bacteria can even transfer their drug resistance to the normal bacteria which exist in the body. And hence, whenever a fresh infection occurs, our body does not respond as well to the antibiotics as it would be in case there were less of resistant bacteria. Now, a rational use of antimicrobial therapy is a balance between clinical cure and the side effects or the adverse effects related to antibiotic use. Rational antimicrobial therapy prevents the selection of pathogenic organisms like Clostridium difficile. It prevents collateral damage and alteration of patients' microbiome, especially GIP. It prevents toxicity or adverse effects of antibiotics. It reduces the cost of treatment, and it also would prevent discovery void of antibiotics. Hence, it is very important that we use antibiotics rationally. Now, these are the facts which have been listed in the Antibiotic Stewardship Program guidelines issued by ICMR in 2018. So it gives a 30% rule. It is seen that 30% of all hospitalized inpatient at any given time receive antibiotics. Over 30% of antibiotics are prescribed inappropriately in the community. Up to 30% of all surgical prophylaxis is inappropriate. 30% of hospital pharmacy costs are due to antimicrobial use, and 10 to 30% of antimicrobial cost can be saved by antimicrobial stewardship program, meaning thereby the amount of antibiotics which we use are not required to be used. Now, looking at the antibiotic void, antibiotic discovery and resistance timelines are shown here. There is a line here in the center, and you see some colored circles above it and colored circles below it. Each of this colored circle is corresponding to the antibiotic class when it was introduced. So if we look at the blue circle, it shows us the date of discovery. Below the line, it shows us the year of discovery. And above the line, it shows us the year in which the drug resistance was identified. So every time a new class of antibiotics is introduced, we do have, after a few years, we have a resistance developing to those antibiotics. But what is disturbing is that for more than 35 years, ever since 1985, when carbapenems were introduced, we do not have a new class of antibiotics which has been introduced. So that means there is an antibiotic void. And if we do not use our antibiotics carefully, we are bound to have antibiotic resistance. So the current scenario, if it is to be summed up, it shows that the resistant bacteria are on the rise, whereas the available antibiotics are on the fall. Now, let's understand what is smart use of antimicrobials. So it means antibiotics which are used responsibly. So there are two types of uses of antibiotics or antimicrobials. One is prophylactic and one is therapeutic. It is essential that we differentiate between the two. Prophylactic antibiotics are used to prevent infection during surgical procedures. It reduces the colonization of microorganisms at the time of operation, and it is needed for a short duration, usually as a single preoperative shot, because we do not have any pre-existing infection in the patient. Her body is healthy, and she has good bacteria which will fight out the microorganisms. Whereas therapeutic antibiotics are used to resolve an established infection, and they need to be used for a longer duration. So we must be very clear whether we are using antibiotics for prophylaxis or for treatment. Now, the various principles of optimal use of antibiotics in patients with suspected or proven bacterial infection include these 4 important points. First is initiation of the empirical therapy. We should use the right antibiotic when we initiate empirical therapy. It is not, piptas or cephalosporins for all our patients. In case there is a patient who has got urinary tract infection, we will use antibiotics against the gram-negative bacteria. So we would like to use aminoglycosides. In case it is a chest infection, then we would like to use augmentin. And there is no need to use antibiotics like metronidazole or clindamycin because we are not expecting anaerobic organisms to be there. But in case it is a puerperal sepsis, then we need to cover gram-negative, gram-positive, and anaerobes. So that is why we should know what infection are we treating and what organism is likely to cause that infection and choose the drug judiciously. And it is important that, the drug is given in the optimum dose and by the optimum route, and it is initiated as fast as possible. The second point is tailoring the therapy or antibiotic time out. Gone are the days when once we would start antibiotic, we would not stop it, thinking that there would be resistance which would develop. It is not the same now. So you are supposed to collect the cultures before you send the start the antibiotic. And once the culture comes, then whatever higher antibiotic you were using, you can stop that and put the patient on the specific antibiotic. So that means reevaluation continuously, usually after 48 to 72 hours. And in the meanwhile, if you realize that it is not infection and it is some other thing, then you can stop the antibiotic. So you can change the antibiotic, you can adjust the dose, you can add or subtract. Second is converting from intravenous to oral administration. Normally, if the patient is in the hospital, we keep giving intravenous antibiotics. So it is much better to stop that because patient can get infection from the IV needle site. So it is always better to shift them over to orals as and when it is indicated. And then use it in the shortest effective dose for shortest duration. And remember to take relevant cultures before starting antibiotics. So there are 5 Ds for appropriate or smart use of antibiotic therapy. It should be used for the right indication. The right drug should be used. It should be used in the right dose for the right duration. And remember, de-escalation to pathogen-targeted therapy is very, very important. Now, just to take you through the evidence which is available as far as the use of antibiotics for surgical prophylaxis is concerned. In OB-GYN, we would have usually the type of surgical wounds which we will have would be class 1 or maximum class 2. Class 1 are clean wounds. So these are all elective surgeries where there is no encounter. We do not enter the respiratory, alimentary, genital, or uninfected urinary tract. So things like diagnostic laparoscopies, cystectomy. So all these are class 1 clean wounds. Whereas class 2 or clean contaminated wounds are operative wounds in which respiratory, alimentary, genital, or urinary tracts are entered under controlled conditions and without unusual contamination. This would happen when we do hysterectomy because we enter the vagina, or we do cesarean sections. So usually these are the 2 types of wounds which we have. And antimicrobial prophylaxis is justified for most clean contaminated procedures. So a single shot of antibiotic should be good enough for most of the surgeries which we perform. No antibiotics are required for laparoscopy, except for laparoscopy, which includes diagnostic, tubal sterilization, operative laparoscopy, except for hysterectomy. There is no antibiotics are required for transcervical procedures like hysteroscopy, which can be diagnostic or operative, intrauterine device insertion, endometrial biopsy, hysterosalpingography, oocyte retrieval, DNC for non-pregnancy indication, cervical tissue biopsy, including LEEP or endocervical curettage. Only if the tubes are damaged on HSG or on laparoscopy, give antibiotics for a short while. Cystoscopy also does not require any antibiotic. There are certain indications where antibiotic prophylaxis is indicated, This includes uterine evacuation procedures like DNC, suction evacuation. Here one can give oral doxycycline 200 milligram or metronidazole 1 gram or azithromycin 500 milligram, a single dose prior to the procedure. There's no need to give antibiotics for 7 days. In cesarean section, hysterectomy, 3rd or 4th degree perineal tears, pelvic reconstructive surgery like colporrhaphy or vaginal sling or mesh placement, a single dose antibiotic is good enough. So giving cefazolin 2 gram IV stat within 60 minutes of giving the incision, within 60 minutes before placing the incision, or a combination of metronidazole or gentamicin can be given in those who are sensitive to cefazolin, or a combination of clindamycin or gentamicin, a single dose. When I say a single dose, it means a single dose. Now, antibiotic stewardship is what is desirable. It is a systematic measurement and coordinated interventions to promote optimal use of antimicrobial agents. So every facility, whether small or big, should have antibiotic stewardship program. I'll share my journey of antibiotic stewardship program in our own hospital. Although it looks as if, given the rush and the kind of patients who come to us, it is very difficult to think that we can give only prophylactic antibiotics, but it is not impossible. So what stimulated me to start this antibiotic stewardship program was this case way back in August 16. There was a 25-year-old prima gravida at term with preeclampsia. She had generalized anasarca. She had hypoproteinemia. She underwent cesarean section for fetal distress, and she was put on injection ampicillin and metronidazole. That was a time when we used to give antibiotics for 7 days. On day 2, she developed fever, tachycardia, tachypnea, loose motions, discharge from the wound. Her wound swab was sent for culture sensitivity. The antibiotics were stepped up to meropenem and ciproflox. On day 6, when the culture sensitivity reports came, it was found that her blood culture had Coagulase negative staphylococcus, sensitive to vancomycin and clindamycin. And her pus culture sensitivity showed organisms which were sensitive to linezolid, vancomycin, and gentamicin. So her antibiotics were changed to vancomycin and clindamycin was added. On day 10, she continued having fever. Her culture again came. This time it showed Acinetobacter, which was sensitive to peptase and colistin. And her antibiotics were changed and peptase was added. The fever continued. And on day 21, we did an exploratory laparotomy, gave her a peritoneal lavage. There was a whole lot of pus inside. And on day 26, she became breathless and she was shifted to ICU. She was intubated for assisted ventilation. Her endotracheal tube culture and central line cultures later on showed Pseudomonas and Klebsiella, which was sensitive to colistin. Her antibiotics were stepped up to colistin. And on day 32, this patient was extubated. And on day 40, she was discharged. So what was it? It was hospital-acquired infection and antimicrobial resistance. So it was a nightmare, and that is what got us thinking. And we thought that we must have antimicrobial stewardship program in place. This is what the picture culture sensitivity reports look like in these kind of patients. It is all resistant. And you feel very frustrated and you feel what is going to happen. Not every patient can be put on colistin. So the key messages here are that prevention of infection is not about administering antibiotics. It is more about use of aseptic precautions and rational use of antibiotics. And AMR is a serious problem. It needs to be combated by prudent or smart use of antibiotics. Otherwise, antibiotics will lose their efficacy and we will return to the dark age of medicine when there were no antibiotics. So sharing our journey of antibiotic stewardship in the Department of Obs and Gynae, Lady Hardinge Medical College, it was no giant step. It was a whole lot of small steps which we took. So we followed the point of care quality improvement methodology for the rational use of antibiotics. It is a 4-step approach. A number of you are already trained in this. So it comprises of identifying a problem, writing an aim statement and forming a team, then analyzing the problem and measuring quality of care by identifying outcome measures, developing and testing the changes by doing PDSA cycles, and then sustaining improvement. So I'll take you through all these 4 steps, which we did. First was problem identification, and forming a team and writing the aim statement. So our aim statement was to increase the antibiotic prophylaxis, a single shot antibiotic prophylaxis in low risk patients undergoing elective major surgery from 0 to 60% by 8 weeks. The team comprised of all consultants of the Department of Obs and Gynae, a team leader, a communicator, and a recorder. We did, the step 2 was we analyzed the problem, and we found out problems related to policy because there was no antibiotic policy in place. Anyone and everyone would give different antibiotics. Problems related to people, there was no sensitization, no awareness. There was reluctance to give single shot antibiotic because people were worried about asepsis. Then we had procedural problems like when should it be administered, who will administer, where would it be documented? And then problems regarding place, non-availability of antibiotic in the OT. So no one was willing to take forward this thing. In the step 2, we decided on 2 quality indicators. The first indicator was a process indicator. We thought that we will keep a record of number of patients who received single shot antibiotics, and the denominator would be number of eligible patients who underwent elective surgery. And the frequency of data analysis was monthly, and the data source was the case records. At the same time, we thought that let's keep an outcome indicator also to convince everyone that the thing is working. So outcome indicator was the number of patients who received single shot antibiotic and developed surgical site infection. And denominator was number of patients who received single shot antibiotic. Frequency was again monthly, and the data source was case records. So we had these 2 outcomes which we followed. Then we developed, did quality improvement PDSA cycles. So these were planned. We planned what are we going to do. Then we did when and how did we, will we do that change was decided. And then we looked up the results and saw what we learned. And then according to the results, we either adopted the change or adapted the change or abandoned the change. So I'll show you a tabular, display of the various PDSA cycles we did. So the first one was formulation of antibiotic policy. We had a detailed discussion and decided to finalize it with agreement of all the faculty members. And we also decided to do sensitization workshop for the residents on asepsis and roll it out in the whole department. So this process started in July and continued till the end of August 2017. We built a consensus of all involved, but not everyone was convinced to roll it out for the fear of sepsis. So we adapted it. We thought, let's start small. So this was the lesson learned. Then we moved on to the second PDSA cycle. Then we implemented it in 1 unit. And we did sensitization workshop for residents and also for the nursing officers because people were not convinced that the things would be sterile. And we also decided to collect the baseline data on the outcome measure, that is surgical site infection. So in 1 unit, it was rolled out for a month and there was 35.6% use of single shot antibiotic. There was no increase in surgical site infection. And then we adapted. So everyone else got convinced and we rolled it out in the whole department. So the lesson learned was that sharing experience with others builds confidence. Then we implemented it all the units and this was done in August. So approximately 50% use was there and there was no increase in surgical site infection. So this was adopted. And the lesson learned was that one has to be slow and steady. Then we moved on further. Then we identified a coordinator and nodal officers in each unit with a monthly meeting in person with presentation on data and discussion on cases where antibiotics was continued. So this was introduced in September 2017. And with this, the use increased to 60%. So we adopted this. And the lesson learned was that increase in accountability and ownership pays. And now this, we had reached our target, which we had planned, and it remained above 60% in October and November 17. In December, it again came down. So we looked at the reason. So we found that, the residents had changed and that is why the process had stopped. So we added we added an induction training for residents and regular sharing of data by the nodal officers with the coordinator. And this increased the use to 75% and we adopted it. The lesson we learned was that wider dissemination and need for continuous follow-up is important for sustenance. And we continued having it between 80 and 90% from November 18 to August 17 and 19. And a meeting was missed. 1 or 2 meetings were missed in August and September as the coordinator was on leave. And the rate again came down. So what we then decided was that we should have a fixed day in the month for a meeting for the nodal officers. And we also made a WhatsApp group so that the communication should be faster and it should not be dependent only on the coordinator. So we learned that for the change to sustain, it should not be person-centric, but self-sustaining. Then, we started sharing the monthly data in our monthly statistics meeting. We showed a PPT slide where we would show the single shot antibiotic usage and the surgical site infection rate per unit. And the lesson learned here was that there's a need for continuous follow-up for sustenance and sharing of data. And that keeps the momentum of change and everyone interested. There was a kind of competition. So since then, our surgical site single shot antibiotic use has remained above 80%. And for most of the months, it is above 90%. So this is what is happening in our hospital. So these are the kind of WhatsApp group which we had. And this is how we share the data so that, every unit would know what has been their performance. And for sustaining the improvement, what we have done is we have been continuously monitoring the process and outcome indicator monthly. We have been sharing the data. We have generated competition among the units, and we've appreciated those who do well. So each month, whichever unit does well is appreciated. So this is what our results are. The mustard line shows you the single shot use of antibiotics, and it has stayed above, almost 90%, reaching up till 100% also in some months. And the lower line, blue line, shows you the surgical site infection, which shows there's been no increase. Rather, there's been a decrease in the rate of sepsis, because everyone is cautious as far as their own practices are concerned. So this also shows the total sepsis and the sepsis in single shot antibiotic group, and it is being comfortably low. So to conclude, antimicrobial resistance is not a hype, it is a fact. And if we do not act now, AMR will take us back to the dark age of medicine. And antibiotics are essentially for prevention and treatment of maternal infections, for reducing maternal and perinatal mortality and morbidity. And we should use antibiotics responsibly to prevent antimicrobial resistance by observing 5 Rs: right indication, right dose, right drug, right duration, and de-escalation, right time to de-escalate. So I think with this, I come to an end, and I need to acknowledge a few people before I finish my oration. Professor Sushila Rathi, who's been my mentor, Professor S.S. Trivedi, who's been the advisor, Dr. Jagdish Chandra, who was our director when we took up this project. He's a visionary. Dr. Aparna Sharma, who's been my quality improvement buddy. Dr. Shilpi Nain, who's been the coordinator of all these activities. Dr. Sonal Saxena is a microbiologist who was our 24/7 AMR consultation line. And of course, my thanks to all the consultants and residents of Department of Obs and Gynae to participate actively in this project and keep it kicking. Thank you so much for patient hearing.
Thank you, organizers, for Dr. Ragini Agrawal, Dr. Jyoti, and Dr. Saroj Kumar for making me part of this important CME. It is a matter of pride and honor for me to chair the oration of Dr. Manju Puri, a great teacher, academician, orator, and a wonderful human being. The oration was mesmerizing. Thank you so much, ma'am. To sum up, antibiotic resistance is one of the biggest threats of global health, food security, and development today. Antibiotic resistance occurs naturally, but misuse of antibiotic in humans and animals is accelerating the process. A growing number of infections like pneumonia, tuberculosis, gonorrhea, and typhoid are becoming harder to treat with antibiotics. And antibiotics used for treatment has become less effective. Antibiotic resistance is leading to longer hospital stay, higher medical costs, and increased mortality. Prevention and control. Madam has very well enlightened us on the use of point of care approach to tackle antibiotic resistance. We can all do it in our facilities and follow her pattern of single shot antibiotic before the procedures. And I think this is going to help us all and help our country to tackle this great, problem which is taking a global stage. And the burden of antibiotic resistance on women's health is great. Sepsis is a major cause of death after abortions and childbirth. So here again, rather than being pushed into the dark age when we did not have antibiotics, it is better we take care today. We stand together and we do our our duty towards the good health of our society by using the antibiotics judiciously, carefully, following guidelines, and to educate people not to overuse antibiotic or rather misuse these products. So here again, thank you very much for a wonderful oration, ma'am. And I'm honored to chair the session. Thank you so much, organizers.
Thank you, Dr. Kiran, and thank you, Dr. Ragini, for this opportunity. And it gives a very, very, warm feeling. It is very, I can't explain, I don't have words to say how good it feels to be linked with all of you. And I appreciate the efforts you people are putting in for all the important aspects of women's health. So continue with the good work and all the best.
Thank you. Thank you so much, Manjudit. Please be here for a second more. We will awarding a oration to you. Sonika, please share the slide. And me, along with my co-conveners, Dr. Saroj, Dr. Jyoti, Dr. Promila, and Dr. Chandan, and all the HARObGyn team, we give you we really, from bottom of our heart, we give our thanks to you, Dr. Manju, because it is a really, really very important thing which you have given to us, and we are our advisor of the HARObGyn, and we are going to be benefited in future also. So Professor Manju Puri is awarded Oration of Abhilasha 2022, theme Saving Mothers, on 27/2/2020 for her excellent contribution in field of obstetrics to save mothers. Topic of oration is antimicrobial resistance. How can obstetrician contribute to curb this menace? Thank you so much. You here, you are on vacation, but you have joined. Thank you so much.
Thank you so much. Thank you.
Next session, Ankit, carry on.
Next session is Dr. Ragini. Next session is
Jyoti.
Yes. Then next session is by Dr. Jyoti on ART pregnancy after 40+. Over to Dr. Jyoti.
Yeah, thank you so much. Thank you, Dr. Saroj. Thank you, Ragini ma'am. And again, I would thank you for the POKI program that you organized for all Haryana, because ma'am has done this PSDA cycle, and most of the people who are there on this platform have know about it. So that was very important that you organized that thing, and I would like to thank you for on this platform for organizing that, and Dr. Surekha organized it for us. So it was actually a great honor to be associated to this HARObGyn platform, and welcome to this panel that we are doing now. So I would, without wasting any time, I would share my screen and we would be discussing on the ART pregnancy after 40. So we have this panel discussion here on ART after 40, where we have expert Dr. Sonia Malik ma'am. And we have the other panelists who are also as expert, Dr. Poonam Lumba, Dr. Seema Mittal, Dr. Ritu Jain, Dr. Neeru Thakral, Dr. Sapna Jindal, Dr. Rakhi, and Dr. Gurpreet Singh Kalra. So why we are talking about this? Because late marriage, second marriage, widespread use of family planning measures, postponement of pregnancy because of the career goals, and advances in ART are contributing to all this. The advanced maternal age pregnancies, and what we consider advanced maternal age is 35 years, Whereas after 40 and older, we are considering very advanced maternal age. So today we would be discussing about very advanced maternal age pregnancies. So straight we come on to this situation, Dr. Kalra. We have this 41-year-old Mrs. A. She has been conceived by IVF in the second attempt, and she was lucky enough, she conceived with herself oocytes. Now she comes into the OPD with 6 weeks, 4 days pregnancy, bleeding PV and pain abdomen. So how would you proceed? Dr. Kalra, yes, sir.
Yes, can you hear me?
Yes, sir.
Thank you. Thank you very much, Dr. Jyoti, and thanks to Haryana OBGYN to have me on the panel. I'm thankful to the co-panelists here. Yes, so thank you for your query, very relevant, common presentation. I mean, just getting the initial acute assessment and ruling out any acute event out of the way, if there's any topic, any whatever is going on. So this lady's had a second episode. She's miscarried once, isn't it? This is second episode, and it could be miscarriage. And I will straight on with my ART, reproductive endocrinology hat on, and reprogenetics being close to me. I think, what are the risks? What is his prognosis? Because of course, if this is a miscarriage, then one needs to think about what do we do next and why is this happening? That will be the first question the patient will ask you. Doctor, I'm miscarrying again. And the fact is that we have long
actually,
known
this is not a second miscarriage. It is a second IVF. I mean, she has conceived in the second attempt of IVF, and she is presenting to us with this threatened abortion. So, what do we do? What investigations? How do we counsel her? What more we add? Whatever we have been giving her, because as it is IVF pregnancy, we always give progesterone support, a luteal phase support in these. Cases which is continued.
Yeah, okay. Thank you for clarifying that.
And what could be the reason for that? And maybe I would, after this, I'll request Dr. Neeru to add on to this question, to the answer.
Okay. So I will go down to the specifics that you mentioned there. Thank you for that. Now, so second IVF, assuming that first IVF has of course failed, and there is, her age is relevant here. The female age is very strongly related to the outcomes. So you will initially kind of rule out the acute event, as I said. There is no ectopic or anything, although at 41, the chance may not be that high. And then you mentioned the word progesterone, and that's relevant because I know there is widespread prevalent use of progesterone to support the pregnancy in these cases. Now, she, per definition, will be a recurrent miscarriage after the second miscarriage. Again, there is a variance between professional organizations considering it and countries considering whether it is a recurrent miscarriage or not. So the PROMISE trial was one of the big trials from United Kingdom. I think it was from London, which looked at this it was a randomized controlled trial, and that trial in itself did not manage to prove it, that there was benefit from progesterone against recurrent loss of pregnancies. However, there was a subsequent study by Kumar from Birmingham in the United Kingdom. I think it was years ago, where they've shown benefit for these women from progesterone replacement. And now, not long ago, the National Institute of Clinical Excellence in Healthcare
I would like you to brief it, because we have only 45 minutes and we have many things to cover.
Sure, I will. Thank you
so we
your
can
guidance.
Just
so my point
on
is
ultrasound, what all treatments. I know all these trials actually they don't support progesterone, but in a threatened miscarriage.
Well, no, I was actually coming to that. Recently, NICE has included it in its recommendation for miscarriages. Progesterone is now okay to use based on evidence.
Sir. So what you would give Dufaston, you would give injectable, you would give vaginal progesterone.
In my practice,
we want to give our viewers the clear points. That is it.
So you want to give clear succinct management points, right?
Yes.
So you would, of course, scan initially and see what's happening. Is there a pregnancy located within the uterus? If it is located in the uterus, of course, as you mentioned earlier, an imminent, or it could be a threatened abortion. And then you would want to consider what you want to do. And there isn't any evidence, however, if there is threatened abortion, that starting progesterone at that time is going to stop it. There's no evidence whatsoever. There is evidence, as I said, if you started it previously in a 41 years old previous failed pregnancy, if she's had miscarriages in the past, you may be in your right to give her progesterone beforehand, starting from her embryo transfer. However, no evidence of benefit after she started bleeding. So I would follow her up with HCG and repeat scan whether she's okay with that or not. Going forward, is she miscarrying or not miscarrying? I think that would be my approach. I wouldn't give her progesterone to protect
I
or
would
stop
like
the
Dr.
miscarriage.
Neeru to add to that. Dr. Neeru.
Yeah, thank you, Dr. Jyoti.
What would be the reason for that, and what do
Yeah.
you think ectopic, the pregnancy rate is increased in women above 40, and otherwise the treatment that you would
yeah, so we'll ask the history also. That is very important, because this IVF pregnancy, many times they are on the high dose of low molecular weight heparin or in the ecosprin. So if they are taking the ecosprin, we'll take the history. We can stop the ecosprin, but we generally carry on the low molecular weight heparin. Then we admit the patients, get all the investigations, ultrasound, progesterone, sugar, and CBC count and CRP also, because I've seen personally also endometritis incidence is very, very common nowadays with these patients. Then we get the ultrasound, we'll see the cardiac activity. Is there any cardiac activity? Because there are so many chances of abortion. We all know after the age of 40, abortion risk is even 29% if it's more than 40, and it's 39% if more than 42. So we rule out whether there is a cardiac activity is there or not. Retroplacental clot is very, very important. If there is a retroplacental hematoma, we definitely, it could be due to the endometritis, or it may be sometimes in case of APLA also, we see the large hematoma. We get all the investigations and then manage according to the cause. What is the cause and manage accordingly.
So very nicely, Dr. Neeru, that you've said that the incidence of abortion increases. See, as at 35 to 37, it is as high as 13%. And 38 to 40, it goes to 20%. Above 40, it is as high as 30%. So all these ART pregnancies are very, very vulnerable. And 42, as high as 1/3 of the pregnancies may abort. So we have to be very careful, and the support that you have described is we should continue with that. We can stop aspirin, but we can continue with low molecular weight heparin. So that was one important thing that you pointed out. And why they are increased in these women is because of the decline in the oocyte quality, because of the changes in the uterine function and the hormonal function, and majority of these losses occur between 6 to 14 weeks. So these losses could be both trisomic, be both euploid, and as nicely explained by Dr. Kalra and Dr. Neeru, we have now come to this consensus that we continue with we give progesterone and continue with the low molecular weight heparin, and rule out other, and maybe we can do a sequential ultrasound to see the hematoma size, that the choriodecidual separation that you pointed out. So coming on next to our question to Dr. Poonam Lumba ma'am. Ma'am, this 43-year-old IVF lady, she has conceived with donor eggs. Now, on the ultrasound, we see twin sacs, and it is a diamniotic, dichorionic pregnancies. At 9 weeks of gestation, we see cardiac activity in both. So what now at what time would you start with the aneuploidy screening? Actually, I want you to focus on the aneuploidy screening, the scan, the NT scan, the role of Doppler in this part, and the role of double marker. So mainly all this in a very short time. Dr. Poonam.
Okay. Yeah, good morning, Jyoti. Good morning, everyone. See, this is what we all are doing in our day-to-day practice. So at 9 weeks, if we are seeing dichorionic, diamniotic twin pregnancies, first of all, counseling of the women is very important. We have to counsel her regarding maybe one of the twins disappears and we are left with a singleton pregnancy. But in case both the fetuses grow simultaneously, then at around 11 weeks, I would like to check on the nuchal translucency thickness. NT values will be checked, and then the nasal bone will be seen. Now, in single-term pregnancies, we depend upon the NT and the nasal bone plus the biochemical markers during the first trimester for aneuploidy screening. The Doppler studies, which we look at, are tricuspid regurgitation and
NT scan you do at 11 weeks. Is it? Can you see
11
it
to
clearly, or
13
you would like to do it a little later? I mean, what is your
No, 11.
What time?
So earliest I will check at 11 weeks.
Okay.
But still we can follow it up up to 13 weeks.
Okay.
So the earliest I would like to see at 11 weeks. So then we can in singleton pregnancies, normally we depend upon the NT thickness and the biochemical markers. But for twin pregnancies, the role of biochemical markers is still debatable because the reference ranges for the twin pregnancies have to be seen to make the calculations. So age-related risk, that is her age, and the NT value can be taken into consideration. And pregnancies which are conceived after ART, the decision making is very, very difficult for the woman. So the counseling is important, like if we follow them up to 13 weeks and still we find some abnormal values. So the decision making is very difficult in the sense that the pregnancies are very precious and nothing is 100% as per our calculations that the fetus will be 100% abnormal. So again, we have to counsel them for the invasive testing, which very few women would likely to take. In practice also,
the role of Doppler, ma'am? Doppler, where you would do it at, and what is the importance of doing a Doppler in this particular age group at this time in the first trimester?
See, Doppler studies, tricuspid regurgitation can be, it can catch the Down syndrome at around 13 weeks. And ductus venosus can also, blood flow can also be seen in these women, fetuses.
Right. I would like, if Dr. Seema Mittal or Dr. Neeru, anybody would like to add on to that?
Yeah, we can do it 12 weeks generally, do the level 1 scan, and double marker also can be done. If it's a twin pregnancy, then also vanishing twin, then there is no significance of the NIT or double marker. Otherwise, we can do the double marker testing also in singleton or twin, all these pregnancies.
Right. See, recently they have also, the NIPT, recently they are trying to make calculations by the NIPT test also for twin pregnancies at around 10 weeks plus.
Yeah.
Dr. Ritu, you would like to add anything? Dr. Ritu,
Yeah, that's the only thing is, Doppler is, Dr. Jyoti, is so important, as in these age group, we are doing it like pre-pregnancy also to know the uterine Doppler indices, so that PI is already existing. And when we do this, if this PI of uterine artery is more than 2.5, so we know we need to add ecosprin 150 milligram. But as these are advanced age pregnancy, because of pre-existing hypertension, so many of the patients may be already on ecosprin. We may just need to increase the dosage, and we need to follow up the Doppler parameters very, very carefully, because this is going to affect the outcome.
So if the already patient is on aspirin 150, so and if the Doppler indices, they say that the PI is more in the uterine arteries, what would your take be? You would still continue on the 150? Because I don't think they're increasing a dose above 150 would be anything.
Yeah, Dr. Jyoti, certainly not beyond 150. I do add NO dilators like RG Prim sachets or tablet as they are available in the market, or we add low molecular weight heparin, explaining the patient that this is like obstetric vasculopathy. So Doppler is one of the parameters to assess it. So as in pregnancy, the role of other markers is, other blood parameters is not conclusive, because of procoagulant state. So we do start low molecular weight heparin, and as we follow through the Doppler, we definitely find that there is improvement in the Doppler parameters, and PI does increase, and the various charts are available as per gestation. So, but very important is that we need to do Doppler every 2 weekly in these patients.
Right. So the frequency of Doppler needs to be higher. We have to start them on aspirin 150. If they are already on aspirin 75, we increase the dose. If they are not on low molecular weight heparin, we add that. And then the frequency of the surveillance increases. Again, I would like you to cover up, Dr. Ritu, on the aneuploidy screening in triplets, how you would go about it. In the case of triplets, what do? You would take biochemical screening into play, or only the NT scan would be enough?
Yeah, Dr. In triplets, because it depends. Like in triplets, if it is a reduction already from quadruplets to triplets, which is rare nowadays, or it is pre-existing triplets, and if we have to do some screening, it is around 11 to 13 weeks, and the nuchal translucency has a great role to play. And already the chorionicity we should know. It is like in IVF pregnancy, and if it is a donor pregnancy, it is usually dichorionic, diamniotic pregnancy, though there can be sometimes monochorionic diamniotic also, which we cannot miss out. So chorionicity has to be mentioned very, very clearly from the first trimester scan. And NT scan has NT value is of so much importance, because discordance in NT value, it gives us a hint that how these pregnancies are going to be in future. Like if it is a monochorionic diamniotic, it gives the first, NT gives the first hint about TTTS. Now coming on to trichorionic triamniotic pregnancy. So as this is a triplet case, so basically we have to depend more on ultrasound, a very detailed ultrasound nuchal translucency, and is of great help. Serum markers are not of much help. We already know they will double or triple as per the gestation. So moreover, if serum marker are this FMF Foundation have found validity of this aneuploidy markers only in twins, not in triplets. They are not so validated. Even in quadruple scan, if we do in first or second trimester, the detection rate is 78% or 54% in first trimester, or the first trimester markers like double marker, and quadruple it is just 58%. So even in twins, the efficacy rate is, this detection rate is less, and false positive rate is very high. So nuchal become very, very important. And discordance is one thing which we should be looking for. And in these patients, we should definitely follow them up with the early genetic sonogram with uterine artery Dopplers.
So early genetic means what gestation age would you consider if in these cases?
Usually we get it done around 15 to 16 weeks.
So yes, so that
because high-end machines can give us a lot of information around that time.
So early genetic sonogram is something that we have to focus in these cases, and we just not wait till 18 weeks or 19 weeks for a level 2 scan that we routinely do in other pregnancies. And any role of the quadruple screen in these in any of these cases? Quadruple screen? I think Dr. Ritu is not. Less. Okay, Dr. Ritu is not there. Then I think Sonia ma'am is here. Sonia ma'am, I would like to your comments on the aneuploidy screening, if we have left out anything. Sonia ma'am, I saw she had joined. I think maybe now I
Spot marker efficacy is also very, very less.
Less, yes.
If it's 60% in the singleton, but in the twins it's only 40%. So very less.
So when we have pregnancies, if we have triplets, or if we have triplets reduced to twins, we do not go in for biochemical markers. We only focus on the NT scan in those cases, but even if they have been reduced. So now coming on to the second trimester, we have Dr. Seema. What are the risks of genetic chromosomal anomalies and congenital malformations in women above 40, and when would you like to do the anomaly scan? So maybe I can
Thank you, Dr. Jyoti. Yes. Hello.
Yeah, we can hear you.
Yeah, so the risk is definitely more. 1 in 100 women will have some chromosomal abnormality or genetic abnormality because the whole ovarian cellular milieu is now altered in women beyond 40. So definitely chances are more. So if we talk of anomaly scan, as the question has been given to me, normally all our patients 40 and above, we are doing neural tube. For neural tube, we do at 12 weeks, we just do the ultrasound and that gives us a complete picture. And we don't go for dual marker at this stage if everything is normal on ultrasound. And at 16 weeks, we are doing quad marker for all the patients beyond 35 in our IVF cycles. So this is how we look for all these anomalies. We are not doing NIPT as a policy matter because false positive, false negative results are more. So this is our basic protocol that we are following at our center.
So you don't do double marker and you do only quad screen?
If our neural tube, our scan is all right, we don't go for dual marker definitely because that puts unnecessary tension on the patient and we have not seen much. Initially we were doing, but I have not seen any resultant effect of all these procedures. So this is good enough. 16 weeks we do go for quad and 12 weeks we do for neural tube.
Dr. Neeru, what is your policy?
No.
What do you
quad
follow?
marker efficacy is very less. It's only 60% in the case of single and 40% in case of twins. We go for double marker because double marker efficacy is always better.
Yeah,
it's
that
around
is,
85% if we combine double marker with the level 1 scan. So always do double marker, never the quad marker.
Actually, theoretically, it is very correct, but practically, I've seen all my patients come with a double marker and it is doubtful, and then they spend all time. I have not seen a single patient with abnormal dual marker having problems later on.
Dr. Sonia Malik, ma'am, if you are there, I would like your comment because we are actually differing here. Dr. Seema wants a quad screen and Dr. Neeru goes on double marker. Is Dr. Sonia ma'am, are you there? Sonia ma'am?
Jyoti, hello?
Yes, Dr. Poonam.
Yeah, I would like to make a comment.
Yes, ma'am.
That as per the ACOG guidelines, recently I have seen in America, they have shifted to totally to NIPT at 10 weeks. They don't even do the anti-scan. And at 13 weeks, they call for like only anti-scan, or they will do alpha fetoprotein for this neural tube defects.
Right, ma'am.
So as per the ACOG guidelines, they are
But
not
ma'am,
doing any
in
marker
our
also.
setup, because NIPT is quite costly. So
Yes, it is
then
expensive,
we
and maybe
cannot
we
use
don't
it
have the good labs which are doing.
Yeah.
We don't have good reference range. And secondly, the sex determination is prohibited. It's like not allowed. There, they also declare the sex, and they also do the screening for trisomies 13, 18, and 21.
Right.
So
I also agree with
Dr.
Dr.
Ritu?
Poonam.
Yeah.
So what do you?
Dr. Poonam, whatever
always-
you're saying is almost what we are following. Yeah.
Yeah, sensitivity is already 99%. It is best, but yes, cost factor is also there.
So, okay.
Otherwise, we can do very nice.
Dr. Ritu, you do NIPT in all your cases, all your ART pregnancy?
Above 35, if it is self, and if it is donor, this is a double combined screening and integrated serum screening whenever needed.
Okay. And one important thing that we all, I think, forgot to mention is that when we are ordering this test of the biochemical screening, when it is we have to always mention the donor age, because we sometimes in the lab, we see the patient's age and the slip, and that age is mentioned.
No, only the donor's age is
Age has to be
recommended.
mentioned. So we have to be very categorically in our form mention that it is the pregnancy from a donor and the donor's age is so and so. So that we have to keep in mind.
See,
always.
definitely the donor will be less than 35.
Yes, ma'am. Yes.
Yeah.
So yes. So always the donor will be less than 32. It would 35.
30.
So, yeah. So coming on next, Dr. Neeru, what about fetal echo? Do you do fetal echo in all your ART who are more than 40? And At what time do you advise a fetal echo, and what are the common anomalies do you feel can be picked up in this echo? In
Yeah,
these, what are the
fetal
common?
echo I do in all the patients who are more than 40 and having their self-X, definitely was chances of chromosomal anomaly and cardiac anomaly both are high, especially chances of ventricular defect. Otherwise, there are more chances of ASD, BSD, single ventricle defect, and palate tetralogy. So we do the echo, and best time to do echo is 22 weeks. Because if we said at the 20 weeks, always cardiac person, they says, no, we can't see now early. So we do it 22 weeks. Now we have MTP age also up to 24 weeks. So better to do at 22. Now level 2 also we order at 2021 only. Never earlier we used to do at 18 to 20 weeks, but now we send all them to 20-21 weeks.
Dr. Siva, have you changed your policy after this new MTP Act?
Actually, Dr.
the
Neeraj, because when we talk to radiologists, they say that the more the time, better they can perceive the anomalies. So definitely we are shifting beyond 20 weeks now, but not beyond 22. Yes, we are doing it.
So,
echo at 20 weeks and level 2 at 20-21 weeks.
Echo at 22, level
Level 2 at
21. And Dr. Poonam, you also follow the same policy?
See, I'm doing between 18 to 20 weeks, level 2 scan, and fetal echo for all my ART patients.
Even if they are 35, if the lady is 35 and conceived?
Yes.
Fetal
I do
echo
it
in
for
all.
all my patients, and that is around maybe 24 weeks. 22, 24 weeks, but ideally around 24 weeks.
Okay. And there is a comment by Dr. Promila Malik in the chat box. She has been actually giving us all the answers there. So she has written that she wants to do both level 2 and echo at 22. So she wants to combine it together.
Yes, visits are less and patient is more comfortable and the cost is less. So we don't call people
So we
twice
can
after.
do it since after this change of law, now there is no need to rush the patient for a level 2 at only 18, 19 or 20. We can even go till 22 weeks. So that is most of our panelists that have agreed on this. And if our expert, Dr. Sonia ma'am is there, we can take her comment. Ma'am, have you joined? Because in between I saw ma'am. If
I will make a call to her.
If Dr. Deepika, if you can please call up Dr. Sonia ma'am and find out if, because I saw her joining and then I can't see her. We want her comments in between. So coming on next, we have this 43-year-old, 31-week pregnant with HDP. Dr. Rakhi, this question is for you. She is a 43-year-old. Or I would like to share the screen if you want to read. I would just 1 second. I'll share the screen so that you can. So yeah. So this is this 43-year-old, 31-week pregnant with HDP, and she's on labetalol 100 mg twice a day. Her GCT blood sugar at 1 hour was 160. So what would be a management plan? Very briefly, how would you manage her, Dr. Rakhi? Dr. Rakhi, are you there? Dr. Sonia ma'am has joined. Ma'am, we wanted your comment on the what time you advise a level 2 scan and a echo, and whether in all cases or not. Rakhi, we'll come to you just after half a minute as ma'am comments. Ma'am, please unmute yourself.
Actually, Jyoti, I got disconnected because I was in the car and I didn't have any internet.
Okay.
What exactly is the question?
Ma'am, actually,
what exactly?
We were talking
level 2 scan.
A level 2 scan.
At 18
whether
weeks.
Fetal echo needs to be done in all cases, and at what time we do the fetal echo. And for the level 2 scan, actually, have we changed it? Are we doing it a little later these days after the new MTP Act? And what time now? Because otherwise we used to do it at 18, 19, 20 weeks. So now, as suggested by many of them, that they have done it at 20, 21 weeks. and a fetal echo at 22. So what would you advise to all our viewers?
Yeah, that is actually that was regarding the MTP bill only, because basically fetal echos are more useful after 21 weeks. You know, the diagnosis, and similarly for kidneys also, you know, the renal scans are much more efficient after 20 weeks, not before that. So at 18 weeks, many times these things used to be missed. And that was the reason everybody was stressed on raising the MTP limit, you know, to 24 weeks as we were all wanting. So basically, yes, after 20 weeks, if you're wanting to, or if there is an indication, fetal echo is not indicated in every patient. It's not as if you want to do it.
Okay.
But if the level 2 indicates that there is a cardiac anomaly or there's something in the heart which needs more attention, then yes, a fetal echo is mandatory. Then it becomes
so many
mandatory.
times all our reports say there is a small calcification in the left ventricle and advised fetal echo. तो उसमें क्या करेंगे?
बहुत बार वो many times that calcification, if it is all by itself, over a period, say starting from the first NT scan on to the second scan, and there are no other markers other than this little calcification, it does not mean that, you know, there is something over there. This calcification may be just a normal anomaly and it will pass off.
So
but
only
if there are other
isolated.
markers in a isolated, yeah, it doesn't mean anything. But if
Doesn't
there
mean
are other markers along with it, then yes, it warrants a further, you know, assessment of the cardiac function and structure also.
Right, ma'am. And about a maternal echo, I would like to ask, even at the same point, though I wanted to discuss it a little later. Do you do in all ART pregnancies above 40? Do you do a maternal echo as well?
No. See, the guidelines are very clear about maternal about pregnancy after 40. Before starting any such patient, we are supposed to be taking a an assessment from the physician. There has to be a physician clearance. There has to be a physician clearance, which is not only for whether she can undertake a pregnancy, it is also whether we can give her high doses of hormones. Because in the first trimester, you must remember that she is going to take high doses of hormones. So therefore, we have to take this clearance from the physician.
Right.
Hence, then it becomes the responsibility of the physician to guide us whether this patient needs any further cardiac assessment or not.
But
if the physician is sure that the patient doesn't need anything more than just a normal ECG, then we don't do it.
Right. So
But
we do a ECG in all our pregnant patients and a echo accordingly. So thank you so much, ma'am. I'll come back again to you. Dr. Raki, sorry for interrupting you. We have this question for you. She's HDP and gestational diabetic. And how would you plan her? She's 43-year-old, very briefly, so that we then go on to next, Dr. Poonam, what would other problems you would anticipate in these elderly women apart from hypertensive diseases and gestational diabetes? Raki, please unmute yourself. Raki, abhi bhi sunai nahi de raha hai. Can you please unmute yourself? Ankit, can you please see?
Actually, ma'am, वो है ना the wire, the cord.
Yes, ma'am.
You'll have to be without the wire, ma'am.
Remove the hands free. Yeah.
Yeah.
Yeah. Now
Ma'am,
you're audible. Yes.
Okay. Since it's a high-risk pregnancy and I would like to admit this patient, advise the patient to get admitted and do the BP charting and the sugar monitoring. Since there is both hypertensive and high sugar can lead to sudden IUD, so it's a close monitoring is necessary. And accordingly, we can change the laboratory dose and we can start whatever the sugar levels will be there, fasting, PP, breakfast, lunch and dinner. We can add this glycemic drugs or we can start the insulin according to the reports, and we have to give the steroid to the patient, so that if we have to give the early cesarean, if we are planning, or early delivery we are planning, so that for the lung maturity of the patient. And the ultrasound also we will do because the patient is admitted, so we can go for color Doppler and with the ultrasound. So
more
that will
of
be my
surveillance and more, we have to have a proper strict diet control, MHT, we can put her on metformin.
control both the BP and the sugar basically. Motto, that is why we are admitting the patient.
Yeah, very right. So Dr. Rakhi has stressed on a strict control of blood sugars and the blood pressure, because these are the two common problems that can occur. Ma'am, Dr. Poonam, what other medical complications do we encounter in these elderly women apart from these two?
See, if she is a case of chronic hypertension, as Dr. Sonia has suggested, so before we take them for any ART treatment, there is always a physician green signal and physician checkup, so that all her baseline studies, renal function test, liver function tests, and her lipid profile and her cardiac assessment is already done prior to taking her for ART. Because all these high-risk women, apart from hypertension, diabetes, and because of hypertension, they can have some renal problems, or they can have the complications of hypertension in diabetes, or hypertension in pregnancy, and also complications related to diabetes.
Right, ma'am. So apart from that, we have also these placental issues in these women. We have higher risk of abruptio placenta. We have higher risk of
That is related
previa.
to the pregnancy. So
Right.
medical complications can be related to the hypertension and diabetes,
Yes,
which can affect their renal and liver functions. But as far as the fetus is concerned, there can be growth restrictions, there can be oligohydramnios, preterm birth, and perinatal morbidity, mortality can be there, and intrauterine
Growth
fetal
retardation.
death can be there.
Right.
And for placental abnormalities, there can be risk of placental abruption. So all these complications have to be kept in mind. The patient has to be counseled for the risk of superimposed preeclampsia or eclampsia, God forbid. But recently we have seen that patients, all these patients are on ecosprin. And since I have been using ecosprin for the last so many years, I have seen that the risk of preeclampsia has really become very, very less. Seldom no case of eclampsia I've seen in all these women, high risk pregnancy groups. But they can have preeclampsia, and it has to be tackled well in time so that it doesn't progress. And the counseling has to be done to the patient before they become pregnant.
Right. So these older women already, they are at risk. They already have all these, they are actually have more prevalence of cardiovascular, renal, autoimmune diseases, obesity in these women. And that is why we have a higher rates of hospitalization, cesarean delivery, and pregnancy related complications. And these two, hypertension and gestational diabetes, are the most important. And these women have higher rates of severe life-threatening morbidities, including renal failure, shock, cardiac morbidities. So we have to deal these cases along with the physician, even during throughout their pregnancies. Now, women who are 45 to 54 had nearly 3 times the risk of severe morbidity compared to younger women, and they had high risk of preeclampsia, PPH, gestational diabetes, thrombosis, and hysterectomies. And as Dr. Poonam ma'am suggested, that these women are at high risk of low birth weight, IUGRs, because of decreased placental functions and preterm deliveries. So Dr. Neeru, very briefly, we have only 5 minutes left. I think just I would like you to cover this case. She is 44 years. Adenomyomectomy was done 8 months back. She conceived with donor eggs, and she has conceived twins. And she comes at 30 weeks of gestation with severe pain abdomen for last 3 hours. So what is your probable provisional diagnosis, and how do you manage?
She's got adenomyomectomy done and now come in acute emergency with the severe pain. So there could be chances of rupture uterus. We have to keep in mind in all these patients of adenomyomectomy. That's why we does not allow pregnancy for 3 to 6 months after adenomyomectomy, and we always prefer to do single embryo transfer. We never
Absolutely.
do two blast transfer.
In
Because
crutch,
if
she
we are
has told
twins or
us
triplets or any
everything.
multiple pregnancy, rupture is more chance. Yeah.
Absolutely. So in adenomyomectomy, we have to be very, very cautious about history, about rupture. These cases can rupture early, even at 30 weeks. And this is the thing that we should keep in mind in cases who have undergone adenomyomectomy, and always do a elective single embryo transfer, and never even think of having twins in these cases. So coming on to the third part now, in the labor and delivery, Dr. Seema and Dr. Raki collectively, if whoever can take this. She is now 36 weeks, 3 days. Singleton BP is 150/92 on labetalol, though urine albumin is still nil. So when do you do induction in these cases? Is there any time limit where when you start the induction, what would be the mode of delivery, the intrapartum monitoring, or you do elective cesareans? Your comments, please.
Dr. Jyoti, we go for elective cesarean, especially this particular case, who is 43 years old and she's already crossed 36 weeks. Albumin is not the criteria, but other factors are there. So for this patient, we will go for cesarean section only. And routinely beyond 35 weeks pregnancy, we do a planned cesarean only. We don't induce. Otherwise, if patient is hypertensive beyond 36 weeks, we must induce with strict intrapartum monitoring.
Okay.
I don't agree with this. We can do the bishop, do the PV and do the bishop scoring if it is favorable or not, and we can decide if there is chance for the induction of labor. If because 150/92 and all of it. Otherwise, if we forget that she's ART pregnancy, we can give a chance for a normal delivery also if the bishop score is good.
Okay,
this elderly primary, we never give any chance for
Dr. Poonam, are you brave enough to do be like Dr. Raki?
Jyoti, we are not brave. We will try to be very safe in such pregnancies. There is no need to take a risk.
Right.
Just deliver her by cesarean section.
Dr. Kalra, what do you say, Dr. Kalra? What would you do? Sir, unmute kijiye.
See, vaginal birth, Jyoti, vaginal birth in ART pregnancies is recommended and happens also.
Yes.
But it happens in women who are multiparous, who have had children, prior they had, and they were a case of secondary infertility. And sometimes, my patient, like a foolish patient of mine, she conceived with donor eggs and they lost their baby, taking chance for a vaginal birth.
Right.
So it's very
no,
risky.
No, it is absolutely. Dr. Raki is also very right, and Dr. Seema was also right. As Dr. Poonam, we have to, according to the patient, how she can understand whether she can come to us in time, and whether she is willing for a cesarean. We can give a short trial and then go in for a cesarean. And would you like to induce, because or there is any option for delivery as such according to the guidelines, if anybody can point out? Dr. Ritu?
So it is like we should assess each case individually, take the medical risk factor on one account, her age on another, obstetric conditions like what are Doppler parameters and what are ultrasound parameters, and this Bishop scoring on other side, and willingness of a woman and her CTG tracings also. So each case is individual. Nobody can say that for this will go elective, or this. It is, you make a complete assessment and decide case to.
Dr. Ritu, about the anesthetic complications in these elderly women.
Yeah, they are too much. One will be related to the pre-existing medical condition they have. Suppose they have pregnancy, the superimposed hypertension or hyperglycemia of pregnancy, so that or hypothyroidism or hyperthyroidism relating to that, all the complications can increase the medical thing. Another is age-related anesthesia complications, or underlying more important are the cardiac complications which can happen to these patients. So even with the spinal anesthesia, we know the regional is safe. Sometimes there are cases of cardiac arrest which are reported, and in case it is a failed, and also some people, because obesity comes in, failed intubation and anesthesia related risk increase. Then if there is pre-existing hypertension, the next day the chances of this cardiomyopathy also increases in these patients.
Dr. Sonia ma'am, I would like your comments on these ART pregnancies. What is there any, what do you do? Do you do induction in these cases? Do you go for elective cesarean? Dr. Sonia ma'am, your expert comments, if you are there. I think Dr. Sonia.
Jyoti, can I add, Dr. Jyoti?
Yeah, please. I think Sonia ma'am has left.
I just wanted to make this clear. This is not the point of being brave or not being brave. This is about the patient, and we will induce only that patient which is favorable of delivering the, and they can be 2 out of 10 patients like this which could be delivered normally. So just to say to the patient, oh, we'll go for elective, I just don't agree with this.
Absolutely. So we have to go according to the patient, and it is actually we have to assess individually whether we should go in for induction, whether we go in for.
Yes, Dr. Jyoti, since, sorry, quickly, 10 seconds. You asked me the question, so I'd like to answer that.
Yes, Dr. Kalra. Yes.
Yeah, no, I will agree with the last speaker and what you're saying as well. I mean, there are 3 risk factors. She's 43, she's IVF, and she's hypertensive. But that does not mean that there's an imminent disaster happening. It's not waiting to happen right now. So I would assess her and counsel her and talk to her about the risk, and then give her a chance if she really wants it. I'll give her a chance for a short while, and she's Bishop is favorable and she's progressing right, and with intrapartum monitoring, she may be led to a favorable result by inducing. However, if she's not willing to take the risk and is wanting to not have it, then we have to give in to her demand. I think that will be my take on it.
Right.
But I'll be open to give her a chance.
Absolutely. So we all these have to be individualized, though we know that there is an increased risk of prolonged labor due to inertia. There could be malposition, there could be impaired joint mobility, inelasticity of the soft tissues of the birth canal, and induction of labor. Some proponents of induction at 39 to 40 say that they can reduce the late stillbirth, because there are always increased chances of stillbirth in these women, and they can reduce the maternal risk due to ongoing pregnancy in women with preeclampsia, though there are insufficient data available for a routine induction in all elderly women more than 40 years of age. So we come on to our last question.
Ma'am, sorry to interrupt, ma'am.
1 minute, last 1 minute only, Dr. Deepika. Just,
okay.
I think
Right,
Dr. Poonam can take this question. This is the last one about the lactation issues and the risk of puerperal psychosis in these women. Dr. Poonam, ma'am.
Yeah. See, lactation issues are as good as in any other woman. So we have to, counsel them for breastfeeding from the very beginning only, and that sorts out, and they have to be given moral support and encouragement by the staff as well as the doctor. And then they can be started on drugs if the the lactation is not happening properly. Then regarding the puerperal psychosis, I cannot say that it's more common in the elderly women, but it all depends upon their previous history also. we have to take. If there is any history of psychosis in the past, or any family history of psychosis, or any like their family issues or stressful conditions at home. But if it happens, then it has to be taken very seriously. The mental condition has to be assessed. The counseling has to be done by a psychologist. In all these women prior to ERT also, they are sent to a psychologist or a psychiatrist for an evaluation for their mental health. And then we take them for ERT cycles. And definitely the pregnancy remains a very stressful condition for all 9 months. So again, postpartum also, they can take a psychologist for a counseling, and they can be put on some anti-anxiety, antidepressants if they are going into some depression or are facing some anxiety issues. And plus family support is very important. So that is all I would like to comment.
Absolutely, you've covered everything, ma'am. And in fact,
I would like to add two lines to this. Puerperal psychosis is a psychiatric emergency, and we should deal it with the psychiatric as early as possible. Isolate baby from the mother and give it to some caretaker so that the harm to the baby and mother is decreased. And except lithium, all SSRIs, clonazepam and all are safe. Discuss the breastfeeding issue. Always the antipsychotic medicine has to be given after feeding. There has to be done an adequate spacing between the feed and the medicine. So, and she has to be helped with the caretaker till the patient resolves back to normal. Because सबसे important, it is a very serious emergency sometimes.
So we may ignore it, but it can be very serious, and a timely and a very urgent help is something that Dr. Ritu has stressed. So it is very important in these cases. The baby may be harmed sometimes in these cases. And as Dr. Poonam said, a counselor is very important. So in ART, we have to have a counselor in all our clinics these days, and a pre-IVF, during IVF, during pregnancy, the counseling part definitely helps in these cases. So all is not gloomy in these women. Increasing maternal age is associated with improved health and development for children up to 5 years of age. So it was found that the children of older parents have certain benefits, including the devotion, the patience, the attention of their parents, as well as the emotional and the financial stability. So they actually prove to be good parents, better parents than the younger lot. So it is all not all that
mature. They are more mature.
They are more mature. They have the emotional and the financial stability. They have the patience. So they can take care of the kids better. So that is some positive side to it, and it is certainly possible for elderly women to conceive, have healthy pregnancies, to bear healthy babies, and advanced ages should not be a reason to abstain them from becoming pregnant, but it does carry increased risk. It should be discussed, and it should be carefully monitored with the couple. So thank you all my panelists. Thank you Dr. Sonia ma'am, Dr. Poonam Lumba, Dr. Neeru, Dr. Seema Mittal, Dr. Rakhi Malhotra, Dr. Ritu Jain, and Dr. Kalra. Thank you so much for your interaction, and I hope we have been able to bring out certain important points from this discussion. Thank you, everybody.
Thank you, Jyoti. Thank you, everyone.
Thank you. Over to you, Dr. Deepika.
So, ma'am, it's a short sponsored break. So with a very good quote from the Socrates, true knowledge exists knowing that you know nothing. So with that, we could move to our next session.
Our eminent speaker is Dr. J.B. Sharma. He is connecting us from US and going to speak on anemia. And everyone knows him very well. He is chairperson, Urogynecology Committee, FOXY, Professor Gyneops, in charge Urogyne AIMS. He has more than 360 publications to his credit. Editor, Indian Obs and Gyne, and published textbooks and trained in urology in King College Hospital. Welcome, sir. Welcome, Dr. J.B. Sharma.
Thank you very much, madam, and I thank the organizers. It's actually 2 o'clock here, but yeah, I'll try to do justice. So can my slides be played from there? And I congratulate the host for organizing such a good conference. So my topic is basically, mothers die because anemia can be one of the important causes of them. Anemia may not directly cause death, but it causes death indirectly, through by complicating things. So Dr. Agni wanted me to talk a little bit about injectable iron. So just general comments about anemia. We know that this is reduction in total circulating red cell mass below normal limits, but traditionally we call it less than 11 gram per deciliter hemoglobin by WHO definition, or less than 11 gram in first and third trimester and 10.5 in second trimester according to CTC. But generally we take 11 gram as a cutoff point. So anemia is very, very important, and we are seeing a tip of iceberg only because many patients remain undiagnosed or they have got low ferritin levels. So basically they may not be obviously anemic, but they will become anemic under certain conditions like pregnancy, purpura, and other conditions. Next, please. Yeah, so we know that is the most common medical disorder of pregnancy is anemia, and World Health Organization calculates almost 40% of pregnant women worldwide are anemic, and in India incidence is much higher, almost 80 to 90% in some areas. Next, please. Okay, so prevalence of anemia in pregnant women in India increased marginally from 50% in 2015 to now almost 52% in the last survey, and 58% of women who are breastfeeding in India are anemic. So both in purpura as well as in pregnancy. And why does India belong to high prevalence region from anemia and pregnancy? Because of poor eating habits, early onset childbearing, high parity, short inter-pregnancy interval, lack of accessible healthcare facilities, hookworm infestation, H. pylori infection, malaria, deficiency of iron in soil, hemoglobinopathy. These can be the various causes of low hemoglobin. Next, please. So we know iron deficiency anemia is the most common nutritional deficiency out of all. Folate, B12 are also important. Then pregnancy is a state of negative iron balance, and only 10 to 15% of total dietary iron is absorbed. So that's why they have to take higher iron. And anemia is the late indicator of iron deficiency. So estimated prevalence of iron deficiency is 2.5 times that of anemia. So that means much more as a whole. Next, please. Yeah. So normally, traditionally, whenever we get a patient of, normally in like Western countries, they don't prescribe iron. They prescribe iron only to anemic patients. But in India, and third world countries, all patients during pregnancy are prescribed up to 12 weeks of pregnancy oral iron, 100 milligram, 60 to 100 milligram elemental iron per day for prophylactic purposes. And if they are anemic, that means less than 11 grams, then we give them about 200 milligram per day. That means 2 to 3 tablets a day if they are 60 milligram. So advantages of oral iron is cheap, easy to administer, no hypersensitivity reactions usually, but disadvantage are GI intolerance. So GI intolerance is quite common with oral iron therapy and poorly absorbed, and there's variable absorption rates because of inflammation, dietary and factors, etc. And there's difficulty in replenishing stores. So that's why, the oral iron has been there for 50 years, but the incidence of anemia remains high. So we need to think of other things. And these are the various iron preparations like ferrous sulfate traditionally available free of cost in government hospital, ferrous gluconate, ferrous fumarate, ascorbate, bisglycinate, succinate, carbonyl iron, ferrous ammonium citrate, iron polymaltose, liposomal iron has also become available. So simple ferrous sulfate available free of cost in government hospital can be given, and those patients who can tolerate results are quite good. But those patients who can't tolerate, then you can give iron ascorbate, but then the cost becomes high. There's 6 to 8 rupees. Similarly, carbonyl iron and all, so they can be given to those patients. So I feel that initially start the simple preparation, and if patient is not able to tolerate, then you can go to the more expensive preparation. And next, please. Now, but unfortunately, in spite of iron being available for 50 years, the incidence remains high. So parental iron originally used to be like, would used to cause sensitivity reactions. So we used to avoid it. But now we know that indications are there. It is when the patient is intolerant to oral iron or no response to oral iron, and advanced pregnancy, severe anemia, patients, on erythropoietin therapy. So then we have to give. So in parental iron, basically we have to confirm the diagnosis of iron deficiency anemia. Adequate supervision for management of anaphylactic reactions has to be there. Stop oral iron about a day before it, and sensitivity testing is usually recommended for traditional iron, but for iron sucrose and FCM it is not recommended. And these days we are using only iron sucrose and ferric carboxymaltose. Other irons we are not used. So that means we don't now do iron sensitivity. But if patient is allergic, then definitely we avoid any sort of iron that way. Okay, and these the various reactions can be chest pain, rigor chills, hypotension, dyspnea, hemolysis, and anaphylaxis. Next, please. Yeah. So basically what we do, iron requirement in milligram we calculate, and we use with the Ganjoni's formula. That means target hemoglobin. Suppose we want hemoglobin to be usually taken up to 14 grams minus actual hemoglobin. So patient hemoglobin is exposed is 6. So you can say, 14 minus 6, 8. And then you multiply it by 2.4, and pre-pregnancy body weight, that suppose 50 kg. So like that you can calculate, and we do. So 1000 milligram is added to this to replenish stores. So suppose your amount comes to be 1000 milligram, you add another 1000 milligram so that we can take out the stores also. So like total we calculated 2000 milligram. A very simple formula is there. Like, usually for one gram of hemoglobin, we need 250 milligram of elemental iron. So suppose patient's hemoglobin is like 6. So we need to take it to say 14. So 6 plus 8, 14. So 8 into 250 like that. So almost 2000 milligram iron requirement. That's a simple formula. Target hemoglobin we want is 14 grams. That's why we calculate from 14 grams, not from 11 or 12. Next, please. So now we have calculated like 12 and say 2000 milligrams. So then we can divide it into further, and we discuss that. So intramuscular iron, the iron dextron not recommended anymore. So these days we are using only intravenous iron and only 2 preparations, that iron sucrose and ferric carboxymaltose. Okay, these are those. So the iron sucrose available as various brand name, for iron, etc. Iron sucrose. So iron dextron, ferric carboxymaltose. Others are just to complete the list, but we are using. I want to discuss only iron sucrose and ferric carboxymaltose. Next slide, please. Okay, so intravenous iron is given these days, very, very safe. So these are the various preparations of that. I don't want to go into detail, but type 1 iron, type 2 iron, type 1 iron. So depending on that, but I concentrate only on iron sucrose and iron carboxymaltose. Next slide, please. Yeah, so I just want to say, so basically iron sucrose, all of you know that has routinely been given for last almost 5 to 6 years now. So like in this patient, we calculated the deficit to be 2000 milligrams suppose. So 2000 milligrams. So iron sucrose we can give up to 300 milligram a day, and you can't give more than 2 to 3 times a week. So usually like Monday, Thursday we give 300 milligram like that, and then patient comes, we give 300 milligram diluted in saline, and then or 15 to 20 minutes patient goes home, and then still we keep in the beginning we keep oxygen cylinder ready, adrenaline, hydrocortisone, and AV injection ready just in case. But usually accident don't happen, and after that they can be given in the OPD basis also. So yeah, usually it will take 2 to 3 weeks before full 2000 milligram can be given. So that is the drawback of iron sucrose, that you have to call the patient again and again, because you can't give more than 300 milligram in one time, and not more than 600 milligram over a week. While ferric carboxymaltose now has become available, and this is the study which we did and published in BMC, I think, our thesis. So we use 100 pregnant women were given, and like between 16 to 26 weeks, so hemoglobin was more than 6 and less than 10. They were taken. So we gave them either iron ferric carboxymaltose or iron sucrose, and we found that significant increased chances of raise in hemoglobin with the ferric carboxymaltose. So ferric carboxymaltose, usually we can give up to 1000 milligram a time. So like suppose the total deficit is only 1000 milligrams, so single dose is required. And now it is allowed by Government of India at the Ministry of Health. We can give carboxymaltose also during pregnancy. Initially, we were giving it only in perfusion. Next slide, please. So carboxymaltose also basically, you can say, like we give 1000 milligram and you dilute again it in 100 million saline and you give it over 15 to 20 minutes. And like initially we first dose we give in labor room and we just keep everything ready, adrenaline, hydrocortisone, avil, oxycylinder, just in case. But usually reaction does not happen. So what are the response to iron therapy? Basically improvement in symptoms, improved appetite, increase in reticulocyte count over 7 to 10 days, and rise in hemoglobin after 2 weeks, and hemoglobin reaches normal levels by 6 to 8 weeks. If no significant improvement occur in 3 weeks, then we need to diagnose it properly. So this is very important. So just in the end, I want to say that now either only two. So in fact, there has been some tenders, just like we are given a tetanus toxoid injection to the patient. So is it possible that those patients who can't tolerate oral iron, at least we can give them just 1000 milligram of carboxymaltose just once or twice in whole pregnancy? That is good enough. Recently, I had a doctor, daughter of a doctor, herself a gynae, not a gynae, I think, yeah, she's a doctor. I'm not sure whether she was a gynae or something. So her hemoglobin dropped to 8 gram in pregnancy, and then she was not a good eater and couldn't tolerate any iron. Tried her every oral iron. Ultimately, I calculated that we need to give her 2000 milligram. So I gave her 1000 milligram ferric carboxymaltose, and then after that her hemoglobin increased to like 11 gram, just in over a week's time, from 8 to 11. So I didn't give her second dose, and we just gave her oral iron. So carboxymaltose is a very, very useful molecule. Up to 1000 milligram can be given easily at one time. And in case of purpurium, you can, before discharging the patient, your hemoglobin of the patient 11 less than that. So we are routinely giving 1000 milligram of carboxymaltose to the patient. And another role I'm finding is that those patients of like placenta increta or other conditions, so we are giving them, carboxymaltose. We are raising their hemoglobin to 13 or 14 gram, and sometimes we even give erythropoietin, like 18,000 units of erythropoietin plus 1000 to 2000 milligram of carboxymaltose. So we raise their hemoglobin to 14 gram before pregnancy, and then when we are doing cesarean hysterectomy or other procedure on them, then the need of blood transfusion can be reduced almost by 50 to 60%. So that is one way more. So again, in the end, I want to say that iron sucrose 300 milligram twice a week for like 2 to 3 weeks you can give, or carboxymaltose can be given very safe, and only single dose is usually required. Thank you very much.
Thank you, Dr. J.B. Sharma, for your wonderful presentation on anemia and IV iron. Thank you so much.
I kept it very small so that
because you are connecting from US, that's why. Okay, thank you so much. Thank you. So our next session is keynote addresses by Dr. Ajay Mane on medico-legal issues in obstetrics. Presently, he is Chairperson Website Committee AMOGS, Maharashtra State, Chairperson Adolescent Health Education Committee AMOGS twice, Chairperson Sexual Medicine Committee FOXI. He has many publications. Superintendent MGM Medical College, Aurangabad. Welcome, Dr. Ajay Mane. Over to you.
Thank you, madam. Thank you, Saroj, madam. This is my biodata. Just add to my biodata. I'm a medical legal consultant since 18 years for free of cost for only FOXI members and doctors. I don't give advice to patients, give advice to only doctors. Okay. And my sincere gratitude to Dr. Ragini Agrawal ma'am, who have given order me to be here. She is very senior fellow and mentor to me from North India. Thank you, Dr. Jyoti Malik ma'am, who is secretary, and Dr. Saroj Kumar ma'am, who is treasurer. I convey my gratitude to Dr. Promila Malik, past president Gurgaon Society. Then I convey my gratitude to very senior friends of mine, Dr. Mitra Saxena ma'am, Dr. Savita Singhal ji, Dr. Vibha Dua ji, Dr. Nisha Kapoor ji, Dr. Kamla Bhardwaj ji, and Dr. Chandan Kachru ma'am, all conveners, and Haryana Association of Obstetrics and Gynecology and organizers of Abhilasha. Thank you very much. Now we move on to the topic. So the situation: patient came with a pregnancy of 17 weeks, first time, and her age is 17 years. What next? 17 weeks is no problem for us, but the age is 17 years with pregnancy is a problem. So the POXO Act applies here. Means the protection of child from sexual offense is the long form. Many of the consultants say POSCO. It is a POXO Act, and in the POXO Act, we need to inform police whenever a lady or a girl comes with a pregnancy who is less than 18 years completed. Not started 18 years. Completed 18 years is a major by definition in India. So we need to inform police. Otherwise, we are liable for a punishment of 6 months imprisonment if we don't inform police. So that is the provision. So inform police, have and follow the protocols, safe documentation, and keep it with you. Okay. Next question. Do we need a consent for labor? Can a patient give consent who is in active stage of labor and pains during pains? And can a relative give consent for the patients? And the answers are, do we need a consent for labor? Yes, obviously it is very much needed. Can a patient give consent who is in active stage of labor and pains? No, because in definition of the consent, the sound mind and the sound body is needed. So here the patient is in agony, she is under pain. Whenever a patient is under pain or any under influence of any medicine or any anesthetic drug, she cannot give the signature or the consent. So can a relative give consent for the patient? Yes, in good faith, a near relative under section of IPC 88, don't remember that, but a near relative can give the signature on behalf of the patient in a certain situation. But if the patient is registered with you, take the consent for a normal labor and if needed for cesarean section in last antenatal checkup visit, that can be taken, and it is given in uniform consent for book in Foxy, page 95 to 104 book. It is very nice consent. Go through that. All details are given. What to be done, what not to be done, consequences, if, but, plus, minus, negative, all points, everything, morbidity of nature of life, and this is undertaking, signature of the patient. The last part, sign of patient, doctor, and witness of two, one from patient side, one from doctor side. Why? Because signature of doctor and signature of patient is needed. As it is a contract, both signature are there, then and then only it is a complete consent form. If the doctor is not signing that, it is an incomplete form. So signature of the patient, doctor, and two witnesses. Okay. Then next situation, IUFD. Okay, G4P3L0 type 2 diabetes mellitus, very bad patient, presents at 39 weeks with IUFD on admission. Okay, this on arrival also, on arrival only the IUFD is found. Then what next? Explain properly the two, because we have seen in 2-3 cases the CMO or the doctor who is attending the patient in casualty or in the endo department did not tell and say कि नहीं इसको उठाओ यहाँ से जल्दी से आप दूसरे hospital लेके जाओ, and they took the patient to the other hospital, and on arrival at the other hospital they told कि it is IUFD. Then they sued the doctor कि during transit दूसरे हॉस्पिटल में उसको डेथ डिक्लेयर किया IUFD है, मतलब पहले हॉस्पिटल में उन्होंने कुछ बताया नहीं था, मींस the baby was alive. It is considered that the baby was alive, which was not true, but उन्होंने उनका रिकॉर्ड तैयार हो गया उनके अगेंस्ट. So don't do it. If it is IUFD, coolly sit properly, silently tell them scientific way, so that they will not get furious कि ऐसे हुआ ऐसे हुआ ऐसे हुआ. अगर if it is a registered patient with you, उसमें से क्या रहेगा? Did not come for checkup, did not get blood sugar done, did not take insulin as advice, did not maintain fetal movement count as advice. ये सब आपने अगर पहले से डॉक्यूमेंट किया है, so you are free, you are not negligent. But ये पेशेंट आपको फॉलो नहीं करती है जो अपने पेपर में ये पूरा लिखा है, so it is a contributory negligence, means negligence on the part of patient. You are safe here. Okay, so everything you need to write down on the paper, and whatever you write down is considered as a correct by the law, as you are an expert. Next situation, documents patient's non-compliance in the outpatient record. Primary with severe PIH presents at 39 weeks with IUFD on admission. What next? Same thing. Explain properly with truth. And what is the message? Do not come for checkup, get blood pressure done, treatment not taken properly, and fetal movement count not kept properly. That is again become a contributory negligence. Next situation. Patient is in PPH and you have not done the blood grouping prior, as patient was your regular ANC. Patient was registered with you coming for regular ANC checkup and you have not done blood group. Patient went in PPH. So is it negligence? Yes, it is 100% negligence. If patient succumbs, it becomes criminal negligence. If patient is saved, it becomes then civil negligence. The severity is less, it becomes a civil negligence. If severity is very more, it is a gross negligence. Then it becomes a criminal negligence. In civil negligence, you need to pay the compensation. But in criminal negligence, you need to pay the compensation as well as you will get a imprisonment up to 2 years. That is the That is provision for criminal negligence. Okay. Next, do we need consent for CS? Yes. Can a patient give consent? Same questions. Do we need a consent for cesarean section? That was the labor. Here cesarean section, 100% yes. Can a patient give consent who is in active labor for cesarean section? No. Can a relative give consent for the patient? Yes. Can a patient give oral consent? Yes, 100% yes. But if patient denies, we don't have any proof. That's why we are taking a written consent form. So patient is taken to operation theater in emergency, patient cannot give consent. So your assistant go to the near relatives who are standing there out of the labor room or the operation theater, and they may take the consent there, or your nursing staff may go explain everything and take the consent of the near relative. Okay. And one more thing, as I said in labor also, you can take the consent in prior, as the patient says, if I should be undergoing any emergency section or emergency operations, and I am not in the condition to give consent, so I appoint such and such person, his husband or the father or mother or father-in-law, mother-in-law, whosoever the name, one or two persons can give consent on behalf of. That can be done prior. Okay, that is safe method. Uniform consent for FOXY for cesarean section is 104, page number 104. They have explained all the things, 1, 2, 3, their benefit, alternative, consequences, outline, substantial risk. Consent for anesthesia is different. It is a different part. You need to have two consents, one for procedure, one for anesthesia. It is damn sure that you need a separate consent for anesthesia. You have to have a separate notes also by the anesthesiologist on the paper, and separate notes by the surgeon for the procedure, as well separate consent for the procedure, separate consent for the anesthesia. And I have seen so many cases that kindly match the timing of the surgeon and the anesthesia. At 6:30, surgeon says patient was stable, and 6:30 anesthesia says patient was pulseless. And this disparity will take the case against the doctors. Okay, the advocates are very clever. The judicial system sees, oh, there is disparity, means they are hiding something, so it goes against you. So have a separate consent. Okay. And notes by email. Emergency section, it is given. Undertaking. Okay. Next question. How many years do we need to maintain records of labor? 21 years. Mind it. Any procedure, 7 years. In insurance also, it needs 7 years. For MTP, 5 years. For PCP and DT, 2 years. And for Consumer Protection Act, it is a 2 years. But in view of Consumer Protection Act, in Abomination Act, we need to keep it for 5 years. But in CPA, in amendment in 2019, they made an arrangement that patient can sue the doctor within 2 years. But if the CPA judge thinks that the case is to be admissible, it is very gross negligence by the doctor, she may get the case admitted after 4 years also. So we need to maintain the record at least for 5 years. That is for benefit of our doctor fraternity. Okay. Next situation. Unregistered patient came in early labor, not ready for any investigations, and asked for admission and delivery. Can we deny? Yes, because the patient is first thing unregistered, so we don't have any moral duty. Second thing, it is early labor, so we can very well send the patient. How to send? Send with proper documentation. What documentation? Consent, the referral sheet, and the treatment you have given is written to be on one sheet and to be given to the patient. And if certain situations, the doctor or the assistant or nursing staff should accompany the patient. Next situation, registered patient. Okay, there is a moral duty to take the patients because she is registered with you. Registered patient with routine follow-up came at full term in labor and insisting for normal delivery only and not ready for CS if needed, as the fetal heart rate is fluctuating. 120 से कम है, 160 से ज्यादा है, बीच में कम ज्यादा हो रहे हैं, और वो बोल रही कि दिन दिन हिलता नहीं है कल से. So what is the procedure then? Record proper finding. ये जो finding पूरी मैंने बताई आपको पेपर पे लिखने. These are the findings and they are considered as correct because you are expert. Second is partogram. It is a legal document. In partogram, you can see the descent, the cervical dilatation, displacement, the contractions, उसकी nature कैसा है, liker कैसा है, उसका blood pressure कितना है, input, output, everything in one look you can get from partogram, and we can prove that at this situation, this point at 4:30, we advise patient cesarean section, immediately patient denied. कौन से point पे depend हमने बताया था 1, 2, 3, 4, 5. We can say. So partogram is very important document. Start writing part of God if you have not started yet. Okay, then fetal record CTG is to be maintained. Negative consent. What is negative consent? Patient आपको ये CS का consent नहीं दे रहा है, अगर जरूरत नहीं तो उसको बोलना ठीक है हमने आपको पूरा समझाया है, ये एक्सप्लेन किया है, आपने बोलना है कि ओके फाइन, जो भी कॉन्सिक्वेंसेस होंगे आई विल बी रिस्पांसिबल फॉर दैट, आई एम नॉट रेडी फॉर द सिजेरियन सेक्शन, दैट इज नेगेटिव कंसेंट. ये आप पेशेंट से ले लीजिए एंड आपके पास रख लीजिए एंड फॉलो ऑल प्रोटोकॉल्स. इफ समथिंग गोज रॉन्ग यू नीड टू प्रोड्यूस द प्रोटोकॉल. ये प्रोटोकॉल है, ये हमारे डॉक्यूमेंट है, हमने प्रोटोकॉल से काम किया, फिनिश. यू आर नॉट नेग्लिजेंट if you have worked according to the protocol. Next situation, patient not progressing well in labor and not ready for a CS, routine scene, and not ready to shift also. That is also a routine scene. हम जाएंगे भी नहीं, सीजर भी नहीं कर देंगे, आप नॉर्मल को कैसा करेंगे? अपने हाथ में है. We are not God, no? तो क्या करेंगे उसमें? Again explain all consequences, keep all records. मैंने अभी पिछले केस में बताया वैसा. Denial of shifting and negative consent. Denial of shifting का भी कंसेंट लेना पड़ेगा. हम नहीं जा रहे, we are not ready for that. पेशेंट अगर नहीं तैयार है ये सिचुएशन में, नेगेटिव कंसेंट देने को भी अगर तैयार नहीं है, सो यू कैन टेक अ कंसेंट और द अंडरटेकिंग फ्रॉम द नेबरिंग पेशेंट और द रिलेटिव और द पर्सन हु इज थर्ड पर्सन इन हॉस्पिटल एंड हु इज स्टैंडिंग देयर कि ये सब डॉक्टर साहब ने मेरे सामने इनको बताया है, फिर भी पेशेंट तैयार नहीं है एंड दिस ऑल थिंग डन इन फ्रंट ऑफ मी, उसका साइन ले लीजिए. एक ऑप्शन ये है. और दूसरा ऑप्शन एक है कि आपका जो सीसीटीवी कैमरा है उसमें आपका रिकॉर्डिंग मेथड रखिए, उसमें ऑडियो रिकॉर्डिंग भी रखिए. सो इट इज हेल्पफुल टू यू एज यू आर एक्सप्लेनिंग टू द पेशेंट. सो एवरीथिंग इज रिकॉर्डेड, द एक्शन इज रिकॉर्डेड, द वर्ड्स आर रिकॉर्डेड, यू कैन प्रोड्यूस दैट रिकॉर्डिंग इन द कोर्ट ऑफ लॉ. दैट सी, अगर रिटर्न फॉर्मेट में पेशेंट देने को तैयार ही नहीं था, वो तो बोले मैं कहीं भी साइन नहीं करूंगा, बट दिस इज द रिकॉर्डिंग ऑफ द सेम डे एंड इन माय कंसल्टिंग रूम आई हैव एक्सप्लेन्ड एवरीथिंग. सो यू आर सेफ. सो डू इट. ओके. नेक्स्ट, हैंड प्रोलैप्स. क्या करेंगे उसमें? काउंसिल अबाउट द कॉन्सिक्वेंसेस डॉक्यूमेंटेड, उसमें हारोस पाल्सी, ब्रैकियल प्लेक्सस, क्या क्या सब बता दो उनको, सिग्नेचर ऑफ विटनेस ले लो, कंसेंट ऑफ प्रोसीजर एंड pediatrician is must, because in that situation nowadays everybody is having pediatrician for normal labor also. That is a good thing that one expert hand is there with you. So court consider that okay, दोनों expert है उसमें, so nothing was wrong and every positive thing must have been followed by these two experts. So it is considered. Okay, and take proper consultation of other faculty, neurologist है या तो फिर ऑर्थोपेडिक सर्जन व्हाट नॉट. कॉर्ड प्रोलैप्स, उसमें भी वही सेम सिचुएशन है. आपको कॉर्ड को पल्सेशन देखने पड़ेंगे, पेल्विस और हेड के बीच में उसको आके उसका पल्सेशन कम ना हो, उसका ऑक्सीजन कम ना हो, ये सब देखना पड़ेगा आपको. और वहां से यू नीड टू शिफ्ट द पेशेंट वेरी अर्जेंटली. उस कंडीशन में आप कंसेंट नहीं ले सकते, पेशेंट भी कंसेंट नहीं दे सकता, तो आपका असिस्टेंट फिर गो टू द रिलेटिव एंड बोलना पड़ेगा ये कंडीशन है, हम ले रहे, उनका साइन ले लीजिए. दैट इज एक्सेप्टेड. अनलेस एंड अनटिल life threatening condition is there, you need everything you need is a consent for any procedure. If it is a life threatening condition, in that condition you can go without consent for the benefit of patient, but the onus of proving the condition if something goes wrong lies on you. अगर कुछ उसमें कम ज्यादा हुआ तो पेशेंट अगर सू कर देता, आपको देखना बताना पड़ेगा कि ये कंडीशन थी, बहुत पिपेज था, 3 लीटर गया था, तो मुझे तो कंसेंट लेने को रिलेटिव भी था नहीं, तो आई हैव टू रश देयर, तो मैंने ये कर लिया. पेशेंट बच गया तो अच्छा है, नहीं बचा तो भी आपको प्रोटोकॉल फॉलो किया कि वो आपको बताना. ओके. कॉर्ड प्लस में भी ये सब पूरा करना पड़ेगा. प्रीवियस एलिसिस, ये रूटीन कंडीशन है आजकल, क्योंकि एलिसिस का रेट बढ़ रहा है. वो क्यों बढ़ रहा है हम सब लोगों को मालूम है, पर मॉर्टेलिटी और मॉर्बिडिटी कम हो गई ये कोई नहीं बताता. सीजर का रेट बढ़ रहा है इतना ही बताते हैं, पर उसकी वजह से फिर प्लासेंटा प्रीविया के केसेस बढ़ रहे, इनक्रीटा के केसेस बढ़ रहे. ओके, एवरीथिंग इज ओके, बट मैटरनल मॉर्टेलिटी कम हुई ये क्यों नहीं कंसिडर करते लोग बाकी, है ना. तो पहले कितना था मैटरनल मॉर्टेलिटी मॉर्बिडिटी, आज कितना है. रादर फिटस का और ये न्यूबॉर्न का भी मॉर्बिडिटी कम हुआ, ये भी देखना चाहिए ना उसमें. सो नथिंग टू वरी अबाउट, गो फॉर सीजर वेयर इट इज नीडेड. It is said by WHO also. Okay, उनको ऑप्शन दीजिए, उनको वो पढ़ के आते हैं, सर वो विवेक पढ़ा हमने नेट पे और वो बोल रहे कि हो सकता है तो आप करो. They dictate you. Okay, what you should do at that condition, उनको ऑप्शन दो, उनको बोलना ये 1 thing या 2 thing. Counsel all positive and negative points. इसमें ये हो सकता है, डेसेंस भी हो सकता है, रप्चर भी हो सकता है, न्यूनेटल मॉर्बिडिटी हो सकती है, मॉर्टेलिटी हो सकती है, बच्चों मर सकता है, मदर का भी जान को खतरा हो सकता है, नहीं भी हो सकता है. +2 नाउ यू डिसाइड. ओके, लेट देम डिसाइड. उनको डराओ मत, अरे ये नहीं किया तो खत्म हो गया बात, ऐसा नहीं करने का. उनको जस्ट 1 2 3 4 5 ऑल पॉइंट्स, सिट क्वाइटली, आई गिव यू 10 minutes एंड थिंक एंड बोलो लाइकवाइज, एंड एवरीथिंग मस्ट बी फेयर. कीप प्रॉपर नोट्स of short intervals. Routinely, what we do, पार्टोग्राम में तो बोला है कि 4 आवरली करो पीवी, यहाँ हम 2 घंटे को अगर करते होंगे, सपोज फर्स्ट स्टेज का लेट फेज है तो उसमें, है ना, तो यहाँ पे आप थोड़ा जल्दी जल्दी कीजिए, क्योंकि चांसेस रहते हैं। सेकंड ओपिनियन लिया तो सबसे बढ़िया, क्योंकि इफ समथिंग गोज रॉन्ग, कोर्ट कंसीडर्स दैट, अरे सेकंड ओपिनियन भी लिया, दोनों को सेम आया, फाइन, सो दे आर राइट. What Jacob-Matthew case gave us, it gave us a strong support of negligence cases में. उसमें कोर्ट ने क्या कहा, so long as a doctor follows a practice acceptable to the medical profession of that day, he cannot be held liable for negligence. जो रूटीन में होना चाहिए वो अगर डॉक्टर करता है तो नेग्लिजेंट नहीं है, ऐसा सुप्रीम कोर्ट ने बोला, दैट्स फिनिश. उसके पहले तो किसी को भी नेग्लिजेंट बोलते थे. सो व्हाट इज द थिंग, कीप पेपर रेडी, ड्यूली कंप्लीटेड. आप पुलिस कभी भी आपको आके बोल सकती है मुझे कब पेपर चाहिए, आपके पास 36 आवर्स से पेपर कंप्लीट करने के लिए, पर मेनी टाइम्स पुलिस से नहीं, अभी हम पेपर लेके जा रहे हैं, तो लेके जाते. तो एट दैट मोमेंट व्हाट यू शुड डू, इनकम्प्लीट पेपर के नीचे ऐसे एक लाइन मार के वो पेज पे लिखना है कि दिस पेपर इज इनकम्प्लीट, पुलिस डिड नॉट गिव टाइम टू कंप्लीट द पेपर. आपका पेशेंट का ट्रीटमेंट करना जरूरी है, ना कि पेपर लिखना जरूरी है. कोर्ट कंसिडर्स, लॉ कंसिडर्स 36 आवर्स आपको दिए उसी के लिए, पर ये पुलिस कंसिडर नहीं करती. उनको तो हाँ कर रहे हैं वहां की, उस वक्त वो रोप झाड़ने के लिए आते हैं वहां पे. तो बहुत सारे पुलिस अच्छी भी होते हैं, ओके ठीक है, आप रूल के हिसाब से कीजिए, दीजिए हमको पेपर चाहिए पर उनको, तो आप पेपर कंप्लीट कीजिए. उसमें लिखिए कि दिस इज इनकम्प्लीट पेपर. उसका मतलब क्या हुआ कि आपको पेपर कंप्लीट करने को टाइम नहीं मिला, सो यू हैव डन मेनी थिंग्स बट यू हैव नॉट रिटन. व्हाट रूटीनली कंसिडर्ड, यू हैव नॉट रिटन द थिंग्स एंड यू हैव डन द थिंग्स, बट दोज आर कंसिडर्ड इन द कोर्ट ऑफ लॉ एज नॉट डन, बिकॉज आपने लिखा नहीं. सो इसलिए ये पेपर इनकम्प्लीट है बोल के एक सेंटेंस लिखना नीचे, उसको साइन करो, टाइम डालो, डेट. ओके, पेज नंबर डालना कंपल्सरी, क्योंकि उसमें से 1-2 पेपर अगर मिस हो गए तो आपके बहुत सारे फाइंडिंग चल जाएगी. तो पेज नंबर डाल के देना है को, और फोटोकॉपी देना है, ओरिजिनल कभी भी नहीं देना है. ओरिजिनल आपके पास सिर्फ टिल द एंड ऑफ द केस, बाद में मिलेगा. ओके, एक्सप्लेन द रिलेटिव इन अ साइंटिफिक, उनको बोलना कि साइंटिफिक 1 2 3 4 5 6 90% वो सुन लेते हैं. आउट ऑफ कोर्ट सेटलमेंट कैन बी एन ऑप्शन. इसमें लोक अदालत है, आप कोर्ट में जाइए, पेशेंट आता है वहां से, दोनों एक्सप्लेन कीजिए, वो रिटायर्ड जज रहते हैं डिस्ट्रिक्ट लेवल पे, एंड ही डिसाइड द कॉम्पेंसेशन. कॉम्पेंसेशन शुड बी गिवन थ्रू कोर्ट, एंड एक बार वो कॉम्पेंसेशन कोर्ट के थ्रू दिया इसमें लोक अदालत में, तो वो आपके कोई भी दुनिया के कोर्ट में आपके अगेंस्ट केस नहीं कर सकता है. फाइन, सो लोक अदालत इज बेस्ट ऑप्शन. नहीं तो क्या है, वो 10 लाख 30 लाख 40 लाख वकील साहब बहुत पैसे लेते हैं आजकल. सॉरी, डॉक्टर मस्ट हैव अ स्ट्रांग मेडिकल इंडेमनिटी. कम से कम 1 करोड़ का मेडिकल इंडेमनिटी लीजिए और 3 to 4 इंसिडेंसेस का लीजिए. हम लोग साइन करना पड़ता है, एजेंट होता है, यहाँ साइन हो गया ना, चेक दे दो इसको. शाम को मुझे पढ़ना है, कितने कवर किए बताओ, क्लास किधर है. अच्छा, उसमें दूसरी एक बात है कि आपका स्टाफ भी उसमें कवर होना चाहिए. नहीं तो स्टाफ ने अगर कुछ कर दिया, गलती, इंजेक्शन गलत दे दिया, पेशेंट एक्सपायर हो गया, तो दैट इज अ क्रिमिनल लायबिलिटी. क्रिमिनल लायबिलिटी नेवर शिफ्ट्स फ्रॉम दैट एम्प्लॉय टू यू. यू आर विकैरियस लायबिलिटी रह सकती है, पर क्रिमिनल लायबिलिटी नेवर शिफ्ट्स. ओके, सो उसका आपका स्टाफ भी उसमें कवर होना चाहिए, नहीं तो स्टाफ का जो कॉम्पेंसेशन है उसके लिए आपको किसी से देना पड़ेगा. सो मेडिकल इंडेमनिटी का थोड़ा सा देखना जरूरी है. Section 304A is very important because it is a death by negligence. 304 है culpable homicide, उनका चार्ज है, तो ये है कि नहीं है आपके केस में देखना जरूरी है आपको, ठीक है ना, ये होना चाहिए. So it is a safe. Defense of a doctor contributed negligence with patient के पार्ट पे है. Duty discharge according to prevailing standards वो बताया मैंने, and error of judgment which will not help you. Error of judgment is different and misdiagnosis is different, और undiagnosis is different. एक पेशेंट है, आपने सीजर कर दिया, शिफ्ट कर दिया रूम में, और उसको 2 घंटे देखा ही नहीं, पेशेंट वेंट टू PPH एंड शॉक. दैट इज नॉट एरर ऑफ जजमेंट, दैट इज मिसडायग्नोसिस और अनडायग्नोस्ड. एरर ऑफ जजमेंट क्या है, 2-3 चीजें नजदीक है, उसमें आप थोड़ा मिस कर गए, दैट इज एरर ऑफ जजमेंट, दैट इज कंसिडर्ड बाय कोर्ट. बट मिसडायग्नोसिस, अनडायग्नोसिस और नॉट ट्रीटिंग द पेशेंट आफ्टर डायग्नोसिस इज कंसिडर्ड एज अ negligence. So what is precaution against negligence? Obtain written informed consent, develop good rapport with the patients, relatives, and our colleagues, and never guarantee 100%. It is given by a quack. Okay. So anticipate complications during and after procedure and be ready if it takes place. हम गाड़ी चलाते कैसे कहते हैं, ये सामने वाला रुक जाएगा, ये इधर से घुसेगा, ये पीछे वाला आके ठोक देगा, ये कैसा एंटिसिपेट करते. वैसा एक पेशेंट को सोचना है, इस वाला क्या है, नॉर्मल लेवल का पेशेंट है ना, ये बीच में जा सकता है, कभी भी ये कन्वर्जन में मार सकता है. अगर अनरजिस्टर्ड है, रजिस्टर्ड है तो हम लोगों को मालूम रहता है कि कहाँ तक जाएगा वो. सो अकॉर्डिंगली यू कीप रेडी. कीप ब्लड रेडी इफ पेशेंट इज नेगेटिव. कुछ भी नहीं है उसमें, फिर भी एक बैग तो आप रेडी करके रख ही दीजिए उसमें। बैड इंसिडेंसेस भी आप एंटिसिपेट करो, क्योंकि रिलेटिव किस तरह से रिएक्ट करेंगे वी डोंट नो, रिलेटिव भी कैसे है। एंड कीप डॉक्यूमेंटेशन अबाउट स्पाटोग्राम, नथिंग वाज मिस्ड। ये फॉक्सी, आईसीओजी, एसीओजी, डब्ल्यूएचओ, आरसीओजी, ये इनके प्रोटोकॉल्स किसी का भी एक का करना है, सबका नहीं करना है मिक्स किचन। और तकरीबन 99% सबके सेम ही है, जीसीपीआर है फॉक्सी के, वो फॉलो करो तो दैट इज बेटर। डन एवरीथिंग अकॉर्डिंग टू प्रेजेंट सिचुएशन एंड ऑल कंसेंट एंड विद प्रॉपर डॉक्यूमेंट्स भी आपको मेंटेन करना है। प्रोटोकॉल्स, डॉक्यूमेंट, ट्रेन स्टाफ, ट्रेन एंड ड्रिल्स रेगुलरली, क्योंकि पीपीएच का पेशेंट आया तो इधर उधर से भागम दौड़ी शुरू हो जाती। फिर नई सिस्टर से बोलते सर मैं नहीं हूँ, मुझे नहीं मालूम वो प्रोफिडिन कहाँ रखा है, फ्रिज कहाँ है, वो दूसरी चीज कहाँ है, इंजेक्शन नहीं मिल रहे सर। तो सो उनका ड्रिल रेगुलर और ट्रेनिंग बहुत जरूरी है। हैव अ सिस्टम, आदमी स्टिपुलेट करके रखिए उसमें, एंड कीप गुड रिलेशन विद योर कलीग्स, बिकॉज कलीग्स ही आपको बचाए। Difference between PCPD and MTP: one consultant may have many centers for MTP, which is not possible in PCPD. Only 2 centers in one district. MTP में आप कितने भी कर सकते हो। One may perform MTP at any recognized approved center in India. कहीं भी जा सकते हैं। मैं ज्योति मैडम के हॉस्पिटल में जाके कर सकता हूँ, वो भी मेरे हॉस्पिटल में आके कर सकते हैं, कोई प्रॉब्लम नहीं है। पर अगर स्टेट चेंज होता है तो स्टेट को इन्फॉर्म करना है, स्टेट मेडिकल काउंसिल को। बाकी इंट्रास्टेट जो है वो इन्फॉर्म करने की जरूरत नहीं है। नो रेगुलर इंस्पेक्शन मेंशन इन लॉ फॉर एमटीपी सेंटर्स। तो जो पीसीपीडी में हर 3 महीने की इंस्पेक्शन है वो एमटीपी के लिए नहीं है, फिर भी आजकल आए के बाद देख लेते, पर नहीं है वो। नो रिन्यूअल, एमटीपी के लिए रिन्यूअल लाइफ लॉन्ग है, एक बार दे दिया। पीसीपीडी में हर 5 साल को है, आधी फीस के साथ में रिन्यूअल होता है। पीसीपीडी में जिसका नाम उसमें लिखा हुआ है 2 लोगों का, वही आएंगे, या 10 लोगों का नाम लिखो पर वही 10 लोग आएंगे, 11 आदमी नहीं आएंगे। या तो आप उन्होंने आपका नाम उसमें नहीं तो आप भी मशीन को हाथ नहीं लगा सकते। एमटीपी में वैसा नहीं, यू आर एमसीआई रिकॉग्नाइज्ड डिग्री होल्डर, आप कर सकते हो। ओके, नॉन बेलेबल, कॉग्निजेबल एंड नॉन कंपाउंडेबल। अब इसका मतलब बताता हूँ। नॉन बेलेबल मींस बेल मिल जाती है उसमें, पर वो कोर्ट के थ्रू मिलती है। बेलेबल में चौकी में मिल जाएगी। ओके, ये कोर्ट में पेश करने तक आपको बिहाइंड बार रहना पड़ेगा, दैट इज नॉन बेलेबल। कॉग्निजेबल मींस द इन्वेस्टिगेटिंग ऑफिसर कैन अरेस्ट and he can or she can start the investigation on his own, उसको मैजिस्ट्रेट के ऑर्डर की जरूरत नहीं है, that is a cognizable। and non compoundable means एक बार केस फाइल हो गई तो उसके एंड तक ही जाना पड़ेगा, नॉन रिटर्न वॉल। बाकी लोगों के जैसा नहीं कि हम कोर्ट सेटलमेंट करेंगे, हमारे दोनों को होगा जज साहब नमस्ते, थैंक यू वेरी मच फॉर योर परमिशन, ऐसा नहीं। यहाँ एक बार केस फाइल हो गई आपको एंड तक लड़ना ही पड़ेगा, दैट इज नॉन कंपाउंडेबल, उसमें आउट ऑफ कोर्ट सेटलमेंट नहीं होता है। ओके, एंड रिगरस इम्प्रिजनमेंट 2 to 7 years with fine or without fine, that is a MTP। and if needed I am always there, a phone call away। कभी भी आप इसका फोटो ले लीजिए, नंबर सेव कर लीजिए, ये मेल है। आई एम देयर फॉर फ्री ऑफ कॉस्ट एंड ओनली फॉर डॉक्टर्स, नेवर फॉर अ पेशेंट। ओके, वुमेन एम्पावरमेंट इन इजराइल उसके लिए है, ये वुमेन एम्पावरमेंट डॉक्टर दीपिका छेत्री। सैल्यूट टू दिस वुमन एंड सैल्यूट टू द ग्रेटेस्ट आर्मी ऑफ द वर्ल्ड। Salute to this chain, lowermost chain of the health system in India. They have 160 crore लोगों को किया है उन्होंने। देखो रनी बेटी, छोटा बच्चा, वैक्सीन कैरियर, great woman, and woman is always a great person। For the post of vice president Foxy, and vote for me. There are 2 posts in West Zone. Kindly consider me for 1 post and kindly vote for. Thank you very much. Thank you again, Ragini madam and Jyoti madam, for giving me the chance. Thank you very much.
Excellent.
Saroj madam.
Dr. Ajay.
Yeah.
As
Thank you,
always.
Ragini madam. Thank you. आप हो उधर?
I just joined. We are having NABH assessment in our hospital.
जी। Thank you madam. Thank you very much. Jyoti madam, thank you very much.
Thank you so much, Dr. Ajay, for your wonderful presentation, and many things we were not knowing and now we know. Thank you so much. And our next session is keynote address by Dr. Kanika Yadav. Doctor is going to speak on role of NIPS and microarray in abnormal pregnancy as diagnostic tool. Dr. Kanika is currently working in Modern Diagnostic and Research Center as clinical head genetics department. She did her post-graduation from Himalayan Institute of Medical Sciences, Dehradun. She further did professional training in genetics and genomics from Stanford University, USA, and specialized in prenatal and postnatal genetic screening and diagnosis. She is further pursuing her PhD in genetic profiling in breast cancer. Welcome, Dr. Kanika. And over to you.
Thank you, ma'am, for your kind words. And I thank Haryana Association of Obs and Gynae under the initiative Abhilasha to give me an opportunity to speak amongst the distinguished delegates. And I shall start my presentation. Good afternoon, everyone. Today I shall be discussing about role of NIPS and microarray testing as advanced screening and diagnostic tool in abnormal pregnancies. Antenatal period investigation can be broadly classified into various ultrasound investigations, routine investigations, and prenatal genetic screening tests. In prenatal genetic screening test comes the marker studies, which includes double, triple, quadruple marker, along with recently introduced pentamarker. And now, since a decade, a new test has also been introduced, which is non-invasive prenatal screening test. NIPT test helps in actually diagnosing the common syndromes like Down syndrome, trisomy 13, 18, but it is more specific than marker studies as it is a DNA-based testing. When we talk about the burden of genetic disorder in India, Down syndrome has second highest incidence. So many techniques and testing is actually focused towards reducing the incidence of Down syndrome pregnancy. Detection of fetal anomaly, as you all must be aware, can be broadly classified into non-invasive and invasive testing. The limitation with non-invasive testing is that though it is affordable, but it offers a very low accuracy. Invasive, though it is very accurate and is very sensitive, it carries a small risk of pregnancy loss or miscarriage after the procedure. So there was a lacuna to develop a non-invasive testing which offers similar accuracy as to that of invasive testing. And with that, there was a development of NIPT test. So when we talk about the timeline of development of NIPT testing, it was in the year 1997 when fetal DNA in the plasma was first identified, and various tests were started, which included bichromosome detection, RHD negative status of the fetus. And it was from the year 97 to 2011 then research was going on to on various platforms to launch this test for detection of Down syndrome mainly. And after 2011, this test was launched clinically, and now this test is being carried out in more than 60 countries, and they have started including single gene disorders on NIPT test as well. The research is now going on. One second. The research is now going on to perform whole genome sequencing on cell-free fetal DNA. So the technique of NIPT testing is broadly classified into two categories. One is counting method and one is genotyping method. In counting method, it is based upon amplification or sequencing of either the whole chromosome or specific region of the chromosome, and then the counts are being counted on to take a call for Down syndrome or trisomy 13 or 18. And another method is genotyping or SNP analysis based method. Cell-free fetal DNA actually is not from DNA, but it arises from the cell death of cytotrophoblastic cells of placenta. So it has both mother origin as well as the fetal origin. So the general indication of NIPT testing are high or borderline risk in marker tests, advanced age, which is more than 35 years, or if there's some family history of the same syndrome. So the most common technique that is being used is massive parallel shotgun sequencing, and where the cell-free DNA, which is a short base pair, 200 base pair fragments are there, and it is circulating in the mother plasma. So 95% of these fragments are actually derived from a maternal part, and only 5% are fetal part. So these short base pair fragments are amplified, and then they're sequenced, and then they're aligned to the reference genome sequence to identify it belongs to which chromosome. If the count for respective chromosome increases, then a call for trisomy is given, and if the count decreases, then a call for monosomy is given. General syndromes that are covered in NIPT are trisomy 21 and the Down syndrome, trisomy 18, 13, genome-wide aneuploidy detection ranging from chromosome 1 to 22, sex chromosome aneuploidy, and detection is also there. So the major advantage of NIPT is actually detection of sex chromosome aneuploidy, especially Klinefelter syndrome, as currently no non-invasive screening marker is actually present to detect these aneuploidy. And Klinefelter syndrome especially is diagnosed in adolescent stage or when the couple undergoes primary infertility testing. So here we can see that NIPT testing carries detection rate of more than 99%, especially for Down syndrome, and it is very high as compared to markers and ultrasound investigations. And when we compare the accuracy of NIPT along with other invasive method, it is almost similar to them. The pooled sensitivity of various aneuploidy detection ranging from trisomy 21 to other chromosomes is more than 99%, 99.5% for trisomy 21. And as we move from trisomy 21 to other chromosome aneuploidy detection, the sensitivity decreases. This sensitivity decreases because of difference in the GC region content of various chromosomes. But the major focus is that negative predictive value for all these conditions is approximately 99.9%. So when we say that this syndrome will not be present in the baby, that means we are approximately 99% sure that this syndrome will not be there. So various countries have their own guidelines and various hospital and gynecologists have their own preference. But generally, NIPT test is ordered when there is a high risk pregnancy is there, which can be if there is some abnormal screening test. If NIPT test comes out to be normal, then no further testing is required. But if it comes as a high risk positive, then the finding needs to be confirmed with amniocentesis or serious sampling. Recent ACOG guidelines recommend NIPT for all pregnancy regardless of risk or regardless of age. So just summarizing the advantages of NIPT test, it is safe as it is non-invasive, it offers higher accuracy, and the technique which is shotgun sequencing or the massive parallel sequencing, it can be done even in twins, surrogacy, egg donors. The other method, which is SNP genotyping, it cannot be done in twins, surrogacy, and the egg donors. And the major part is that it offers a peace of mind test, especially for the pregnancy where high-risk pregnancy cases are there or in IVF pregnancy. So who can have the test? If the gestation age is more than 10 weeks, and if the lady is having singleton or twin pregnancy, they can undergo the test. And the unsuitable candidates for NIPT testing are candidates for having cancer or autoimmune diseases, blood transfusion cases, trisomy or mosaic cases, stem cell or organ transplant cases, and in triplets and vanishing twin, this test cannot be done. So the NIPT result is generally reported as low risk, high risk or aneuploidy detected, no call or indeterminate result. So around 4 to 5% cases are given as no call or indeterminate results, which can be because of any borderline risk or for low fetal fraction or in cases of high data noise or invalid gender. So it's very important that the person either undergoes repeat testing or can directly go for invasive testing. Coming to case number 1, a 38-year-old pregnant female with IVF pregnancy with gestation age of 13 weeks had trisomy 21 high risk on double marker, but USG findings were normal. NIPT test was done and it came out as low risk. So in this case, actually the patient avoided undergoing invasive testing for confirmation of the findings. Case number 2, a 25-year-old female with normal pregnancy, gestation age 19 weeks and singleton, had a hypoplastic nasal bone on ultrasound scan. Cord marker was done and trisomy 21 came to be as high risk. Patient underwent NIPT test and the results were found to be positive for trisomy 21. So then the patient underwent amniocentesis for the same and the sample for amniotic fluid was sent for karyotyping and FISH. And both the reports came out as positive for trisomy 21. Case number 3, a 29-year-old pregnant lady with 15 weeks of gestational age had normal USG findings, but a double marker was reported as high risk for trisomy 13 and 18. NIPT testing was done, but in this case, patient instead of trisomy 13 and 18 was found to be abnormal for sex chromosome aneuploidy and specifically XXY syndrome was found to be positive. So the biochemical hormone markers are actually dependent on various other factors as well. So any other genetic abnormality can also lead to abnormal hormones, and then it can give a positive report for other syndrome as well. So this thing also needs to be considered. So to conclude, NIPT is a great screening test and it immensely reduces the need for invasive procedure testing. but one needs to be aware of the disorders it can screen, its limitations, and need of pre-test and post-test counseling is very, very important. And we should always correlate the findings with other reports that are there. So the major dilemma always comes whether to go for screening test or whether directly to go for invasive testing or confirmatory testing. So with this, I would like to start the next session, which is chromosomal microarray. Chromosomal microarray helps in detection of copy number changes, which can be in the form of deletions or duplications, microdeletion, duplication, or trisomy, monosomy detections. So the general concept of microarray is that sample DNA and control DNA both are labeled with different dyes. They are hybridized on a microarray. And then the data is being analyzed based on whether the genomic content has increased or the genomic content has decreased. The ACOG indications for undergoing microarray testing are prenatal indications, which are used for confirmatory of screening results if they come as positive, or if any congenital disorder is suspected on ultrasound. It is also done for POC testing, where the couple is undergoing recurrent abortions or stillbirth or fetal demise is there, or some congenital malformation is there in the baby. And also for postnatal testing, it is done as first line of investigation if some autism disorder is suspected or intellectual disability is suspected. So the advantages of microarray are that it is a DNA-based method. So it is very helpful for testing POC microarray, where around 20 to 30% POC culture failure rate is there. And as it is a DNA-based method, it is very easy to isolate DNA, and DNA is being amplified. So it's very, there are high chances to detect abnormality. Microarray offers a higher resolution when we compare to conventional techniques like karyotyping, where even with best of the resolution, we can only look for around 1 to 5 MB of content. But within this 1 MB also, we can actually look for very, very small deletions, which can range to the size of 1 KB as well. So 3 main techniques are there for POC testing and AF testing, which is karyotyping. Another is FISH. With FISH, the disadvantage is there that we will only look for the abnormality for which the probe is added. So the most common probes that are there are for chromosome 13, 18, 21, X and Y. So besides that, no other information shall be available. But with microarray, we can look for 1 KB change, and that change can be looked for genome-wide aneuploidy, or any genome-wide microdeletion duplications can be tested. So the turnaround time for microarray is also fast as compared to other culture methods. So microarray is recommended by ACOG if the fetus is having 1 or more USG abnormalities. In cases of POC also it is recommended, and for confirming the findings for any NIPT abnormal report. As we are including microdeletion more and more into NIPT testing, although more validation is needed for it, it is found that there are very high cases of false positive reports for microdeletions and duplications. Therefore, chromosomal microarray is strongly advised if you want to confirm its finding. Yeah. So when we talk about causes of pregnancy loss, chromosomal abnormality is one of a very major common cause for miscarriage or pregnancy loss, and which can be broadly classified into autosomal trisomies, polyploidies, monosomy X, and structural and other abnormalities. So the major focus is knowing the presence of structural and other abnormality, because if there are cases of unbalanced deletions or gains, it is found that 50% cases have one of the parent is actually found to be carrier for balanced translocation. Because when the patient, one of the parent is a balanced translocation carrier, so the parent will be phenotypically normal, but there will be presence of 50% chances that the child will actually have unbalanced translocations or unbalanced gains or losses might be there. Coming to case number 1, 33-year-old female presented with history of recurrent abortion and underwent missed abortion during 10th week of pregnancy. Investigation was done, and lupus anticoagulant profile was normal, antiphospholipid antibodies were normal, no specific findings on biopsy were there, but the POC was sent for karyotyping. Culture was unsuccessful and test was further converted to microarray. Here, chromosome 14 region gain was found, which was of the size of 74.9 MB, and it was pathogenic in nature. Patient was advised couple karyotyping to look for the same change, and genetic counseling and prenatal genetic diagnosis for future pregnancy was advised. Case number 2, 34-year-old female with primary gravida, 20 weeks of gestation, presented with abnormal USG findings, having VSD defect, multicystic kidney, and oligohydramnios. So screening markers were found to be negative for Down syndrome, but still a suspicion for Down syndrome was there. Amniocentesis was done and fluid was sent for microarray analysis. Here, a region of deletion size of 2.83 MB was found in the region of 22q11, and this site is specific for DJAW syndrome, and this was the case for DJAW syndrome. Patient was advised for genetic counseling, and though this occurs sporadically in more than 90% of the cases, but 85% have typical deletion size, and it can be even smaller also. Case number 3, 31-year-old female with primary gravida and history of missed abortion at 8 weeks of gestational age. POC sent for karyotyping, but as no culture was there, test was converted further to microarray. And the case was found to be of monosomy X. So monosomy X, as it is a random event, and so no strict management was needed for future pregnancy. But knowing the genetic abnormality that can be present in the POC can help in managing the case either conservatively, or the patient can be directly advised to go for IVF pregnancy, and further PGD and PGT testing can be done. Case number 4, a 4-year-old girl presented with developmental delay, ataxia, and characteristic facial appearance with seizures. Sample was sent for microarray analysis. And here, chromosome 4p region showed a deletion of 8.8 MB size, and this was a case of Wolff-Hirschhorn syndrome. Last case, 8-year-old boy was presented with intellectual disability, developmental delay, abnormal facial appearance. Sample was sent for microarray analysis, and this was a case for chromosome 15q deletion and duplication syndrome. So microarray result can be broadly classified into normal or no aberration detected. Here, no clinically significant copy number change is generally identified, and we can exclude microdeletion duplication within the limits of resolution of the test. It can be aberration detected. The aberration can be pathogenic, where it is found to be associated with abnormal phenotype. And in many cases, a VUS call might be given, which can be likely benign or it can be pathogenic. In VUS cases, it is advisable for the patient to undergo, the parents also to undergo the same testing, so that we can identify whether the parents are also having the same gain or not. So to conclude, chromosomal microarray should be considered for invasive prenatal testing and confirmatory test for screen positive samples. And POC microarray is actually first line of investigation, which is also recommended by the guidelines. And it offers a very high resolution than traditional karyotype. But on microarray, balanced translocation, low-level methodicism, and single gene mutations cannot be looked for. So this thing needs to be kept in mind. With this, I would like to end my presentation.
How can genetic abnormality detected in POC's microarray testing help for future pregnancy?
Ma'am, if some unbalanced translocation is being looked after, like some gain or loss is there, and if parents also undergo the testing for karyotyping, and if the parents also, we see that they are actually carrier for balanced translocation, that's why they are undergoing recurrent pregnancy loss. So in such cases, they can be advised to undergo IVF for the pregnancy, and PGT testing can be done to look for the same structural rearrangement. And if the embryos are not having that abnormality, then we can transfer them and they can have a successful pregnancy after that.
Okay, okay. Thank you so much. Thank you, Dr.
Thank you,
Deepika.
ma'am. Thank you.
Over to Dr. Jyoti.
Excellent talk.
Thank you so much, ma'am.
Thank you, Dr. Kandika. It was very short, crisp, and you have explained both the procedures, which one is needed where. So moving on, I think we move on to our next session. Already we have covered anemia there. Dr. J.B. Sharma's talk has been done. So is Dr. Promila Malik talk is due now on carbetocin?
Yes.
So I will invite now Dr. Chanchal Gupta, who would be chairing this session, to introduce Dr. Chanchal. She is head of department minimally invasive surgery, Asian Multispecialty Hospital, Faridabad. Thank you, Dr. Chanchal, and over to you to introduce Dr. Promila Malik, our speaker.
Thank you, Dr. Jyoti. And I thank the organizers, Dr. Ragini ma'am, Dr. Jyoti, for inviting me here. I would invite the speaker for this session, Dr. Promila Malik. She's Senior Consultant and Obstetrician and Director, Chiranjeev Hospital, Gurugram. She has experience of 33 years and have been past President of Gurugram Obs and Gynae Society. I welcome you, Dr. Promila, and she would be speaking on a newer molecule for prevention of PPH, that is carbetocin.
Good afternoon, everyone. Thank you, Dr. Chanchal, for the kind introduction. Are my slides visible?
Yes, ma'am.
Yes, we can see your slides.
So we are going to speak on the PPH, the greatest cause of the maternal mortality, general guidelines, and carbetocin, a new molecule for its prevention and management. So the maternal mortality in developing countries is almost 24 times 239 per live births as compared to the developed countries, that is 12 per lakh. So 99% of all maternal deaths are occurring in the developing countries, most like in the sub-Saharan Africa, which is responsible for half of these deaths, and almost 1/3 occur in South Asia. Large disparities are not only between countries, but also within the countries. They are more in low income groups and rural areas as compared to high income and urban areas. Imagine about 830 women die from pregnancy or childbirth related complications around the world every day, and Airbus crashing every day. And more than half of the maternal deaths are attributable to 3 leading preventable causes, that is hemorrhage, sepsis, and hypertensive disorders. And WHO statistics suggest more than 1/4 of maternal deaths are due to PPH alone. And postpartum bleeding is the quickest of maternal killers. It can kill even a healthy woman within 2 hours if not treated. And incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean. And about 50% of cases of PPH are just because of uterine atony. In India, SRS reported that PPH was a major cause of maternal mortality. According to SRS 2001-2003, PPH accounts for 38% of maternal deaths. And even by ICMR in 2003, it was reported that PPH is the leading cause of maternal mortality. So MMR in India is 130, lowest in Kerala and highest in Assam. And SDG 2030 aim is to bring down MMR to 70. So what are the definitions of PPH? According to WHO, blood loss more than 500 ml within 24 hours after birth. Severe PPH is blood loss more than 1 liter within the same time, or the patient going into shock. According to ACOG, cumulative blood loss of more than 1 liter or blood loss accompanied by signs or symptoms of hypovolemia within 24 hours after birth process, regardless of route of delivery. RCOG defines minor PPH between 500 to 1 liter, major is moderate up to 2 liters, and severe is more than 2 liters. International expert panel says active bleeding more than 1 liter within 24 hours following birth that continues despite the use of initial measures, including first-line uterotonic agents and uterine massage. PPH occurring in the first 24 hours after delivery is called primary PPH, and occurring after 24 hours to 12 weeks after delivery is called secondary late or delayed PPH. So what are the physiological mechanisms that limit the postpartum blood loss? Normally, hemostasis occurs upon placental separation because uterine bleeding is controlled by a combination of two mechanisms. Most important is contraction of the myometrium, which compresses the blood vessels supplying the placental bed and causes mechanical hemostasis. They act as biological ligatures. Second is local decidual hemostatic factors, tissue factor type 1 plasminogen activator inhibitor, and systemic coagulation factors, platelet circulating clotting factors, which cause clotting. The pathogenesis of most cases of PPH is a disturbance in one or both of these mechanisms. And the pathogenesis for most of the remaining PPH cases is loss of intact vasculature, that is trauma. And the potential for massive hemorrhage from pathology in normal physiological mechanisms at delivery is high because in late pregnancy, uterine blood flow is 500 to 700 milliliters per minute and accounts for approximately 15% of cardiac output. So imagine if the patient is not managed in time, how much blood loss she can lose within minutes. So revising our MBBS, causes of postpartum hemorrhage, 4 T's, most important: tone, tissue, trauma, and thrombus. The tone, the most common cause of PPH is uterine atony. More than 50% of cases of PPH are because of uterine atony, that is uterine atony, that is lack of effective contraction of the uterus after delivery. And diagnosis of atony is generally made when the uterus does not become firm after routine management of 3rd stage of labor, that is giving oxytocics and uterine massage. And atony may or may not be associated with retained tissue. After delivery, uterus should feel like a cricket ball, which cannot be indented, a well-retracted uterus, and not a football. Placental disorders like morbidly adherent placenta, placenta previa, abruptio placentae, retained products of conception, and uterine inversion also result in atonic PPH because they inhibit effective uterine contractions either focally or diffusely. Trauma-related bleeding can be due to lacerations or cervical surgical incisions. Cervical and vaginal lacerations may develop as a result of natural process of delivery or may be related to provider interventions like instrumental delivery. And they may not be noted until excessive postpartum vaginal bleeding prompts lower genital tract examination, including examination for vaginal and vulvar hematomas, especially if the uterus is felt well retracted parabdominally. We must have 2 SIM speculum and 3 sponge holders in delivery set for inspecting vagina and cervix in routine after every delivery. So uterine lacerations may be complete transmyometrial ruptures or incomplete lacerations of the inner myometrium. At cesarean delivery, hemorrhage from the uterine incision is generally caused by lateral extension of the incision, which can result from spontaneous tearing of an edematous lower uterine segment during an otherwise uneventful cesarean after prolonged labor, or from an incision which is made too low or not sufficiently curved on the lower segment, or from delivery of the fetus through an incision that is too small. So to avoid this, in any second stage LSCS, we should give a smiley incision, the curving upwards, higher up, and deliver by Patvardhans or reverse breech to avoid the lateral extensions of the uterus. And bleeding from lateral extension of the uterine incision is readily ascertained by inspection of the incision, lateral pelvic side walls, and broad ligament. And retroperitoneal enlargement and bulging of the broad ligament at cesarean can be signs of retroperitoneal hemorrhage. Coagulopathy or platelet dysfunction can contribute to PPH in women with inherited or acquired bleeding diathesis. Coagulopathy can also be a result of PPH when there is severe reduction of clotting factors due to persistent heavy bleeding and hemodilution of the remaining clotting factors. Example, placenta accreta spectrum. Women with von Willebrand's disease are especially at risk for PPH because von Willebrand's factor levels, which typically increase during pregnancy, decline rapidly after delivery. So take any history of menorrhagia since menarche or excessive bleeding in trivial injuries. Acute acquired coagulopathies can be caused by amniotic fluid embolism, placental abruptio, preeclampsia with severe features, or HELP syndrome. So what are the guidelines for rapid identification and treatment of hemorrhage in a postpartum patient? We should identify high-risk factors in the antepartum period itself, like multiparity, previous uterine scar, previous history of PPH, obesity, anemia, macrosomia, polyhydramnios, multiple big fibroids, placenta previa, placenta accreta syndrome, abruptio, gestational hypertension, preeclampsia or HELP syndrome, magnesium sulfate administration. The intrapartum and postpartum high-risk factors are chorioamnionitis, induced labor, prolonged labor, instrumental delivery, prolonged third stage or retained placenta after vaginal delivery. Most important is to correct anemia in the antenatal period, maybe with parenteral iron. The target hemoglobin should be 12 at least, except in a patient with beta thal minor. As already discussed by Dr. J.B. Sharma, we must not hesitate in giving parenteral iron if the hemoglobin is not rising with the oral iron. So in all high-risk patients and Rh negative, to keep 2 units packed RBCs cross-matched at admission, and to deliver very high-risk patients like placenta accreta syndrome, APH, coagulopathy, multiple big fibroids in tertiary center. And active management of third stage and vigilant monitoring in the fourth stage are the cornerstones to prevent maternal mortality. So actively managing the third stage of labor is administer oxytocic at anterior shoulder, uterine massage after delivery, controlled gentle cord traction. Then after delivery of the placenta, closely examine the placenta for any retained tissue or retained bits of placenta. Then carefully examine in routine in all the patients, the vagina and the cervix for any lacerations, and quantify and document the blood loss. Postpartum, that is the fourth stage of labor, is very, very important. Assess for excessive lochia and or blood clots, displaced and or boggy uterine fundus, bladder distension, examining vulva and episiotomy for any hematoma, and the vital signs alteration. The continuous monitoring of the vitals is very, very important by electronic monitoring. And we can take a Mio score also, as was discussed in drill yesterday. And let the patient be monitored with pulse oximeter for at least 4 hours postpartum. And it is not very difficult. Even we can monitor the pulse if you don't have a multipara. Small pulse oximeters are there. And if there is any tachycardia, decrease in the blood pressure, any tachypnea, any alteration in the level of consciousness, skin changes such as pallor, cyanosis, clamminess, any excessive pain in the episiotomy, you should look for any visible hematoma or laceration, or any tenderness of the perineum, or any patient complaining of rectal pressure. So blood loss is estimated by the vital signs. If the blood loss is up to 15%, the BP remains normal and the pulse above 90 systolic BP, patient may have mild tachycardia and palpitation and may complain of slight lightheadedness. Up to 15 to 25% of blood loss, the systolic pressure also starts going down, but it doesn't go below 80. Patient complains of weakness, sweating. The tachycardia increases from 100 to 120, and the respiratory rate also increases from 20 to 24. If the blood loss is further continuing up to 35%, the BP starts going down, doesn't go beyond below 70, tachycardia up to 120 to 140. Patient complains of restlessness, confusion, oliguria, cool and clammy skin. And above 35%, the BP starts going below 70 and the patient may collapse and initially complaining of air hunger and lethargy and anuria. So what are the general principles of management? Yes, a day before yesterday, we had a PPH drill in which it was told to keep PPH box ready in the labor room. It has already been described in the drill, so I'm not going into the detail. So immediately quantify the blood loss And patient should be on the pulse oximeter in the labor room also. And initiate additional measures to monitor the vitals. Initiate additional measures to control the bleeding based on the severity of obstetric hemorrhage. Shout for help and notify the obstetric hemorrhage team. Continue to monitor vital signs. Quantify blood loss, preferably with multipara. Ensure intravenous access with 2 large gauge catheter, number 16. And when you are putting the IV cannulas, take samples for lab and cross-matching itself. Begin bimanual uterine massage. Increase the oxytocin flow rate. Volume resuscitation, preferably with blood and blood products if the bleeding is continuing and the coagulopathy is imminent. Till the blood products arrive, replace with IV fluids 3 times the blood loss. Give a second uterotonic, methyl ergometrin if not contraindicated, carboprost if not contraindicated, carbetocin, misoprost. Injection, tranexamic acid IV. Catheterize the bladder, which will help in uterine retraction also and the output monitoring. Examine for uterine retraction, lacerations, any retained products of conception, uterine inversion and other causes of bleeding. Consider bedside ultrasound of uterus if required and treat as appropriate. Repair lacerations, reposition of uterus or curettage. If cesarean delivery, apply conservative surgical interventions to control the bleeding like stepwise devascularization and internal iliac artery ligation, uterine compression sutures. If the blood loss is still continuing, do all the above. Draw baseline samples. Insert intrauterine balloon for tamponade. Transfuse 2 units packed RBCs and 1 to 2 units fresh frozen plasma. Immediately activate a massive transfusion protocol if bleeding is heavy and transfusion of 4 or more units of blood is likely. If vaginal delivery, move the patient to operation theater to perform conservative surgical interventions to control the bleeding. And selective arterial embolization is considered only if the patient is hemodynamically stable. It is never performed in a decompensating patient. If cesarean delivery, continue to apply conservative surgical interventions to control bleeding, but decision for obstetric hysterectomy should be taken timely rather than delayed to prevent irreversible decompensation. And if the blood loss is still going more than 1.5 liter, initiate massive transfusion protocol immediately. And if the conservative surgical interventions are not successful, perform hysterectomy. And keep the patient warm, treat acidosis, check ionized calcium and potassium levels every 15 minutes. Once a massive transfusion protocol has been initiated, treat hypocalcemia, hyperkalemia aggressively. Continue until the emergency has been contained and the protocol for massive transfusion has been stopped, and maintain oxygen saturation at 95%. So how do we prevent postpartum hemorrhage? Active management is recommended rather than expectant management of the 3rd stage of labor. Active management of 3rd stage can reduce PPH due to atony. Active management is a bundle of interventions. It is defined as administration of prophylactic uterotonic with or without tranexamic acid just after the delivery of anterior shoulder, followed by gentle controlled traction of the umbilical cord until the placenta separates and is expelled. Pharmacotherapy is the most important component of this combination of interventions. Cord traction has been associated with modest benefits. The active management of 3rd stage of labor can reduce the incidence of postpartum hemorrhage by almost 1/3. So we have been using routinely oxytocin as in the active management of 3rd stage of labor. It is structurally similar to vasopressin, secreted by posterior pituitary gland, and stimulation of oxytocin receptors in myometrium leads to myometrial contractions. And the concentration of these receptors increase with gestational age and labor and is higher in the fundus than in the lower segment. Usual regime is 10 international units in 500 ml of normal saline or ringer lactate and infused over 1 hour, followed by additional 10 international units in 500 ml of fluid at 2 ml per unit for next 4 hours. And the IV line is removed at the end of the oxytocin infusion if the patient is stable. And intramuscular administration of 10 units of oxytocin is an acceptable alternative to IV especially in the periphery when there is no IV access, but it is somewhat less effective than IV. And intravenous bolus, if it is effective, but the safety of this route has been questioned due to case reports of significant hypotension associated with rapid injection, which may lead to myocardial ischemia, cardiovascular collapse, and death. So it is always safer to give rapidly in a drip rather than giving a bolus dose. Misoprostol is a synthetic prostaglandin E1 analog that causes uterine contractions. Its heat stability and ease of administration are advantages compared with the oxytocin and ergot alkaloids in low resource areas where refrigeration and sterile needles are not available. The FIGO and WHO recommend administration of misoprostol 600 microgram orally when injectable uterotonics are not available. The common side effects are shivering and fever, which begin within 20 minutes of administration, peaks at 1 or 2 hours, and spontaneously declines over 3 hours. And it is more when it is given sublingually. Ergot alkaloids, they are serotonergic receptors, and the advantage is they lead to sustained uterine contraction, spasm, and tetany. And advantage is rapid onset of action and the prolonged uterotonic effect of alkaloid. So combination of methyl syntopentine is syntocin on oxytocin 5 units and 0.5 milligram ergometrin, which immediate action of oxytocin and sustained action of ergometrin is there. But they're contraindicated in hypertension and any patient with a cardiovascular disease. So the new molecule which has been introduced for reducing the incidence of uterine atony and PPH is carbetocin. It's a long-acting synthetic analog of oxytocin. It has similar pharmacological properties to those of natural oxytocin, but the half-life is 10 times longer, 40 minutes, as compared to 4 minutes of oxytocin. It binds to smooth muscle receptors of uterus and has been reported to produce a tetanic uterine contractions within 2 minutes, and they last for 6 minutes, followed by rhythmic contractions for 1 hour. And it is available in many countries, not still in USA, for prevention of uterine atony and hemorrhage. And the potential advantages are its long duration of action and availability of a heat stable formulation as compared to oxytocin, where you need a continuous infusion because of its short half-life, and it requires a cold chain and a storage at 2 to 8 degree only. So effectiveness in a network meta-analysis of randomized trials, carbetocin was more effective than placebo or no treatment for reducing PPH. And how do we administer it? It's available in 100 microgram ampule or vial, and it is administered diluted in, it's better to dilute it in 5 ml and then give it over 1 minute. And it can be given undiluted by intramuscular injection also. And it has almost similar side effect profile as oxytocin. Tranexamic acid is an antifibrinolytic drug that has been useful for both prevention and treatment of bleeding in various clinical settings. Its use has become a standard of care in the treatment of patients with PPH, and it is also appears promising when used as prophylaxis against PPH. So we come to the new molecule, carbetocin, a promising choice for PPH management. It is available in a room temperature stable formulation and convenient boil presentation. The disadvantages of oxytocin and ergot alkaloids are that they have to be kept in a refrigerator to avoid degradation, and heat stable formulation of oxytocin is currently not available, and they have to be stored between 2 to 8 degrees centigrade, and resource poor countries do not always have a cold chain transport and storage capabilities. And there is lack of awareness also in the periphery among the users and the pharmacists also, because majority of the times you will find that the pharmacists are not keeping the oxytocin in the refrigerator, that is just lying on the shelf. But carbetocin is stable at room temperature and has shelf life of 24 months at 30 degrees centigrade and 75% humidity, avoids need for cold chain storage and logistics, and is provided in a vial. So carbetocin was created by making several modifications to the oxytocin structure itself, which has prolonged its half-life, and it reduces the enzymatic degradation. It is synthetic, long-acting analog of oxytocin, and it's used for prevention of postpartum hemorrhage due to atony. And one vial contains 100 microgram in 1 ml solution for injection.
लंबा हो गया उन्होंने PPH पहले बोल दिया ये जो बोलता वो
A few minutes, few slides only. So benefits are there is reduced need for additional uterotonic agents. It has longer half-life, no cold storage is required, and good tolerability, similar onset of action, quick action, and similar efficacy.
Sorry to interrupt, Dr. Promila. We are already running short of time. Could you make it faster, please?
Yeah. A single IV injection achieves uterine activity within 2 minutes and lasts approximately 1 hour. And it can increase the rate and force of spontaneous uterine contraction. And the benefit is, the side effect of oxytocin is, if you are given a higher dose, it can cause hyponatremia because of its vasopressin activity, which is not there in carbetocin. And it is not inferior to the oxytocin for the prevention of blood loss for at least 500 ml, or it reduced the use of additional uterotonic agents as compared to oxytocin. And patients treated with carbetocin, they had less need for additional uterotonics compared to those treated with oxytocin. And hemodynamic effects of oxytocin and carbetocin were compared, and their efficacy was assessed. And it was similar in this thing, because in oxytocin we require continuous infusion, and carbetocin just requires a single dose. So efficacy comparison compared to oxytocin, prophylactic treatment with carbetocin after elective cesarean reduced the need for additional uterotonics by more than 50%. And efficacy and safety of single intramuscular dose of carbetocin versus symptometrin in managing third stage following vaginal delivery. It was assessed that requirement of additional uterotonic therapy, incidence of PPH, amount of intrapartum blood loss, and adverse effect profile were similar. So there is reduction in postpartum blood loss, smaller drop in hemoglobin levels, and less adverse side effects, because symptometrin is contraindicated in patients with hypertension and cardiovascular disease. So it is more safe and more effective. And it has comparatively same safety profile to oxytocin. And intramuscular administration of carbetocin at a dose of 100 microgram is more effective than oxytocin for preventing PPH. Its use is associated with less blood loss and better tolerability profile compared to symptometrin. Intravenous carbetocin demonstrated similar efficacy to sublingual mesoprost plus oxytocin infusion for the prevention of PPH. So guidelines are, the WHO has added carbetocin as its this thing for managing active stage of third labor. Canada is using as the first line in AMTL 100 microgram. New Zealand is also using, New Zealand recommends active management of third stage of labor with any of the uterotonics. FIGO has recommended carbetocin as one of the recommendations for PPH management. And Germany and Austria and Switzerland are recommended carbetocin as AMTL, and France is on providing non-inferiority. They are also recommending carbetocin. So key messages are, PPH remains a clinically significant cause of maternal complications and death. It's common and can occur even in women who are not at risk. It has major impact on the lives and health of the affected and their families. And WHO recommends the use of prophylactic uterotonic as an important step in AMTL. This could reduce the PPH by more than 50%. Carbetocin is synthetic, long-acting analog of oxytocin created by making several modifications to oxytocin molecule. It's available in room temperature formulation, convenient boil presentation, doesn't require cold chain and fridge. Carbetocin has similar efficacy and safety profile, and it significantly reduces the need for additional interventions and uterine massage and need for additional uterotonics, and reduces blood loss to less than 500 ml in more women, in majority of the women. So thank you. Thank you so much.
Thank you, Dr. Promila, for such an elaborate...
In my personal experience also, I have used carbetocin in more than 65 patients, and it gives excellent results. Excellent results. But one thing I have observed, you have to be careful in a patient in using who are hypertensive, because it causes a transient rise in blood pressure. I've observed that when you're giving carbetocin, because it causes tetanic contractions like methergin. So you have to be careful in patients with hypertension and you have to monitor the BP.
Thank you, Dr. Promila, for such a wonderful and elaborate talk on postpartum hemorrhage. And we have the take-home messages like in active management of third stage of labor, a newer heat-stable molecule that is carbetocin is definitely useful because of rapid onset of action, prolonged action, and single dosing required, no multiple dosing required. And the most important, what we have seen in practical uses as well, the antidiuretic action which the oxytocin has, that has also been prevented by using carbetocin.
The only limiting factor is its cost. Once it is not there, I think it should become the first line of management in AMTL.
Yes, definitely. And I would just suggest, like Dr. Promila also said, she had used in so many patients.
Yes.
So we all should use this molecule, and then only we will realize how effective it is in prevention of PPH.
Right. Thank you so much. Thank you, Dr. Chanchal. Thank you, Dr. Promila. Since we are running out of time, I would cut it short here, and we go on to the next session. And there is a little change since Dr. Mitra has to leave for another the same commitment. I would now invite Dr. Sarita Gulati, and I would request my worthy speakers to please stick to time since we have many talks still left and the time is running short. So yeah, Dr. Sarita is was SMO in charge Gynae Obs at Civil Hospital Yamunanagar, and she is presently working at Gulati Hospital Yamunanagar. And she is also the Vice President Foxy of Yamunanagar 2017-2019, also now the President Foxy Yamunanagar. So welcome, Dr. Sarita, and over to you to introduce Dr. Mitra Saxena, our speaker for this session.
Good evening, good afternoon, everyone. First of all, I thank you, Dr. Ragini, and all the organizers for giving me a chance to participate in this. As we know, venous thromboembolism is a leading cause of maternal mortality. It is 10 times more common during pregnancy and peripartum period due to hypercoagulable state. Therefore, because of its high prevalence, it needs a special consideration for its management and therapy. And for this, we have with us Dr. Mitra Saxena. She's well known to me from last 30 years. She is my senior and my mentor. She is MD DNB, FICM HCA. She is FICOG Diploma Endo, and she's at present chair of the Technical Obstetric Committee, Foxy. She's
Sarita.
Yeah.
I think we all know each other, and it is organizers. And thank you so much, Sarita. You are such a sweetheart, I should say. And while I'm trying to share my screen, I would like to first say my lots of thanks and my congratulations to the organizer for the 2 days program. It was so good, the whole program, that I have to make this public declaration that my own committee program I shifted because I didn't want anything to clash with our programs of 25th and 27th. Having said, all praise for Dr. Ragini, Dr. Jyoti, Dr. Saroj, the dynamic team of our HARObGyn with Nisha, Dr. Vibha, everybody. And secondly, I want to thank Dr. Sunita Malik, my senior, because this was Dr. Sunita's turn to go. But thank you so much for allowing me to share my knowledge, little bit of knowledge. And what I must thank the organizer कि जब हमें ऐसा टॉपिक देते हैं तो उससे हमारा रिविजन हो जाता है. So thank you, Promila, for taking us through PPH. And now I'll try and take you people through venous thromboembolism in pregnancy. We all know that it is not very high in incidence. I mean, it's the major causes for maternal death. Narendra. So the major killers, of course, are sepsis and hemorrhage. Yet venous thromboembolism, especially the pulmonary embolism, is a sure shot case for maternal mortality. So it's very imperative for us obstetricians to be aware of this entity. Going back to our very basics, we all know that what was the virtuous triad. So hemodynamic changes, endothelial injury compounded with hypercoagulability. These were the three main game changers for this process of thrombosis to happen. Now, when we see it in the perspective of pregnancy, we find all the three things, they are there when there is a pregnant lady. So we understand that a pregnant lady, by the physiological state itself, is at highest risk of venous thromboembolism. And why? Because basically nature is the best, designer or artist, and it has perfect balance. Why a pregnant lady should have a hypercoagulable state? Because when she's going to lose blood, like in PPH, if she has more clotting factors, she'll not go into, and the clot will, the open sinuses, there'll be a clot and thrombus, she will not lose all her blood. So basically nature has provided everything for a, even if there is some deviation from the normal physiology, there is enough reserve in a pregnant lady to combat that. But whenever things go wrong, this same hypercoagulable state of pregnancy, instead of working for the advantage of a woman, is going to cause more trouble. So we are going to look at all those places where this is going to become a serious trouble for a woman in question and also the treating obstetricians. Because like some things are obvious, PPH is so obvious you cannot miss it. But thrombosis, deep vein thrombosis, is something which can always be there. So every obstetrician has to be very much aware that where are the cases where high risk, and our one sense should be taking in antenatal period itself, that is she a high risk for deep vein thrombosis, because incidence ज़्यादा नहीं है, पर अगर हो गया तो फिर pulmonary embolism से death निश्चित होती है. So looking to that, in human circulatory system, there is a perfect balance between the procoagulants and the anticoagulants. But in pregnancy, it is favoring the procoagulants. So in pregnancy, we have to understand that there is, in addition to increased procoagulants, as you saw in the last slide, that all the clotting factors 7, 8, 10 are more than in a normal pregnancy. There are other factors which contribute to venous stasis, and that is the presence of vasodilatory prostaglandin, PGI2, and we all know there is abundance of estradiol that upregulates the nitric oxide molecule. That molecule which is very important to decrease the resistance of the arterial system, so that best blood flow goes to the baby. Yet when it acts on the venous tone, again it causes its dilatation, so it helps in the stasis. Another thing is a gravid uterus is going to compress the inferior vena cava and the iliac vein. सुनो भैया, please 10 minute के लिए बंद करो. And during delivery, whenever there is instrumentation prolonged, the pressure of the head, so we all know that the pelvic veins are congested, and that causes damage to the endothelial wall. So the stage is set, hypercoagulable stage, along with all these factors contributing to deep vein thrombosis. Now, when it happens in the iliac vessels, it will not be evident very early. Yet, if the veins of the lower limb are involved, we may get some clues because of some symptoms. So what we have to remember is, as I've already mentioned, that pregnancy and puerperium are established risk factors for venous thrombosis. And as compared to non-pregnant women, a pregnant lady is at risk of 5 times more of venous thromboembolism as compared to non-pregnant. And puerperium is still more liable to have DVT. Now, as I've already mentioned, that this deep vein thrombosis is associated with adverse obstetric outcomes and is a significant contributor to maternal morbidity and mortality. And we have to understand that if we do not pick up the clues in the antenatal period or during delivery period, even if it is vaginal or cesarean section or in the postpartum period, we are likely to land up with trouble. This is a very busy slide, but it is very important for all of us to recognize what are the risk factors for venous thromboembolism. 10 years ago, none of us were very proficient in using low molecular weight heparin. We were very skeptical about using heparin, and it used to be a bugbear. But now, over last decade and a half, with so much of knowledge going around about recurrent pregnancy loss, that almost everybody is very confident to use the low molecular weight heparin or icosapent, etc. So the entity of thrombophilias is now always at the back of our mind, where patient is landing up with multiple abortions. But such a patient who's already having a tendency for thrombophilia, for thrombosis, they are the patient not just disruption of the pregnancy, but after pregnancy or during pregnancy, these patients are very high risk for thrombosis, venous thrombosis. So this is one of the very, very important group which we have to understand. If any patient has a history of thromboembolism, not embolism, thrombosis, deep vein thrombosis, again, that patient is very liable. She deserves to have prophylactic use of low molecular weight heparin from the very beginning. Again, if a patient has anything which is going to disrupt the circulation, so there is patient is having SLE, inflammatory polyarthropathy, or heart failure, or age is more BMI, obesity is a very high risk factor for stasis and compounding the problem. So, and especially if there's immobility. Now, these are the pre-existing factors. So whenever we have a patient profile, we have to be very meticulous in risk stratification. Once we learn to do the risk stratification, only then I think we are doing justice to our role as a good, sincere obstetrician. If we haven't picked up these clues in the antenatal period and we are complacent, we are likely to get into trouble. Again, in the current pregnancy, if it is a multiple pregnancy or there is PIH, there is hyperemesis, dehydration. You know, these are things where there is going to be more hemoconcentration and more chances of deep vein thrombosis. If a patient has had treatment for infertility and she had OHSS, so again, this patient carries a higher risk of going into venous thrombosis. And of course, we are all aware whenever an obese woman, big baby, prolonged surgery, prolonged labor, or there is increased loss, again, these patients can have venous thrombosis infection. So we have, this is very important, that we have to increase our ability to think of this entity when we are dealing with pregnant ladies. Now, why it is so difficult? Because clinical manifestations are not very obvious. It's not every day that you'll get a patient who's complaining of pain in only one leg. But this is very, very important for every one of us to remember. Normally patients will say, "Tango mein bahut dard ho raha hai." So please ask her, is it both the legs or is it in one leg? And if the patient complains of pain in one leg, please do not write a medicine of painkiller. Please expose the leg and look for the obvious difference in the calf. So these are important because this is, in our busy OPDs, we miss these clues. That is why I thought I'm going to emphasize on all those practice points. If we are capable, we are, very careful, we will not land up into trouble, because always it's the history, it's the examination, and then comes the role of any diagnostic modality. So clinical prediction for pregnant women in first trimester. Now, what is that? If a woman complains of left lower extremity, it is very interesting to note that deep vein thrombosis happens more often in the left side. So if the patient complains of pain in the left side, left lower limb, and when we examine, we see there is a difference in the calf circumference of more than 2 centimeters because of edema. and also if it presents itself in first trimester. So never to miss the diagnosis. Having clinically picked up, now what will be the next investigation? Quite obviously, we have a fantastic modality, which is the ultrasound. So compression ultrasound is the next thing we should order. But we should not miss this complaint of the patient and also not miss this examination. And this is actually called the left rule. And we have to understand that instead of asking for a battery of investigations, we should more rely on history, examination, and ultrasound. Let us talk about D-dimers. See, we all know that in cases where D-dimers is high, there is more chances of intravascular thrombosis, but this doesn't. What we have to remember now, with so much of knowledge about D-dimers, and in COVID patients, when we saw that the D-dimers were high, we were really fretting and fuming and expecting that there will be intravascular thrombosis. So we know that connection. But in pregnancy, let us remember that we are not going to rely on the D-dimers to make our diagnosis of deep vein thrombosis. Now, in deep vein thrombosis, I'll go straight away. After history and an obvious thing of examination, what is important is ultrasound imaging. So compression ultrasound has diagnostic accuracy with a very high sensitivity and specificity. Along with that, a good keen ultrasonologist also does the Valsalva maneuver to make out whether there is obstruction in the flow. We have to understand that it's the deep calf muscle vessels which can present. Iliac veins ka thrombosis will not be obvious. It may become obvious in the form of, for the first time, an attack of pulmonary embolism. So there our role has to be very vigilant, and actually such high-risk patients should have had prophylactic low molecular weight heparin. Now, again, this algorithm is, the cornerstone here again is compression ultrasound and Valsalva maneuver. And it very clearly says, whenever it is positive for DVT, we have to start the patient on low molecular weight heparin or unfractionated. And of course, this is very controversial to give oral anticoagulants or not, because now we are very, very comfortable with the injectable form. And about invasive management, that is not our domain. So as obstetricians, we can restrict ourselves to the fact that we can manage these patients on our own by use of LMWH. Now, if we suspect iliac vein thrombosis, then what is the next modality which is available? That is MR venography. And MRI is not contraindicated in pregnancy, provided our index of suspicion for iliac vein thrombosis is high, which will only be if patient has some predisposing high-risk factors, because clinically it doesn't basically present. Similarly, whenever there is equivocal tests, then what to do? You have to repeat the ultrasound and or take another opinion from another sonologist so that we know, because we have to understand that if we start the treatment timely, the complication will not happen. But if we have missed, we are going to lose the mother. So again, these Geneva scores and the Well scores were all scores, numerical scores, based on different risk factors, which we have to pick up in the antenatal history, taking past history of thrombosis, past history or obesity, the immobilization. There are lots of factors. And I'm going to come to the years algorithm. Now, see, as I told you, if we are, vigilant and we have managed the deep vein thrombosis, we may not land up in pulmonary embolism. But how does one diagnose pulmonary embolism and manage it? Well, we already know that if a patient in post-operative period, everything went off very fine, and 6 hours, 4 hours after cesarean, patient suddenly becomes restless and hypoxic. And then we realize, oh, she may have had pulmonary embolism. And were we vigilant that for high-risk pregnancy, we had put her on complete bed rest. So again, our management in antenatal period may have been the reason why she had unrecognized deep vein thrombosis, and we are confronted with pulmonary embolism. So here's algorithm has 3 criteria. One is clinical signs of deep vein thrombosis. If there is symptom of hemoptysis, and whenever there is a symptom, sudden development, the most likely diagnosis is pulmonary embolism. We do not have to, basically wait for D-dimers to diagnose this. There is, of course, computed tomography, tomographic angiography is one of the modalities, but if we are vigilant, then just by our clinical and sonological examination and risk stratification, we would have been in a better position to start anticoagulation therapy in time. So, as I said, that compression ultrasound is the first investigation of choice. And the next, it's a very simple test, and that is just an X-ray chest. We don't have to go for hi-fi investigations. What is very important is, again, I'm reiterating our clinical suspicion based on risk stratification. An obese, overweight woman with a big baby, with a difficult delivery or a prolonged cesarean section, we should have put her on prophylactic low molecular weight heparin, so that we will not land up with a pulmonary embolism.
थोड़ा सा उसे wind up करो.
हो गया. I'm going to finish it very fast. So I'm not going to go into the details because all of us are very, very, proficient in using LMWH. And we all know that the beauty of LMWH is it doesn't need to be monitored. When you're using unfractionated heparin, then you need to monitor it with the coagulation profile, bleeding time, clotting time, PT, APTD, whereas this doesn't need monitoring. And once you teach the patient, they can always start using it themselves. So I'm not going to be talking about the doses. We all know in the high-risk patient, depending upon the weight of the baby, the weight of the mother, that is the reason, that is the that's what sets the dose. So it's 60 milligram every day. I mean, these empirical doses of 40 milligram, 5 days a week, 3 days a week, alternate days, that's not done. If it is indicated, it is to be administered every day, depending upon what is the half-life of the molecule that we are using. So we are very comfortable with using enoxaparin, which is a category B drug, and which needs to be given once a day or twice a day if it's a frank case of thrombophilia. So we are not using direct oral anticoagulant agents. The only place where these are used are those who have valve replacement surgeries. Again, antiplatelets, now all of us are really masters in using correct dose of ecosprin, 75 or 150, depending on the risk that we are using it for. If a patient has risk of PIH, early onset of PIH by uterine artery Dopplers and by PLGF and dual markers, then we start very early. So again, those patients who have been stratified and who have been put on antiplatelet agents, LMWH, again, we are decreasing their risk of venous thrombosis and venous thromboembolism. A word about mechanical thromboprophylaxis, where some agent like some stockings, etc., are used to protect from obstruction in the circulation. So again, how long we have to continue? Those patients who have past history of venous thromboembolism or they are high risk, we have to continue this prophylaxis or management for a longer time in postpartum. Otherwise, the best method is to ensure hydration and to encourage early ambulation. Okay, so I think depending upon what is the patient profile, the best management of avoiding deep vein thrombosis is early ambulation. One cannot, even in cesareans, it is very prudent to start patients to walk within 6 hours, just as fast as they are stable and pain-free. So Friends, these are some of the options where systemic thrombolysis, thrombectomy, catheter-directed thrombectomy, etc., is done. But if we are vigilant, we would be lucky that our patient doesn't go into pulmonary embolism, which is a sure killer. So for pulmonary embolism, if the patient is in vicinity of ICU within intensivist, and this is in our mind, and we begin the anticoagulation and all the resuscitative measures very, very soon, then maybe we may be able to save the patient. This is a beautiful picture because on left side are the reasons which have baseline risk. If there is history, known thrombophilia, obesity, immobility. During pregnancy, these are the risk factors: gestational age, multiple gestation, ART techniques, preeclampsia, and infections. So the prophylactic indications are unprovoked VTE or known thrombophilia. Sorry. So I think I must thank Ragini for giving me a topic which, just to deliver this talk, it was very interesting to reiterate our own knowledge about this entity. And we have to understand that a physiological process which was made by God, it goes wrong, and when we are not vigilant, then we can really go very wrong. Thank you so much. I hope I've been able to convey some of the important messages that I wanted to convey. And that is anticipate, prevent, and of course, if you've missed the bus, then you have to manage. Thank you.
Thank you, Dr. Mitra. You have well explained it by being vigilant, by having a good history examination, and looking for the preventive factors, and treatment has also been very well explained that we have to give low molecular weight heparin, and some newer techniques are there. Thank you so much.
Thank you so much. Thank you, Dr. Sarita, and for that excellent talk, Dr. Mitra. We move on to another important topic of sepsis, and for this I request my chairperson, Dr. Surekha Yadav, to chair this session. She is president, Rivari HARObGyn Society, and she's done over 10,000 NDVH in her 15 years of private practice. So that is commendable for doing a NDVH in this era of laparoscopic surgery. We all should actually go back to vaginal hysterectomies rather than that. So wonderful, and thank you so much for coming in. And I hand over to you, Dr. Surekha, to invite our next speaker, Dr. Sunita Malik, ma'am.
Thank you, organizers, and Dr. Ragini, ma'am, for giving me this opportunity to participate in this wonderful webinar. And now may I have the opportunity and privilege to introduce Dr. Sunita Malik, who is a former professor, senior consultant, and unit head of Gynae Department, VMC and Safdarjung Hospital, Delhi. She has held the various prestigious posts of Vice President AOGD, Secretary AOGD, and Joint Secretary NARCI Delhi from 2005 to 2007. She has been the chairperson Gynae Oncology Committee AOGD 2021 to 2023. And she is also the chairperson Breast Cancer Awareness Committee AOGD 2016 to 2018. And she has many publications in national and international journals, chapters in books, and her special areas of interest include high-risk pregnancy, critical care, and gynae oncology. I welcome you, ma'am, and over to you, ma'am.
Thank you very much for the introduction, and I'm also thankful to Dr. Ragini and your team. It was such a wonderful conference which is going on over 2 days. Let me share my screen. So mainly sepsis in pregnancy. As we know, sepsis is a clinical syndrome that has a physiologic, biological, and biochemical abnormalities caused by dysregulated host response to infection. We know that it's a clinical syndrome from infection up to morts and deaths. That's a very major cause of sepsis. Starts with the infection, causes bacteremia, sepsis, septic shock, and finally death. And the definitions related to sepsis have changed from the early 90s. When we were studying, we used to have the stage was SIRS, that is systemic inflammatory response syndrome, severe sepsis, septic shock, and MODS. And what we were seeing was respiration rate more than 20 per minute, or PaO2 less than 32 millimeter, WBC count more than 12,000 or less than 4,000 per microliter, or more than 10% in mature forms, heart rate more than 90, fever more than 38 degrees or 100.4, or hypothermia also less than 36. These were the characteristics of the sepsis which we were considering at that time. And after SIRS used to be severe sepsis, then septic shock and MODS. So these days we are not using SIRS, it's non-specific, and it can be caused by ischemia, inflammation, trauma, infection, or several insults combined and not always related to infection. So this term is now obsolete. Even we are not using severe sepsis also, because now we straightaway go to septic shock, which in the definition, which includes patients with evidence of tissue hypoperfusion and organ dysfunction. So now the latest SSCN Task Force 2016, this is the definition. Sepsis is defined as a life-threatening organ dysfunction caused by a abnormal host response to infection. Organ dysfunction is defined as an increase of 2 or more units in the SOFA score. Infection is invasion of sterile tissue by organisms. No clear guidelines are there to identify the presence of infection or to link an identified organism with sepsis. Clinical suspicion with supporting data, radiological or microbiological, and response to therapy, which help us in diagnosing that infection as occurred. Septic shock, that's the next step in the spectrum of sepsis, is a subset of sepsis with this circulatory and cellular metabolic dysfunction associated with a very high risk of mortality. It includes patients who fulfill the criteria for sepsis, and despite adequate fluid resuscitation, we are resuscitating, still she needs vasopressors to maintain a mean arterial pressure of more than or equal to 65 millimeter mercury and have a lecture level of more than 2 millimole per liter or more than 18 milligrams per deciliter. It is associated with a greater risk of mortality than sepsis alone, more than 40%. So the SOFA score, what we used to see, in fact, it is done in the ICU setting. We look at the respiration, we look at the cardiovascular function, the hypotension, and liver function, bilirubin, renal function, creatinine, and urine output. Coagulation, we have platelets, central nervous system, Glasgow coma scales, and we then give them score of 1, 2, 3, 4, depending on the values. And any score more than 9 is associated with 30% mortality, and more than 11, definitely 90% mortality is there if the woman has reached that much of level. But it's very cumbersome and doing all this. So we have, instead of that, we have a quick SOFA score. SOFA means sequential sepsis related organ assessment score. That's what it means. It has now 3 components which can be done anytime whenever the patient comes to the casualty, and we should immediately do the score and then allocate wherever, whether she should go to a critical care unit or ward, so that depends on that. So it has 3 components that are each allocated 1 point: respiration rate of more than or equal to 22 per minute, alternation, and systolic blood pressure less than or equal to 100 millimeter mercury. Score of more than 2 is associated with poor outcome due to sepsis. So, but in pregnancy, we know that systolic blood pressure may not be up to 100 even otherwise also, because there's a drop in blood pressure due to progesterone effect. So we are in pregnancy, obstetric modified quick SOFA is systolic blood pressure more than or equal to 90. 012 score is accordingly. Respiration rate is less than 25 breaths per minute or more than 25 breaths per minute. Alternation, that is alert or not alert. So this part can be done immediately, and then we assign the score and then we treat them. So it's, as we know, in fact, we are getting more and more cases of sepsis now in our critical care unit instead of hemorrhage, which is thanks to so many webinars on PPH and newer drugs. So we are getting more of these cases, and after hypertension disorder, the sepsis is the next cause of maternal mortality as far as our ICU incidence is there, because it can rapidly progress to septic shock within 24 hours in most cases, and within 2 hours in 50% of women, with especially if she has DBS or group A or group B streptococcal infection. For the causes of sepsis in pregnancy, it could be pregnancy related like chorioamnionitis, endometritis, wound infection, perineal infection, mastitis, or it could be general infection like pharyngitis, RTI pneumonia. Now we are very well aware of COVID also. So everybody knows the management for that. Gastroenteritis, UTI, cystitis, and pyelonephritis, sickle cell sepsis, appendicitis, biliary tract infection, and any PUO can cause septicemia. So what are the risk factors? It's more common in Black or other ethnic minority with the adjusted odds ratio 1.82, and more in primiparas 1.6, pre-existing medical problem, and then febrile illness, or if she has been on antibiotics and 2 weeks before presentation, and now she's got sepsis, then we have held, Dr. Manju has given this oration on antibiotic resistance and those. So if she's been taking that, then she gets infection and gets sepsis, it's very difficult to control them. Women with operative vaginal delivery, 2.49, 2.5 times more. Labor cesarean is 3.83, and after labor onset emergency cesarean, the incidence immediately rises to 8. So I just wanted to say, so we take cesarean so lightly. It's even Cochrane database review as far as 2014, they said that cesarean section after onset of labor has more chances, 7% chances of having a sepsis. And if this antibiotic prophylaxis is not given in time, this incidence rises to 18%. So this is very important, the prophylaxis part, which needs to be taken care of if we want to prevent sepsis. The prognostic factors are host response to infection, anomalies in the host inflammatory response, failure to develop a fever, leukopenia, thrombocytopenia, hyperproteinemia, other comorbidities, age, hypocoagulability have all been associated with poor outcome. Site and type of infection. Sepsis from a urinary tract infection has a lower mortality as compared to nosocomial and respiratory infections due to community acquired pathogens. Timing and type of antimicrobial therapy. I just said early institution of adequate antibiotic therapy is associated with 50% reduction in the mortality rate, but just giving empirical antibiotics without any indication within the past 90 days is also associated with increased mortality. Failure to restore perfusion. This is very important. She has come to us and we are just waiting for tests to come. We should start immediately the resuscitation. So we have this in early goal directed therapy, severely elevated lactate. We should be alert and do the management. So what is the management strategy for best outcome? First thing which I said is early diagnosis. To decrease sepsis-associated mortality, emphasis is placed on the early identification of infected patients. Society of Critical Care Medicine and European Society has assessment score for patients outside the CCU to facilitate the identification of patients potentially at risk of dying from sepsis as quick SOFA score. So that's very important. So how to manage? First step is to stabilize respiration. Start oxygen. Monitor with continuous pulse oximetry, intubate if required, if she's come in such a condition with a high SOFA score. Step 2 is assess and restore the tissue perfusion, establish venous access, peripheral and central, because we have to give a lot of fluid to find out the CVP and others. That's important. And third is, of course, along with that is antibiotic administration. For hypoperfusion, critical hypoperfusion can occur even in the absence of hypotension, especially during early sepsis. Signs of hypoperfusion include warm, vasodilated skin in early sepsis, cold, vasoconstricted skin in late sepsis, tachycardia, restlessness, oliguria, or anuria, and lactic acidosis if we do the ABG and lactate levels more than 2 millimole per liter. Now, how to restore tissue perfusion? We should give them IV fluids as first-line therapy. Fluid bolus with 500 ml of normal saline or ringer lactate are repeated until we have to give like a PPH, we have to do that. Until blood pressure and tissue perfusion are acceptable, pulmonary edema has started coming, or further response is not coming. You have already given her 2 liters and response is not coming. And we should not use any albumin containing solution or a hypotonic starch solution. Only crystallized solutions should be used for this purpose. What is our goal to resuscitate initially? Mean arterial pressure more than 65, urine output more than 0.5 ml per kg per hour. CVP should be between 8 to 12 millimeters. Central venous, superior vena cava oxyhemoglobin saturation should be more than 70%. Mixed venous oxyhemoglobin saturation should be more than 65%. Lactate clearance, which is initial lactate minus lactate more than 2 hours later, divided by initial lactate into 100 should be monitored. These levels should be monitored 2 to 4 hours interval, and we should be seeing that what is helping or not. Then if still, in spite of this perfusion and giving the fluids, she's not coming out of that means she's reached the septic shock stage, we need to give them vasopressors. You know, most of the times what we have seen is the people start with dopamine. Dopamine is not to be given in these cases. Preferred initial agent is norepinephrine. And those women who are refractory to IV fluids and vasopressor therapy still it is not helping, then we should give them inotropic therapy with dobutamine. And packed self-perfusion may be given if hemoglobin is less than 7 grams per deciliter. Now, while we are doing this initial part of resuscitation, oxygen, and perfusion, it should identify the septic focus. Unless we deal with that, it will not help you. So we have to send all the cultures before starting the antibiotics from blood, urine, high vaginal, wound discharge, sputum culture, whatever is the site of infection, we should be taking the samples and then start with the antibiotic. Now, antimicrobial therapy, I'm not going to go into the detail. They should be administered within 1 hour of presentation, preferably after appropriate cultures have been obtained. Empirical broad spectrum antibiotics, when a definite source of infection cannot be identified, to be done in non-neutropenic patients only in ICU, and later on it may be needed, but not initially. The points to remember is fluid resuscitation leads to expanded extracellular volume. So higher initial loading dose should be given. Like if we are treating for GBS, vancomycin 25 to 30 milligram per kg, maximum 2 grams to be given initially, along with teicoplanin, 12 milligram per kg, 12 hours for 3 doses, and loading dose, and then 3 milligram per kg daily needs to be given. This we had this surviving sepsis campaign 2018, the 3-hour and 6-hour bundles. Now they have all been combined into a single 1-hour bundle. That's when the initial 1 hour we have to do all this before going further in order to begin resuscitation and manage immediately if we want to save the women. This 1-hour bundle I've already said, measure the lactate level more than 2 millimole per liter, obtain blood culture prior to administering antibiotics, administer broad spectrum antibiotics, begin rapid fluid transfusion of 30 ml per kg of crystallite, start vasopressors if she is not able to come up. So for the septic shock is then along with antibiotic, now it all depends what, and we have a MRSA or we have Pseudomonas. So without going into the details of which antibiotics, cephalosporin third generation, beta-lactamase inhibitors, piperacillin, tazobactam, ticarylcin, flavonate, imipenem, meropenem, these are the initial, we have to attack it strongly. We need to give these antibiotics initially. And if we are suspecting Pseudomonas also, then we need to give them ceftazidime, cefepime, imipenem, meropenem, piperacillin, tazobactam, chloroquinol, or aminoglycoside, gentamicin, amikacin, and if it is a peripheral sepsis, we might have to clindamycin or metrogel also. And once we have started that, we de-escalate the antimicrobial therapy as soon as the cultures are available, or after clinical response to therapy, or after and then we have to look for the septic focus. Where is the septic focus? Why is she getting the infection? We need to look into that. And we have to treat that source. Unless we treat the source and control it, she will never come out of her sepsis and septic shock. That's very important. So additional therapies which are there, glucocorticoids, IV hydrocortisone 200 milligram per day in women unresponsive to adequate fluid resuscitation and vasopressor administration. Venous thromboembolism prophylaxis also needs to be done. She's in ICU setting. All these patients, we immediately start with the low molecular weight heparin. And prophylaxis for stress also needs to be given with PPI or histamine 2 receptor antagonists. Immunoglobulins, intensive insulin therapy, external cooling or antipyretics, nutrition, early maybe parenteral nutrition, but we prefer giving rice tube in combination with enteral feedings. Renal replacement therapy, dialysis, etc. needs to be done, and bicarbonate therapy also is required. So it is all under the control of the critical care specialist and the infection specialist which needs to do. So all the complications of sepsis we know is respiratory failure, ARDS, nosocomial pneumonia, renal failure, GI bleeding, anemia, DVT, IV catheter-related bacteremia, electrolyte abnormalities, hyperglycemia, and DIC. So this can occur along with the sepsis. So to summarize, I must say the alarm findings which we need to take care is fever more than 103 degree Fahrenheit, or along with heart rate more than 110 minutes over first 30 minutes, respiration rate more than 25 in pregnancy, otherwise more than 20 per minute over 30 minutes, BP less than 90 over 30 minutes, manual WBC count more than 10 bands, left shift in bandemia, lactate level more than 2 millimole per liter, oliguria, or change in mental status. So these are the important findings we need to be looked into and do quick SOFA score and start your 1 hour bundle. The take home message, I'm repeating again, prompt fluid and oxygen therapy, antibiotics, and surgical intervention. So this is that 1 hour bundle we go about. Thank you very much. I deliberately didn't go into the details of the sepsis. It's a big chapter. So
Yes.
Salient points only.
No, it was wonderful. Dr. Surekha, please.
Yeah. Ma'am has very beautifully and very in an elaborate way, she has covered everything so nicely. And she's not left any stone unturned to make us understand this difficult topic. And she covered it really beautifully. And from the beginning to the end, it was just wonderful, ma'am. Thank you, ma'am.
Thank you, Dr. Surekha, and thank you, Smita, ma'am, for this lucid and a very, very short but very explanatory, very crisp talk. Moving on, we come on to the third talk of this session, of this symposia. I invite Dr. Anu Sidana, the chairperson for this. Dr. Anu is a gold medalist, director, Astha Medicare, and she has fellowship in laparoscopic surgery, IVF, infertility, and special interests in managing high-risk pregnancies, fertilities, treatments, and ultrasounds. Welcome, Dr. Sidana, and please invite our next speaker, Dr. Vani Malhotra.
Thank you, Dr. Jyoti, ma'am. First of all, I want to thank Dr. Ragini, ma'am, and Dr. Saroj, ma'am, for giving me this opportunity. And I really feel privileged to invite our next speaker. On the topic of the next topic would be referring protocols. We have dealt with life-threatening complications in the previous session. Now, what to do when we want to refer the patient? For this, I want to invite our next speaker, Dr. Vani Malhotra, ma'am. She is professor in IPGIMS Rohtak. Her area of interest is in gynae oncology, high-risk pregnancy, laparoscopy, and she has more than 100 publications. And she has received Amrendranath Dawn Prize for Best Paper Presentation in AICUG 2019. We welcome you, ma'am.
Thank you, Dr. Anu. And at the outset, I would like to thank Dr. Ragini for giving me a chance to speak on this topic. Am I audible, Dr. Anu?
Yes, ma'am, perfectly.
I'm sharing my slides. So to define what is the referral system or the referring protocol, it's a process in which the treating physician at the primary level, by virtue of his qualification or lesser facilities at his level, whichever level he is, whether a primary tier level or a secondary tier level or a tertiary tier level,
seeks the assistance of a better qualified or a better equipped higher level of care to manage a clinical condition temporarily or permanently. I'm saying temporarily. Why? Because after receiving the treatment, patient can be transferred back to the same facility. It is a two-way process. What do you mean by two-way process? That there can be the forward referral as well as the back referral. And the most important of referral system is does not mean transferring the responsibility. It is mainly the sharing the responsibility in managing the patient, in diagnosing the patient's condition and giving the treatment with utmost importance. So, to the referral system, which we know is very important, and to make it efficient, we should divide the referral system into primary tier system, the secondary tier system, and the tertiary tier system. The primary tier system usually consists of the first level of contact between the community and the patients. That is like PHC levels, CHC or sub-center levels. Usually the ASHA worker becomes the primary level of contact between the community or the patients with the health system. ASHA is an accredited state health worker who becomes the first contact between the community who takes the patient to the health system. And the secondary tier system usually consists of the district hospitals, and the tertiary tier system is the medical colleges where the patients are being referred from primary tier to the secondary tier, and after receiving the treatment, after completing the treatment, the patient can be again back referred to the primary tier and the secondary tier system. So this is the diagrammatic representation of the overall referral system. There is the first, the community. From community, the patient is transferred to the primary tier system and there to the secondary and the tertiary referral facility. So this is a referral loop which consists of the back referral as well as the facilitated referral. The forward referral. The forward referral will be from the primary tier system to the secondary tier system, and the back referral will be from the tertiary referral. After receiving the treatment, after adequate treatment facility, the patient will be again back referred to the same tertiary system and will receive the follow-up care at that area only. So the referral system can be from the family physician to the hospital specialist, from one specialist to the another specialist, from a junior specialist to the senior specialist, from a private hospital to a government hospital. So all this constitutes the referral system. The basic aim of the referral system is to provide the utmost patient care to the patient so that he is not neglected. The basic aim of referral system is to provide the utmost care in the healthcare system. So these are the components of the referral system. The health system is the referral system. The total and there is an initiating facility which will be going to refer the patient to the receiving facility at the referral center. And there are certain guidelines which are known as the referral practicalities, which differs according to there are certain standard operating procedures for each institution for the referral system. And to supervise this all system so that there is no undue referral, there is a supervision or an auditing system which will look into the referral system, that the patient is being planned or referred in a nice manner. He is not basically the patient should not be counseling should be done and patient should not be unnecessarily referred from one tier to the other tier so as to avoid the complications. So the types of referral can be mandatory referral or elective referral. For example, when we take the obstetrics and gynae, mandatory referral is in which the patient is likely to suffer harm if not referred. Like a patient of suppose the delivery is being taken at a primary healthcare system or a PSC or a sub-center, that if a patient have complications like inversion of the uterus, if the patient is not referred in time, patient will get harm. So this is a mandatory referral. Elective referral, suppose the patient is getting the treatment for a fibroid uterus, the doctor on the duty wants to know that if she needs a myomectomy or a hysterectomy, or the patient is, there is no emergency in referring the patient. So that referral is known as the elective referral, where the patient is unlikely to suffer harm if not referred. What are the reasons why we are referring the patient? We are referring the patient to seek the expert opinion regarding the diagnosis. Suppose I am seeing a patient at primary tier. I am seeing a patient with certain complaints. I don't have any facility for investigation. I don't have the facility for examining the patient. So, but the patient, so to seek the expert opinion, I can refer that patient to the civil hospital. I can refer that patient to a medical college to have the diagnosis of the complaints. Or when the primary physician, if she has admitted the patient, but she is treating the patient, but she is not satisfied with the patient progress, then the patient can be referred. It is not unnecessarily the patient should be kept in the hospital even if he is not progressing. For additional diagnostic and therapeutics, like patient is admitted, she needs any MRI or CT scan if it is not available in that institute. So for additional diagnostic and therapeutics, the patient can be referred to the other tier of the for this the timely referral is the most important in the referral system for managing the life-threatening conditions like inversion of the uterus, postpartum hemorrhage, management of the vulval hematoma. Patient should be immediately referred. The next reason for referral is when the patient or the family shows the lack of confidence in your diagnosis and the management. You are treating the patient, but the patient is not satisfied. The family members, they are not satisfied with your diagnosis and management. Then the patient should be immediately referred to avoid the hostile environment. If there is a medical legal concern by both the parties, then the patient should be referred to the next tier of system without wasting time. Now, what is the rationale of referral system? Why this referral system has been made? It has been made to support the primary healthcare facilities, which is usually the level of contact between the community and the healthcare. There are a lot of complaints the patients are coming with. The minor ailments can be taken up at the primary healthcare levels, and the complicated ones can be referred to the medical college or the higher center. So the unnecessary overcrowding at the health centers, like higher centers, like the medical colleges, they are avoided, thus providing the management of genuine cases. Like at we are serving at the medical college, so we can have proper time for the complicated patients. We can manage those patients. We can work up those patients without wasting our time on unnecessarily on common cold or PID, vaginitis. These all conditions can be treated at the primary tier system. So basic aim of the referral system is to keep the minor ailments at the primary health centers and to keep the complicated cases at the tertiary care level. A good referral system will provide the best optimal care at appropriate levels, but which will not be unnecessary costly also to the patient. And the primary health facilities are well utilized with this referral system, and the patient access will be more and in a timely way to the specialist care. The patient won't be wasting the time unnecessarily on diagnosis at the primary health center. He is unnecessarily getting the treatment without making the diagnosis. So this will be helpful in our providing the health care. So guidelines for the referring institutions, there are certain guidelines for the referring institution. The medical officer in charge who is treating the patient has to sign the referral card before sending the patient. He has to sign the referral card. He should put his stamp, his phone number also, so that if the receiving institution wants to inquire about something, he can telephone the patient telephone the treating doctor at the primary health center and inquire about the treatment which he has got or he has received at the primary center. And before referring the patient, there should be definitive and convincing, always should be definitive and convincing indication for referral. ऐसे नहीं कि पेशेंट को हम दौड़ा दें वो कि आज उसको रात को रुकना नहीं पड़े प्राइमरी हेल्थ सेंटर पे तो उसने भगा दिया पेशेंट को. No, it should not be like that. There should be always a definitive and convincing indication for the referral, and reason of referral should also always be mentioned in the referral card. The investigations which have already been done in the primary healthcare system or the secondary tier system should always be mentioned in the referral card, whether they are hematological investigations or the radiological investigations. In the pending investigation, it is a duty of the referring doctor that if they are pending investigations which are awaiting the result, when he receives the results of these pending investigations, they should be communicated to the referring doctor. And the referral should never be done for the conditions like HIV, HPS antigen. कि patient HIV positive है, HPS antigen positive है, go to the medical college. वहाँ delivery होगी. No, they should be. If you want to have some opinion about these ART or some antiviral therapy, then you can always take the help of the tertiary level. But the delivery should not be referred for the only simple reason that they are HIV positive or HPS antigen. Whenever the doctor is giving the referral card, the writing should always be legible. ऐसे कोई घुगी नहीं मारनी doctor को. The writing should be very legible, indicating the indication of referral, what is the diagnosis, what the treatment patient has received, and the counseling of the patient and the relatives should always be done to avoid the hostile situation. Patient को ऐसे धक्के मार के नहीं भेजना कि जाओ. You have to counsel the patient why you are sending the patient, which OPD he or she has to consult, कहाँ उसको पहुँचना है, उसको सब बता के भेजना है. Details of the referring patient should be noted in the referral route register. There are two registers, the referral out register and the referral in register. The referral out register is for the referring institution and the referral in register is for the in the receiving institution. So all the details of the referring patient, what is the name of the patient, what is the age of the patient, what is the indication of the referral, what are the investigations being done in your institution, they all should be written in the referral out register, and only then the patient should be referred. In case of emergency referral, like if you are dealing with the case of PPH, you are dealing with the case of uterine inversion or patient has thrown a fit, the transport facility should always be provided to the patient. Patient should not waste his or her money on the transport, but the referring institution should provide for the transport facility. If the patient is critically ill, like patient is in shock or the condition of the patient is worsening, then an appropriate well-equipped functional ambulance should be sent along with a medical officer, because if the patient needs resuscitation during the transport, there should always be a medical officer or staff nurse who is accompanying the patient. And the most important guideline for the referring institution is timely referral. Once you have decided that the referral is important for the patient care, then the patient should be referred without wasting time. So timely referral is the most important in the referral system. And all the possible treatment and care, the primary care should be always be given, and then only the patient should be referred to the referring institute. This is the referral card, the copy of the referral card. It mentions the name of the patient, the address of the patient, what is the age of the patient, what is the date and time of the reference. Then a brief on the illness. A small case summary should always be written, what all investigations has been done, and what is the working diagnosis of the patient, the treatment given. Suppose the patient has received LifeCell, is a patient of eclampsia, whether you have given LifeCell, whether you have given injection labetalol, this should be always be written in the referral card so that it is helpful for the attending doctor. Now, reasons for the reference should always be written, that there is no facility for giving the No, for taking the investigations like CT or MRI. There is no facility for blood transfusion. There is no facility for the cesarean section or the neonatal facility. So the reason for reference is always written so that the attending doctor become wiser to attend the patient. And last of all, the signature, name and designation of the doctor should always be put on the referral card so that he can be communicated for any inquiry. This is the referral in register. It will referral in register. The receiving institution will enter the referral in register, the name of the patient, the treatment, what is the indication of the referral, and then whether any referral card is being given. It should be mentioned in the referral in register for future auditing of the referral system. Now, the patient has been received at the receiving end. Now, what are the various guidelines? The referred cases should be promptly received without delay. Whenever a referred patient is being accompanied in an ambulance or patient is coming by herself, the referred cases should be promptly received. At first priority should be given to the referred cases. Details are documented in the referral in register, and whosoever is coming along with the patient, the communication with that person should be courteous. It should not, that patient should not be the attending, the accompanying person should not receive the open comment, or should not, the doctor should not be criticized why you have sent this patient, you should have given the treatment like here only. No, the patient should be received with open hands and should not be criticized for the treatment which is being given at that center. So communication to the, and if there is a very high communication to the press and media should be given only to the hospital administration. Suppose any rape victim or the sexually rape victim has come to you and that is media highlighted. So there will be many questions from the press and media. We should not give the statements alone. The treating doctor should not give the statements to the press or the media. It should be to the PRO of the institution or to the hospital administration. All the emergency cases are to be accepted without fail. They have to be accepted.
2 minutes are left.
बस थोड़ा सा रह गया मैं. And unnecessary shunting of the patient should be avoided. This patient does not belong to me. This belongs to the primary tier. So unnecessary shunting of the patient should always be avoided. So once the patient has received the treatment at the higher level facility, then the patient can be back referred for the stable chronic condition for the follow-up care. And again, there are guidelines for the back referral. The back referral should be after a reasonable period of care from the higher care center. It should be with instructions to the primary tier that what they have to follow up. The hand contact number should be provided, whether they have to monitor the PP, whether to take, when to take out the drain, when to take out the stitches, when to take out the SRC, and that should also be entered in the register. The advantages of the referral system is for the convenience of the patient and for improved quality improvement care. And the monitoring of the referral process can be done by the state level and the district level committees by the regular auditing. And the unnecessary referral should have penalty, should have kind of punishment, that these cases are referred without indication, without referral card. So to conclude, the referral system is essential for cohesiveness and the integration of the healthcare delivery system. Most important is the primary referral. It is sharing rather than transferring the responsibility. Cooperation between that is the positive contact between the health professional is most crucial, and which is backed up by the written protocols. Every institution should have standard operating procedures for the referral system, and the monitoring of the whole system should be done with the periodical audits and the random reviews. Thank you so much.
Thank you, Dr. Vani ma'am. It was really a very wonderful session which we have attended. I just want to make a comment. When you are following proper referral protocols, in that case, lot of time is saved at the receiving end, so the patient management becomes better. So yes. Thank you. Thanks a lot.
The waiting time for the patient is also reduced.
Yeah.
If he goes directly or as compared to the referral system, or when he's referred, the waiting time is very much reduced for the patient.
Yes. And time is very important when we are dealing with all these emergency referral patients. Thank you, ma'am. Thanks a lot.
Thank you, ma'am.
Yeah. So moving forward, our last talk is in this particular symposium of the saving lives. Now patient is referred. Where and what we are going to do is Obstetrics HDU. And I invite the chairperson of the session, Dr. Sonam Sachdeva, who is a IVF specialist. So Sonam is there?
Yes.
Yeah.
Good evening.
Good
I've
evening.
been here
Good
since
evening,
morning.
Dr. Sonam. Sonam is a
wonderful
IVF
session, ma'am.
specialist from Karnal. And I will not read, you can read. I can only say she's a very, very affectionate person. And when we did the HARObGyn and the only one annual, under her presidentship, it was a wonderful conference, what you have done, Sonam. And thank you so much for that.
It was a teamwork, and special thanks to Dr. Madhu Chaudhary, who under whose guidance I did all those things.
Over to you, Sonam.
Good evening, everybody. And I invite Dr. Just hold on. Yeah, I invite Dr. Sheba Marwa. She's an associate professor in Department of Obstetrics and Gynecology. She is my alumni college is Safdarjung Hospital. I welcome you, Dr. Sheba, and awarded with so many awards and member of so many committees. And she'll deliver a talk on the role of HDU. Now, HDU is a high dependency unit, short of ICU, just in the staff pattern. So we go ahead. It's a new term for many gynecologists. Welcome, Dr. Sheba.
Thank you, Dr. Sonam, for this kind introduction, and thank you, Dr. Ragini ma'am, for giving me this opportunity to be with this August gathering. So without wasting any time, I would go ahead with my talk. All this while we've been hearing management of different critically ill pregnant women like PPH, preeclampsia, hypertension, sepsis just recently. So where these critically ill patients have to be managed is the important question which I am going to answer is that is the obstetric HDU or the ICU. So the critical care unit obstetrics, my talk would entail what is the genesis of the concept of HDU, what is the scope of an obstetric HDU, and what is the planning and setting up of HDU be like, what space, what location is required, what are the equipments required for working of an obstetric HDU, what are the operational guidelines, and how do you manage patients at HDU, when to shift a woman to an obstetric ICU, and how should we do the audit and the record keeping at the obstetric HDU, and what is the capacity building and the training of the staff which is working in the HDU. And I should begin with my talk. Looking back at the maternal mortality trends, the WHO fact sheet of 2019 showed that every day in 2017, approximately 810 women died from preventable causes relating to pregnancy and childbirth. Though the incidence of maternal mortality has dropped over the past 20 years by about 40% worldwide, yet 95% occurred in the low and the low middle income countries. And skilled obstetric care during childbirth and after childbirth can save the lives of many such women and newborns. The maternal mortality ratio by country shows that the Indian maternal mortality rate stands at 145 per lakh live births, which is quite high. And the causes of maternal mortality in India, the leading are the hemorrhage, the sepsis, and the preeclampsia. And they occur mainly in otherwise healthy individuals. So high-risk obstetrics, what is that? Well, pregnancy itself is a high-risk condition. Now, coming to the GDP allocated across the world, India has a very poor show when it comes to only less than 2.2% of the per capita income. And this is a major roadblock when it goes to achieve the sustainable health goal of 2030 of reaching the maternal mortality of less than 70 per lakh live births. So the critical care in obstetrics, the efforts have been though half-hearted by the government till so far because of many social, economic, political, and the attitudinal factors. So the maternal mortality is just the tip of the iceberg, as most of the senior stalwarts before me had emphasized upon, with the vast tip of the iceberg being the near miss with a severe acute maternal morbidity. The critically ill parturient is always a challenge because of a complex homeostatic physiology in the pregnant state, where two lives are at risk at the same time. And when things they go wrong in obstetrics, they go wrong very fast and they fall off a cliff. And we have to halt this continuum of severe morbidity being changed to severe morbidity and near miss to halt the maternal mortality rate. So there are different delays in maternal mortality when we do a root cause analysis. And the FIGO says that the maternal health ecosystem can be defined only when all these barriers are removed. And today we are going to cater to this hospital barrier. That is where the concept of HDU came in vogue, where the timely recognition of sick or high-risk obstetric patient is given a dedicated quality care in this. And that's why the level 2 patients, the level 2 care is given to such women. The level 2 care is provided to all these critically ill women admitted to the obstetric ICU or the HDU. So what are the advantages of obstetric HDU? It provides a concurrent availability of experts, obstetric care and critical care management, avoidance of hazards of emergency transport. Suppose a patient deteriorates and she requires obstetric ICU. Improved continuity of antenatal and postnatal care is ensured. So initially, when this concept came, a lot of confusion was there, a lot of hesitancy was there, how to get started, how to set up an HDU, and a lot of brainstorming was there. But when we came with the crystal clear vision, when the MHF guidelines of 2016 came in vogue of setting up of obstetric HDU and ICU, and these guidelines, they were complemented well with the MHFW operational guidelines for the obstetric ICU and HDU in conjunction with the UNICEF in 2017 and 18. So they had a triage policy laid down where the woman could be admitted either to the labor room or the obstetric HDU and the obstetric ICU with very objective admission criteria. And then according to her course of event, she could be displayed either stepped up or stepped down as pertained to the obstetric care she's receiving in that hospital. So obstetric ICU is an ICU which is separate from the normal ICU of a hospital, dedicated only to obstetric patients who have developed multi-organ failure necessitating specialized care by super specialists like intensivists, nephrologists, cardiologists, pulmonologists, endocrinologists, over and above the obstetrician and gynecologist. Whereas an obstetric HDU is an area in the hospital where these women can be cared more extensively than a normal ward, but not to the point of intensive care. So it's also a kind of an intermediate care unit where patients in obstetric HDU, they may either require an ICU admission later on, so that is called as the step-up management, or at the same time, these patients in ICU who had an improvement in their condition may be shifted back to the general ward, that is the step down from the HDU. So how to set up an obstetric HDU or an ICU? As per the guidelines, the government says that all district hospitals should have an obstetric ICU, and the medical colleges should have both an obstetric HDU and an ICU. And for this, if the resources permit, it is recommended that every medical college should have at least a 4-bedded obstetric ICU, which is attached to the obstetric ICU. The HDU is specifically staffed and equipped. It provides an intermediate level of clinical care, as I've already emphasized. It provides invasive monitoring and support for the patients who are at risk of developing acute or single organ failure. It acts as a step up or a step down unit between the level of the care delivered in a general ward and intensive care, and it admits patients where the predicted risk of clinical deterioration is high or unknown. So based upon the delivery load of a particular hospital, it was recommended that a hospital where the delivery load is around 250 to 500 deliveries per month, an 8-bedded HDU is warranted. Where a 501 to 1000 deliveries per month, most of the medical colleges come here, it requires an 8-bed hybrid ICU, that is a 6-bedded HDU along with a 2-bedded ICU. And where the delivery load is more than 1000 deliveries a month, a 4-bedded ICU plus 8-bedded obstetric HDU is required. So this hybrid model of obstetric care was aimed for optimal utilization of resources in medical college and hospitals where there's inadequate load for a separate ICU. So what are the specifications of an obstetric HDU? It should be ideally located near the labor ward or the OT. Approximately the area designated should be around 120 to 130 square feet per bed, and there should be an adequate partition between the beds. There should be single entry point. The HDU should be well lit, and equal area should be there, which as an extra space or an ancillary area. Also, that hospital should have an in-house or nearby blood bank facility, fully equipped laboratory, and nearby NICU care. And also, there should be a provision of around 150 square feet area isolation room with a separate entry. And this should be at one end in the obstetric HDU for management of high-risk mothers with infections requiring isolation, like HIV positive, H1N1, HPSAG positive, chickenpox, etc. And as I've already told you, they should have a separate entry from the entry for the rest of the HDU patients. So this is the model, which is the 8-bedded obstetric HDU. This is laid down by the Government of India guidelines of 2016 for setting up of the HDU. So what is the infrastructure required? It requires all the infrastructure, that is starting from the Fowler's bed with provision for lithotomy, the multi-parameters monitors, oxygen, air suction for every bed, warmers, syringes, pumps, infusion pumps, the ultrasound, the DVT pump for thromboprophylaxis, the ventilators, the BiPAPs, the defibrillators, and the state-of-the-art, the ECG machines, the NST machines, emergency oxygen supply, and the invasive monitoring tray as well. So the scope of an obstetric HDU is all those women who are having obstetric complications or the pregnant women with medical complications who require intensive care or a high dependency care more than the general ward. So what is the comparison between the HDU and ICU? I've already told you in terms of dysfunction. If a single organ dysfunction is there, a woman requires more care than the general ward. She is admitted into the obstetric HDU. But if a patient has multi-organ failure, she requires inotropic support, assisted ventilation, DIC, ARDS, or she is an adequate candidate for an obstetric ICU. So as per the guidelines, the bed requirement is 10% of the obstetric patients in obstetric HDU and only 1% in the obstetric ICU. But most of the major tertiary hospitals, they have around 30% of the obstetric patients being admitted to the obstetric HDU and around 10% of these going to the obstetric ICU. The facilities required in the obstetric ICU are the same as HDU, plus they have the facilities for invasive monitoring, the ventilators, the bedside dialysis, plasmapheresis, and the pacemakers. Capacity building and training is essentially required, and a financial burden is always there on the hospitals. The emphasis should be laid down to control the infection in the obstetric HDU, which is more in obstetric ICU, and the environment should be made patient-friendly in obstetric HDU, and it is less patient-friendly in obstetric ICU. So the in charge is an obstetrician in both, along with anesthetist and critical care specialist in obstetric ICU, and the human resources, the staffing. The nursing ratio is important because it is 1:1 staff nurse for 2 patients in an obstetric HDU, but 1:1 in an obstetric ICU. So the human resource requirements for the obstetric HDU, they require a medical officer, 1 per shift per unit, staff nurses, 1 per 2 bed per shift, and assistants, existing LRDEOs, and cleaning staff and guards as per requirement, whereas in ICU, the staffing is changed to 1:1 ratio. So a hybrid ICU in most of the medical colleges, which is being advocated, can be made functional, employing 1 anesthetist and intensivist, 4 medical officers round the clock, 20 staff nurses, and 1 assistant, and cleaning staff and guard as per requirement. So the multidisciplinary team I have already explained. These should be supported by the support staff, that is the pharmacist, the dietitian, the counselor, the housekeeping and the cleaning staff, the security, the data entry operator, the electrical technician, and the biomedical engineer. So an organogram is also being laid down that the medical superintendent is the overall in charge of the obstetric HDU in the ICU. He or she designates the head of the department as the nodal officer or the designated officer in charge of the obstetric HDU. In conjunction with the anesthetist or intensivist, they take care of the obstetric ICU as well, and they have medical officers under them working round the clock with staff nurses and the MENA assistants. So then we come to the guidelines and the protocols. The ministry has made our life quite easy. They have protocols and checklists in place that ensure and encourage appropriate immediate responses to the critical situation. So there are guidelines for admission and discharge criteria, resuscitation of a pregnant woman, management in case of failed or difficult intubation, management of major hemorrhage, preeclampsia, eclampsia, management of post-operative pain, thromboprophylaxis, the monitoring charts, and the ICU care bundles. So again, which women they require obstetric HDU? I have already explained this. All women entailing maternal collapse and requiring monitoring essential more than the general ward are admitted. Now, the important to remember is that whenever a patient is being shifted from a general ward or a triage room to obstetric HDU or ICU, the family should be informed. The companion of pregnant women also should be informed of the decision, and consent should be taken. All case sheets containing history, examination, investigation, management should be maintained. The obstetric HDU staff should be appropriately informed. The patient should be escorted by the doctor or staff with all existing treatment, including continuation of patent IV line, and oxygen and supine hypotension prevention is also should be ensured. Ensuring the patent airway is important. And if a mother is quite sick, the baby is shifted not along with her, but to the nearby MNICU. The referrals from outside to HDU, my previous speaker, Dr. Vani ma'am, has already told that the completely filled referral slips should be attached and should be available. Availability of emergency medications should be there while transferring during referral. So there are different guiding principles for CCOB admission. Institution specific criteria are to be followed, and admission triggers should be specific to pregnancy and related complications, where the concept of modified early obstetric warning score came into this system, that is the track and the trigger system. Depending upon how, if the patient is in green zone, she can be discharged back to the ward. If she's in red, she requires ICU, and the action plan can be formed for each patient. So most commonly used are the UK criteria, and the others are the US model, also used in some hospitals where the maternal early warning triggers are essentially used. And the Indian version is also there of the Satarkatak, adopted from news, which is introduced now in the medical wards. Indications for admission I've already explained. Now, once the woman is admitted in obstetric HDU, then her management depends upon the underlying clinical condition. It has to be tailored to her needs, and an individualized treatment should be used. Initial assessment of her and her baby's condition should be made. Immediately she should be resuscitated. Some baseline and specific investigations should be carried out. Try to treat her primary condition and involve appropriate clinicians from relevant specialties. Again, the maternal observations, the fetal observations as per the protocols, all the protocols should be displayed in the obstetric HDU, and they should be managed, they should be followed stringently. The care for fetus in obstetric HDU and ICU is equally important in conjunction with the pediatrician and the neonatologist after birth. So most of the women during this stay, they will deliver, and 90% of mothers, they will be discharged with a newborn or an infant. So nearby MNICU is required for the care, and once mother is conscious and she's able to breastfeed, that should be encouraged. So the blood products requirement in obstetric HDU is also laid down. As already said, these hospitals must have a 24/7 blood bank available with them. Now, when to discharge a woman from an obstetric HDU? When a patient is conscious and alert, she's stable, she has normal respiratory status, she's stable, normal hemodynamic parameters, and no longer she requires an intensive or invasive monitoring with 4-hourly recording of vital signs. And again, the patient can be cared for in general ward. The average time duration of stay in an HDU is usually 24 to 72 hours, and the discharge or the transfer back should also be accompanied with a full written document. There are proposed discharge sheets also laid down in the guidelines for everyone's reference. And indications of transfer from HDU to ICU have also been, I have already explained. And once the patient is in obstetric ICU, different scorings are used to monitor her health. And these are the SAP scores and the Apache scores, and she's given the management. Now, in order to ensure a focus on quality and ensure standardized recording and reporting formats for obstetric ICUs across the India, there are various formats available in these guidelines, laying down the admission register, the formats for the maintaining of the case sheets in an obstetric HDU and the ICU, how to fill the admission forms of such patients, then how to fill the past history of this patient, then what are the orders given, then the format of SOFA score calculation for each individual, then the progress note formats, then the investigation sheets, and the patients who are on ventilator detailed charting, then discharge card and the facility follow-up card once the patient is discharged from the obstetric intensive care unit. Also, for the monthly reporting, the obstetric HDU, human resource details and the interventions done for each patients are entered, and the formats are available for this also, and the monthly reporting format of the obstetric ICU with the causes of admission, the reasons for admission, shifting bed occupancy, and average length of stay are being listed. Now, all this cannot be achieved without adequate trained staff and clinicians across all over India. And for this, capacity building and training is very essential. So the basic resuscitative measures, training for intubation, IV line and medication, blood and component transfusion, daily checking on the emergency or the crash cart, ICU procedures, training for obstetrical emergencies and emergency drills, they should be carried out once on induction, and then every 3 months they have to be reinforced. So the objectives of the training plan has also been laid down in the guidelines, and these major components have been identified, and they should be learned, they should be well versed with the basic life support CPR also, and they should also be told about the infection prevention control policy and the biomedical waste disposal as well. So the proposed skill stations, the training can be done at the HDU or the ICU itself, or it can also be done on the mannequins in the skill lab as well. So there are different training modules, and the guidelines, they say that an obstetrician requires a 10-day training. The medical officer also requires a 20-day training. The staff nurse requires a 30-day training, whereas the assistants, they can be trained for 1 day in data management training after the launch of the software. So the infection control, prevention control in HDU, a word about that as well. We follow the same zonal concept and the hand hygiene and the glove pyramid laid down by WHO. The antimicrobial stewardship is followed as per the hospital requirements, and we laid down strength on these 7 pillars of preventing control infection, that is following the guidelines and safety culture as well. So a time for review, so far so good. The Lux document 2018 has shown that ICU transfer of the patients maximum were because of antepartum obstetric hemorrhage or because of postpartum hemorrhage, followed by hypertensive disorders of pregnancy and sepsis. And introduction of this HDU concept has led us to decrease in maternal mortality by 62 to 25% before 2014 and after 2016, which is a very great motivation for all of us. So the take-home message is that a critically ill parturient is an obstetric challenge with her underlying pathology exaggerating physiological changes, and the sudden influx to tertiary care institutions, thanks to all the referrals beyond the capacities, increases the maternal mortality rate, and currently they are all saturated, and this results, despite our best efforts, suboptimal results in reduction of maternal mortality. So the dedicated obstetric HDU or ICU with knowledge, familiarity, expertise of an obstetrician and a specialist team is the need of the hour. Obstetric HDU can be easily established in most obstetric units in a room which is equipped for it, allowing continuity of the antenatal, intrapartum and postnatal care provided by the same team at the same time, and developing standardized recording and reporting formats for implementation across the country with a targeted capacity building plan for training, besides defining roles and responsibilities of various cadres at a facility level, will go a long way in decreasing the maternal mortality. So our goal is to provide healthy mothers with healthy babies and to save lives. And for that, we still have a tough road ahead of us, but difficult roads often lead to beautiful destinations. Thank you.
Excellent, Dr. Shiba. Very comprehensive, crisp, and a fast talk. You covered almost every point, touching on the maintenance and floor areas to one who gets interested in setting up one HDU. And Dr. Shiba, I have a question for you.
Yes, ma'am.
Does Safdarjung have a HDU?
Yes, ma'am. The pictures I showed in between were of Safdarjung Hospital only.
Very good. Congratulations.
Thank you.
And thank you, Dr. Shiba, for this wonderful talk. And I take it a lot of pleasure to thank Dr. Ragini for inviting me as the chairperson to this talk. Any questions?
Any questions nahi honge ab.
Okay, ma'am.
We are very, very late. Very,
Right.
very late. Yeah.
Okay.
Thank you, Sona, for joining. Thank you so much.
Thank you,
Shiba,
ma'am.
it was excellent what I was expected from you.
Thank you so much, ma'am.
Okay.
For the next session, I would like to invite the chairpersons, Dr. Bhavna Agrawal. Can you have the CV of Dr. Bhavna?
Yes, ma'am.
She is Senior Consultant, Department of Obs and Gynae, Balaji Medi Center, Panchkula. She has special interest in high-risk obstetrics, fetal medicine and gynae lepro, executive member of Chandigarh Obs and Gynae Society, HARObGyn, and secretary, Women Wing of Panchkula, and life member of AOGD. Welcome, Dr. Bhavna, to chair this session. And next chairperson, I would like to invite Dr. Suman Yadav. Can I have the CV of Dr. Suman? Dr. Suman Yadav is holding the position of Director, Pushpanjali Hospital, Medicare, Gurgaon and Rewari. and she's Director Pushpanjali Medicare, past President IMA, and past President Gurgaon Obs and Gynae Society, and she has multiple papers to her credit. Welcome, Dr. Suman, very close friend of me.
Thank you, Dr. Promila. Dr. Ragini is a dear friend of ours and is the whole and soul. In one word, if I want to describe Gurgaon Obs Gynae Society, it begins and ends with Ragini. After this, I would just say that she's a fellow clinical gynecology from UK, master course of cosmetic gynecology. These are the latest things for her. Welcome, Dr. Ragini. Welcome for your talk.
Pillar of Gurgaon Obs and Gynae Society.
Thank you, Suman. And very good evening to all of you. And thank you so much for sparing your Sunday for the cause of saving mother. And I will start my presentation with a small story. Sona, she is a laborer and she has, after 4 deliveries in the 2 abortions, finally an anemic state, she delivered a child and at home, and she had a massive PPH. She went to she was taken by the Dai to the nearby PSC and referred to Safdarjung Hospital, their SDU, because it's a famous SDU, with an incomplete referral paper. And finally, she was saved there and came back.
आप कंटिन्यू करो अगर
मेरा खत्म नहीं हो रहा, क्या करूं, जा ही नहीं रहा है.
इसको तो आपने लिया ही है ना प्रोसेस.
Yes, and she came back home. She's anemic, and now she has only 2 ways to go. Either she'll get pregnant again, or somebody will advise a postpartum contraception and able to save the life of her. So today, from the starting, we have traveled from the preconception to antenatal problems to intranatal problems and to the postnatal complications, and now she has come back and going to the postpartum contraception. So I'm really grateful to each and everyone who has helped me to make this, who has helped me with this. I have taken the articles, and with the blessing, I will start my presentation with this quote. Millions of deaths would not have happened if it weren't for the consumption of alcohol. The same can be said about the millions of the births. I think we all agree that unintended and closely spaced births are a public health concern, as they are associated with the increased maternal child morbidity and the mortality. After a live birth, the recommended interval before attempting the next pregnancy is at least 24 months. That is a recommendation from the WHO. But 61% women are not using effective contraception within 24 months of the postpartum to avoid an unintended pregnancy. So basically, when we define the postpartum contraception, it is to prevent some agent to prevent a pregnancy in first to 12-24 months, and it has to be spaced, and particularly is important in the pregnancy where there's a greater risk for the mother and the baby. The short pregnancy interval also confer increased risk, specifically in an obese and GDM and eclamptic patient. And all the women who has a chronic medical condition require preconception care and the preparation for pregnancy, so they can have an easy pregnancy and baby does not experience lots of problem. So there are many reasons why women do not use effective contraceptions, because there's a many socio-cultural gender norms, timing of return to sexual activity, breastfeeding practices, and misconception that the lactational amenorrhea they can't conceive. And the biggest thing is a lack of access to the contraceptive services or understanding of the contraceptive services. So what should be a modern contraceptive service? It should be a offer service as a part of the care providing during childbirth, increases the postpartum contraceptive use and likely to reduce the both unintended pregnancies and the pregnancies that are too closely spaced. WHO recommend that every point of contact
women should be advised for a contraception, whether it is antenatal care, whether it is immediately after birth in the ward, or during postpartum, well baby care, immunization time, or growth monitoring time. So we have to use this window of opportunity, which is a word for us where everywhere we want to use the word window of opportunity, maybe antenatal care, preconception care, adolescent health, or a menopause health. So each visit to a health professional offers a unique opportunity to screen for and the counsel. And this opportunity required deliberate attention to organize services, update policies, provide practices, and mobilize resources for implementation. So it has to be popularized. Then the point comes what to use and availability of the postpartum contraception. So this busy chart of the advocacy and implementation is there on the WHO site, and which says that lots of barriers are there which we have to cross, and it should be a high impact practice. Only then we can deliver the appropriate postpartum contraception, and this benefit of the postpartum contraception to the women should be popularized. It should be talked about, and there should be a social support, and these only then we can come like outcomes like a reduction in the unintended pregnancy and reduction in the closely spaced pregnancies. This advocacy and implementation goes very large way at the government sector, at the society level, at the individual level also. So providing family planning counseling as a part of the childbirth care raises awareness of the importance of the birth spacing and the postpartum contraceptive. And the biggest hindrance when we talk about is breast milk can be affected by the hormonal contraceptive, and this is a reason everybody hesitate to start the contraceptive agents. So how to overcome this challenge? That is the biggest thing. So it should start when the patient is in the active labor or in the community where women are able to recuperate in a facility after birth. These approaches are considered acceptable to the both provider and the clients, and providing information, and this time woman is more susceptible. Immediate postpartum family planning is not a new concept. If you see, in 1971, there was a survey and it was found that the program is estimated to have averted 5 lakh unwanted pregnancies over in the 8 years of the implementation. So now the question is there, what should be a contraceptive option in the immediate postpartum period? We have a big bouquet of the contraceptive agent which a woman can choose, whether it is hormonal or non-hormonal. So we have to divide the woman into two parts, for the breastfeeding woman and for non-breastfeeding woman. For breastfeeding women, the only thing we have to see when we go for the hormonal contraceptive, which type of the hormonal contraceptive we are going to choose. Otherwise, sterilization, IUD, implants, lactational amenorrhea method and the condoms are common in the both. But when we talk about the non-breastfeeding women, here come the role of the CSC if woman has no other contraindication. So this again, this chart is from the WHO site only, and very clearly it has given what type of the family planning integration we can do, and we can choose the postpartum contraception from this chart also, at which time we can start what. So birth control method selection depends on the factors such as the medical comorbidities, current medication use, patient preference, cost, desire for the future fertility. So this contraception, what can you use immediately after the delivery? Contraceptive implant, Depo-Provera injection, progesterone only pills, condoms, you can use immediately also. IUD is another wonderful thing. We all know the PP-IUCD, and combined oral contraceptive pill only we can give when woman is not breastfeeding. There's no other contraindication, but cannot be start immediately. And vaginal ring is the same as the combined oral contraceptive pills. So breastfeeding still accounts for a significant proportion for all fertility reduction, but this lactational amenorrhea method is a highly efficient tool for the individual woman to utilize physiology to space birth. But it has some criteria that baby is under 6 months, mother is still amenorrheic, and she practices exclusive or quasi-exclusive breastfeeding on demand day and night. So permanent contraception you can offer if she has completed the family, not want another child. But I personally have some reservation to give this permanent contraception to a younger population, specifically if she has one child or from a lower socioeconomic status. With a young child, one should not offer a permanent contraception. If she has a 1-year child and the 2-year child, we should go for the reversible method, which we have many methods of the with us long-acting reversible contraceptive in the form of the IUCD and the contraceptive implants. The major advantage is that do not require ongoing effort on the part of the patient for the long-term and the effective use. And when the devices is removed, the fertility is rapid. They are divided mostly in the 2 parts. One is the intrauterine devices, whether it is a hormonal or non-hormonal, and ethnogestral single rod contraceptive implant, which is now available easily in India, and training is going on. Just coming to the special situations, there are certain general guidelines. During the first 21 days following delivery, we should not give any estrogen containing contraceptive because there's an increased risk for the thrombotic events in each and every postpartum patient. Between 21 to 42 days, CSC can be given if there's no additional risk factor for the thrombosis. Many women with the GDM have risk factor for the thrombosis, which include 35 years older, previous thromboembolism, postpartum hemorrhage, heavy weight, cesarean delivery, preeclampsia, and smoking. And today the GDM is increasing something like an endemic. So we have to be very careful when we give a postpartum counseling to them. After 42 days of the postpartum, all women can use CSC regardless of the breastfeeding status or the pregnancy-related thromboembolic risk factor. Non-pregnancy related risk factors such as age, smoking, thrombophilia, they are the independent contraindication to CSC. Progesterone-only contraception may be initiated at any time after delivery, including immediate postpartum IUCD or the subdermal implant placement. I will focus for the gestational diabetes specifically because we all know that this woman is going to develop a diabetes within 5 years, and effective contraception is therefore imperative in the postpartum period to plan or avoid future pregnancy. It will give time to her for the medical optimization to improve the future pregnancy. So based on the current evidence, women with the past TDM are candidates for all hormonal and the non-hormonal contraceptive in the absence of other contraindication. And as in all patient, recommendation for the contraceptive use in these women should include consideration of the medical comorbidities and the plans for the subsequent pregnancies, acceptability, convenience, all these things should be discussed. Now, if a patient has an inherited thrombophilia, which we are seeing many cases today, when we are putting some patient on the low molecular weight heparin, thinking she is having some type of a thrombotic event or a vasculopathy, and we have not tested that patient for the inherited thrombophilia, or that patient is having a Epler syndrome or SLE, here we have to think whether this patient has a genetic tendency to venous thrombosis, DVT. So these are the candidates where making contraceptive choice. Affected women need to balance the risk of the VT associated with the use of the contraception against if she has an unintended pregnancy and she has again a VT, because we all know that the pregnancy itself causes the 16 times coagulation of the blood, and it is a hypercoagulable condition in this woman. Not in this woman, every woman. And VT increases from the 3 per 1,000 to 6 per 1,000, 3 per 1,000, from the 3 to 6 per 10,000 person year if we put on the CSCs. So we have specifically in the thrombophilia where there is a antithrombin or there's a homozygous factor 5, those are the thrombophilia which are more dangerous. With a heart disease patient, again, we have to see what we are going to give them. Partner vasectomy is no doubt is the best thing, but they are the greater child of the God. They are not going for a vasectomy. So the poor woman, she has to go for this thing. Copper IUCDs or transcervical tubal occlusion, which is not available with us, is I think is the most effective and carry a relatively low risk. Transabdominal tubal ligation should not be offered specifically in the decompensated heart failure patient, but in the compensated patient, you can go ahead with the anesthesiologist with a cardiac backup. Combined hormonal contraception, generally we should avoid in these patients. If a hormonal option is contemplated, this risk can be minimized with the preferential use of the progesterone-only formulation. Barrier methods are least desired because they have a high chances, but they should be given a part of the dual contraception in these women, specifically if we are putting a IUCD. Now, 3% of the women of the childbearing age have a chronic kidney disease, although end-stage renal failure impacts on fertility, conception, and the high-risk pregnancy do occur. Following renal transplantation, patients should understand the potential impact of the pregnancy on the transplant. Effectiveness of a particular contraceptive method is dependent upon acceptability to the patient and the compliance. So again, estrogen-containing contraceptive methods are considered unacceptable in many renal patients. Again, progesterone-only methods have an advantage safety profile, whether we are going with the progesterone-only pill, whether we are going with the LNG IUCD, or we are going with the implant. Concern regarding the IUCD system in the women taking immunosuppression are unfounded, and observational evidence does not demonstrate an increased risk of the infection. Sterilization is effective and should be considered to be irreversible. Barrier methods is reduced when typical use is compared to the perfect use. But again, I will say whenever these high risk patients should always offer a dual method, because we all know this barrier method prevent the lots of STIs and the infection. Selection of a method of a contraception in patient with liver disease can be complicated. Tubal ligation should be considered. Multiple reversible methods of the contraception are currently available, but may affect the hepatic disease. Estrogen-containing contraceptive is a big no. Progesterone contraceptive appear to be safe, and multiple delivery systems are available. Coming to the rheumatic diseases, contraceptive advice needs to be provided prior to discharge, and Depo-Provera injection every 3 months, and other LAR can be offered to them. CSC are contraindicated in Epler syndrome, as I have already told you. Hormonal contraception, which contain both estrogen and the progesterone, can be considered safe in the patient with a stable SLE without any Epler syndrome. Example of the IUCD include the copper IUCD, and early concerns surrounding the infection immunosuppression use are not backed by the scientific evidence. So when we talk about the metabolism, per se the insulin resistance and the glucose metabolism, it was found in the Cochrane review that all the healthy women may have a hormonal contraception related effect on the metabolic disorder, but there is no evidence of the clinical important changes in the found with the hormonal contraception. One word about the DMPA. Here, some data suggests a relation between the DMPA and the insulin resistance, and they found the DMPA were more likely to develop diabetes than those who had used CSC even after adjustment of the BMI. When we talk about the LNG IUCD and the implant, they are the mixed effect on the metabolism. Many women perceive weight gain as a concerning side effect, but again, it is not backed by the evidence. But when we talk about the DMPA, it was found in a Cochrane review, the women who are already heavy weight, their DMPA leads to the more weight gain than the person who was not having a DMPA. So DMPA is little a potential concern in a woman who are already overweight or obese. It's not be ideal in such women, and other methods of the contraception should be considered. As far as the mineral density is concerned, there DMPA again have a black box warning, and it founded on the concern that the prolonged use could result in the significant potential permanent loss. But as far as when we talk about the other LOX, there it is not found. In the LNID or Implanon, you can give to these women. Long-acting reversible contraceptive have few contraindications and should be offered routinely as a safe and effective contraceptive option for most of the women. Then coming to the postpartum IUCDs, you can offer to each and every woman, whether it is a copper IUCD, there is some reservation for the LNG IUCD, but it was again, no evidence has backed it, and you can even put in the breastfeeding woman immediately also. Postpartum IUCD means within the 10 minutes of placenta delivery, the vaginal and the cesarean birth should be offered routinely as a safe and effective option for postpartum contraception, but do the counseling of these patients very, very properly and document that counseling, only then you go ahead. Now the 2 or 3 slides are left. Please go on the net. You can get this MEC classification. And this is a very necessary for all us to know this thing. And here it was put LNG IUCD in a category 2, where advantage generally outweigh the risk. So given available evidence, women who are considering immediate postpartum hormonal LARC should be concerned about the theoretical risk of reduced duration of the breastfeeding, but that the preponderance of the evidence has not shown a negative effect on the actual breastfeeding outcome. So this is the wheel which should be on our table when we are advising. It has given everything, all the criteria. You can see all the indication and the contraindication. This is the site where you can go and find out. And it is such a good thing. You have to put like this, and it will immediately pop up whether this woman is a candidate for this particular type of the contraception or not. This is the screenshot of that particular site, and it shows when you put the, you fill the form and your particular type of the contraception, advisable or not advisable, is popped up. To come to conclusion that a LARC is a few contraindication and should be offered routinely as safe and effective contraception. Copper IUCD should be deferred routinely, offered routinely to women who request emergency contraception and eligible for the IUD placement. To improve LARC method satisfaction and continuation, patient counseling should include information specifically for the menstrual problems like expected bleeding changes, amenorrhea, prolonged spotting. Clinicians should consider LARC methods for the first line options because of their high effectiveness and the compliance. Tubal sterilization is an option for women who no longer desire the fertility and should include the consideration for the potential surgical risk, specifically in the setting of the obesity and other condition. I'll finish my talk with this quote: the contraceptives are the greatest life-saving, poverty-ending, women-empowering innovation ever created. It's really echoing my thought. If anything has offered to the woman, only to the woman for her life, from the modern medicine, it is a contraception. It is the contraception. Thank you so much for your patient hearing.
Thank you, Dr. Ragini, for the elaborate talk. And as usual, it is very informative and to the point. Now, I have the proud privilege to introduce Dr. Shehla Sajid Sheikh. She is DM Endocrinology and MD Medicine. She is the consultant endocrinologist at Prince Ali Khan Hospital, Safai Hospital, and Wockhardt Hospital, Mumbai. She has been the principal investigator in international clinical trials. And she is a member of executive committee of ESI Diabetes India. She is a treasurer of ESI Maharashtra and member scientific committee CAD. She has been awarded top Mumbai Doctors by the TOI group in 2017 to 2020. She is author of International Hajj and Diabetes Guidance, IDF DAR Guidelines 2021. She has published many papers and review articles and has been a speaker at many national and international forums. Welcome, welcome, ma'am. And her topic is postpartum thyroiditis. Over to you, Dr. Shehla, for your lecture, for your talk.
Thanks, Dr. Suman. Thanks for those very kind words. And a big thank you to Dr. Ragini for making me a part of this very, very prestigious meeting. To be very honest, I know Dr. Ragini much before this meeting. It's always been a pleasure to interact with her and learn from her. We've had the good fortune of interacting on our multidisciplinary meetings when we've invited her as a part of our endocrine meetings. And what I would really like to say about her is, apart from, of course, her being a fantastic speaker, clinician, etc., I find her a very down-to-earth and fantastic human being. You know, it's almost like she's just a phone call away. And that is, believe me, something very remarkable. Always, I mean, whenever I've interacted with her, I've always been touched by her warmth. And that's what I really want to put across over here. So thank you, ma'am, and thanks for making me a part of this meeting. Thank you very much. Today, my purview is to talk about postpartum thyroiditis, which I think is really very, very relevant in the present situation. And the reason I'm saying very, very relevant in the present situation is because we all know that when we are talking about mothers, so I think it is very, very important that we have a very high index of suspicion regarding postpartum thyroiditis, because often, unfortunately, what happens is that the moment the delivery takes place, the mother somehow is relegated to the background. Ma'am just gave an excellent talk, and I loved the last words that the biggest gift that modern medicine gave women is the oral contraception. I mean, is the contraception in all forms. And I totally agree with her, because it often happens, and we see it very, very commonly, because especially when we're managing our GDM patients, our diabetic patients, pre-gestation diabetes with pregnancy, the moment the delivery takes place, it's almost like the mother is relegated to the background. And often her symptoms are just not taken into account. It's always put down, if she's a first-time mom, it's put down to being, oh, you're looking after a baby for the first time, sleepless nights, etc. If she's a second-time mom, it's supposed to be the entire stress of looking after children. And the bottom line remains that often symptoms which we could have picked up much earlier are simply not picked up because we all assume it is simply due to the fact that she is a new mother. So what is postpartum thyroiditis all about, friends? We know it as a destructive autoimmune disease occurring in the first year after delivery, mind you, without a history of thyroid disease prior to pregnancy. A very important point which I want to make put across over here is that it can occur also after spontaneous or induced abortion. So we need to keep our index of suspicion high, even in our patients after they've had a spontaneous or induced abortion, if they come back to you with new symptoms or symptoms which are simply not resolving. Postpartum thyroiditis, mind you, can cause transient symptoms, or it can lead to permanent thyroid disease. And some of the three presentations which possibly the patient could come to you with could be just transient hyperthyroidism or transient hypothyroidism, or classically, and actually the classical form is seen in only 25% of patients, where patients have transient hyperthyroidism followed by hypothyroidism and then complete recovery. So that classical form which we expect and we think which is the most common form actually is not the most common form. Transient hypothyroidism is the most common form, which potentially also could lead to permanent hypothyroidism. Now, why is this entire process occurring? We all know it's an inflammatory process, and this is initiated by the presence of thyroid antibodies. And it is in this situation where measurement of thyroid antibodies assumes a lot of significance. There are increased levels of IgG1, increased activity of the entire inflammatory cascade, And finally, what happens is there is going to be lymphocytic infiltration of the thyroid gland. And this entire inflammatory process is going to cause destruction of the thyroid follicles. And because it causes destruction of the thyroid follicles, it causes release of hormones into the circulation. This destructive process just causes release of preformed hormones into the circulation. And because it is causing this release of preformed hormones into the circulation, this state is just transient. The hyperthyroid state is still, the hormones are released into circulation till there's no more thyroglobulin actually left within the follicles. Now, because these hormones are released into circulation, what happens is your T3 and T4, which are your end hormones, they get elevated. Now, because they get elevated, they are going to shut down the thyroid pituitary axis, and there is going to be reduction of your TSH levels. Now, once this entire process takes place and there is no more thyroglobulin left within the follicles, there is going to be there is again going to be the resynthesis process, where once the inflammation settles down, the thyroid gland is again going to start producing hormones. But during this phase, till the entire downregulation of TSH is upregulated, until the thyroid follicles again start producing thyroid hormone, you are going to have a transient phase of hypothyroidism. Why is it important that you recognize these symptoms? Why is it that it is important that you recognize the pathophysiologies? Because that is going to actually determine your treatment. Your treatment is different from how you conventionally treat your hyperthyroid or hypothyroid patients. Very, very individual decisions will be made. You will decide in a very, very different manner as to which patients you will treat, which patients you will not treat, and exactly what are you going to do in these patients. Now, these patients, one very important thing that we need to understand is that a number of these patients come to you practically with painless thyroiditis. They may have other symptoms, but per se, it is actually a clear-cut epitome of painless thyroiditis. So when you evaluate these patients biochemically, you would find similar picture to what you see in hyperthyroidism or hypothyroidism. And if you do not have a high index of suspicion, most probably you'll end up treating them either as thinking that they are Graves' disease, or you're going to think that they have hypothyroidism and treat them. And potentially this patient could end up being on therapy for a very long time, which may actually not be required at all. We all know when we are talking in terms of hyperthyroidism, we are talking about a high T3, high T4 with a low TSH. And if the patient is seen in the hypothyroid phase, we are talking about a high TSH with a low T3, T4, or we could be even seeing a normal free T3, free T4 with a high TSH with subclinical hypo or hyperthyroidism respectively. As I said, it takes time for the TSH to recover. So you could actually at times see a very, very varying picture in these patients. For example, if you actually evaluated the patient while this patient has not completely recovered from the hyperthyroid phase and has not actually become hypothyroid, you may find a TSH which is also low and a T3, T4 is also low. So that is where the history makes a very big difference, where you would sit down and talk to your patients, understand the history of the patient. And these are some areas in medicine where history taking becomes very, very important, of paramount importance, because a patient, when you talk to them in detail, will give a history. Yes, ma'am, 2 months back or 1 month back, I was having a lot of palpitations. I was having a lot of increased frequency of stools. I was having much more anxiety. I was having fine tremors, but now relatively I'm okay. Now I'm all the time tired. Now I've started again putting on weight. I was happy I was losing weight at that point of time, but now again I've started putting on weight. So sometimes it is just those clinical markers which will tell you what exactly your patient is going through. Antibody titers definitely are high in 60 to 85% of patients with postpartum thyroiditis, and they are highest in the hypothyroid state. Now, if your patient wasn't breastfeeding, you would do a radionuclide scan, you would do a technetium uptake scan. We all do it routinely in our non-pregnant, non-breastfeeding mothers. We cannot do this in our in our lactating mothers. Pregnancy, of course, we cannot do it. There's no questioning that. But in our lactating mothers, we are not allowed to do scans because the radionuclide material is excreted in the breast milk and it is going to go to the fetus, and we cannot afford that. Now, in this situation, your clinical judgment and your biochemistry is going to decide what kind of therapy you're going to offer to your patient. If the mother is not breastfeeding, then yes, you can do a technetium scan for the thyroid at all. We do not do radionuclide iodine uptake scans as on the routine because it's more cumbersome, requires uptakes to be done 24 hours and 48 hours, and you get the same information that you require from a simple technetium scan. If you are very confused and you feel that no, you really need to do a technetium scan, then for 24 hours, the mother is strictly not allowed to breastfeed the baby. For 24 hours, if there is a situation where you feel it is going to make a very big difference to your management, then for 24 hours, we often tell, if I have had situations where we've told our mothers then to extract breast milk, and for 24 hours, the mother cannot breastfeed the child. These things we need to keep in mind when we are looking after our patients. Mind you, none of the cases with thyrotoxicosis and 40% of cases with hypothyroidism need treatment. So we need to understand that this is actually mild, it is self-limiting. As I said, patients can become euthyroid subsequently, though some may remain hypothyroid. And as a clinician, you need to make that judgment as to which patients will become hypothyroid permanently and which patients are potentially going to recover. These patients are going to come to you. These patients do not come to us. These patients come to you, and it is your index of suspicion which is going to actually guide your patient as to what has to be done further. Anti-thyroid medications are absolutely ineffective. This is a destructive form of thyroiditis. It is destroying the gland. Anti-thyroid medications actually influence the formation of thyroid hormones, but here it is preformed hormones which are going to be released in circulation. So when it is preformed hormones that are released into circulation, there's no increase in the synthesis of thyroid hormones. Anti-thyroid medications simply do not help. We often see patients coming to us with prescriptions of anti-thyroid medications and saying, ma'am, I'm on anti-thyroid medication since 1 month and I have not responded. The patient has not responded because we need to understand the mechanism of the hyperthyroidism in that patient. Symptomatic treatment, you can give propranolol to these patients. We all know we do not give propranolol to our patients while they are pregnant, but in a lactating mother, the guidelines say you can give propranolol if absolutely required, if the patient is very symptomatic, if significant tachycardia, because amongst the beta blockers, propranolol is highly plasma protein bound, and therefore it is not concentrated in the breast milk. So if you have to use a beta blocker because of symptomatic issues, then you would use propranolol rather than any other beta blocker. You would not use atenolol. Now, when you are assessing, if you decide that, okay, this patient is very symptomatic as far as the hypothyroid state is concerned, and I need to treat this patient, and you decide to put the patient on therapy. If you want to assess at the end of 1 year whether this hypothyroid state is transient or permanent, you can taper the doses of LT4 and reassess or review the patient every 6 to 8 weekly, depending upon the patient's symptomatology and what kind of biochemistry you see. If at the end of this reduction in thyroid dosage, if you find any increase in the TSH levels, that means this patient potentially could be having permanent hypothyroidism. And that is something that we need to keep in mind. Very, very important is that we need to understand that postpartum thyroiditis confers an increased lifetime risk, mind you, of developing permanent hypothyroidism. This is a very important message that you need to give your patients, friends, because often it happens that patients forget all about the postpartum thyroiditis once it is recovered, or they feel like, okay, now I'm fine, I really don't need to bother about it. But in any patient who's come to you with postpartum thyroiditis, they have an almost 60% increased risk of developing permanent hypothyroidism. So they need to monitor themselves annually whenever you have seen them for postpartum thyroiditis. So we need to tell our patients. It's like your patient of GDM. You tell your patient that, look, you are at an increased risk of diabetes, and if you are not careful, you are potentially going to become diabetic, maybe 5 years down the line, maybe 6 years down the line. Similarly, when a patient has postpartum thyroiditis, the patient needs to be made aware that you are at an increased risk of hypothyroidism. So if you are not particular about monitoring yourself annually, at least please be a little more mindful about the symptoms of hypothyroidism, be it weight gain, be it constipation, be it slowing, be it hair loss, be it all those myriad symptoms which we really take part, we really sometimes assume it is part of the aging process, part of a bad lifestyle, part of so many other areas that we assume it is due to. Because this is a very important message that we need to give our patients, so that our patients realize that if they are not screened the way they should be, they can have potential problems. It is very important that we are aware of postpartum thyroiditis. It is very important that the reason we need to be aware, because 6 weeks postpartum, often the patients will not have symptoms. Patients come to you with symptoms maybe 2 or 3 months down the line. A simple clinical marker of differentiating postpartum thyroiditis from maybe Graves would be, if the patient comes to you early on, all the data says that most of the patients with postpartum thyroiditis will come to you between 2 to 4 months post-delivery. Whereas if the patient, for example, has classical Graves, the patient will come to you much later, maybe 6 months down the line. Another area where antibodies, we often check antibodies, sometimes really not knowing why we are checking them. But one area where it makes a very, very big difference, we check antibodies, very important, is in these patients. So if you have a patient with positive antibodies prior to pregnancy, or if antibodies have been checked in pregnancy for some other reason, then yes, this patient is at a high risk. As I said, history, very, very important. And type 1 diabetes mellitus, again, is important. And these 3 areas are recommended by the Endocrine Society clinical guidelines, where these patients should be evaluated. 2 of the other areas where my gynec friends always evaluate their patients is if they're seeing any kind of postpartum depression and lactation abnormalities. But as far as data goes in these 2 areas of postpartum depression and lactation difficulties, there is no clear-cut data which shows that yes, there is an increased incidence of postpartum thyroiditis. But yes, though the guidelines do not recommend it to be done in every patient who comes to you with these symptoms, I personally feel it is always better to evaluate these patients when they are going through these 2 issues. So as I said, they should be evaluated. You need to have a high index of suspicion. And I think together we can definitely reduce the suffering that these patients go through. Thank you very, very much. I tried my best to stick to time. Thank you.
Thank you, Dr. Shaila, for this wonderful elaboration of a topic which we really don't pay heed to. Because by the time the patient is 4 months postpartum, she's actually away from us. She is generally looking around anywhere, and for her usual symptoms, she would go to anyone but the gynecologist. That is why I think we have never paid heed to these kind of problems in our practices. Thank you for making us aware for this wonderful thing. Yes, ma'am.
Suman, to be very honest, I have seen a lot of, I perfectly understand what you are saying, but I mean, when they are breastfeeding now, they often tend to go back to their gynecs only, because I mean, a lot of gynec friends would then, pick it up, realizing that this could be something connected. Because I mean, especially for the first 6 months when the ladies are breastfeeding, and if they're having any kind of difficulty, I mean, we all are their best friends. I think gynecs are the best friends of ladies, to be very honest. I never have that kind of rapport, I'm always a little jealous of the rapport you all share with your patients, because I often will hear, no, ma'am, I'll check out with my gynec and let you know. So, I mean, I think that 6-month period, is a very, very important period where we can potentially reduce the suffering. If nothing else, at least even we know it's transient, we know, but a little bit of reassurance and a little bit of management makes a big difference to their suffering.
Single question from my side.
Yeah,
what is the time for earliest detection of hypothyroidism in postpartum case? I thought that it should be done within 20 days of delivery. Thyroid levels test.
Ma'am, no, in 20 days of delivery, we don't need to do a thyroid test. The earliest, if you're talking about postpartum thyroiditis, the earliest time is 6 weeks. The patients come to us earliest at least 6 weeks post delivery.
Can we detect it if we do in early 20 days?
Ma'am, there is no literature which says that you can detect it if you do it within the first 20 days, because it takes for the entire pregnancy related changes in the hormones, it takes almost 4 to 6 weeks to sort of resolve. And the entire concept is that it is an lymphocytic infiltration, the inflammation will occur post delivery. So inflammation does not occur so soon after delivery, ma'am. So at least 4 to 6 weeks is what we say.
Okay, thank you.
Thank you, Dr. Shaila. And Promila, I guess. Dr. Promila?
So,
Dr. Ragini.
Yeah. I'm just asking patient with with hypothyroidism in pregnancy and antithyroid antibody positive, they are also at a high risk of getting postpartum thyroiditis.
Yes, they are. They are at a higher risk
and
of
they can present earlier also.
Yeah, but Promila, they will get postpartum thyroiditis if they have some amount of functioning thyroid tissue still. Because for thyroiditis, you need functioning thyroid tissue. Okay. So when we're talking about hypo,
we have mild hypothyroidism, but antithyroid antibodies are positive.
Bodies are high, then definitely there is an increase.
Yes.
Questioning that.
Thank you, Dr. Shaila. And COVID has given us many virtual word friend. So if it was not there, maybe our path was not crossed. And it is always pleasure to listening you. So from this, we move forward from all the medicine to the surgery. And for this particular surgical skull, we have chosen the professors from the 4 esteemed institutions of Haryana. And for that, the session will be chaired by our Gurgaon Young Brigade, beautiful Young Brigade, Dr. Reema Goel, who is a FOXI certified training in the reproductive medicine, RT from Delhi. She has her own center and doing wonderful work and wonderful dance also. And she's the secretary Mission Pink Health IMA Gurgaon and visiting consultant in the many corporate hospital, and received Young OBGYN Talent Award in 2017 and presented many papers in the national level conferences. Our second, next slide, chairperson is Dr. Dr. Jyoti Yadav and Dr. Madanjit Pasricha. Yeah, Dr. Madanjit Pasricha, who is another our dynamic young person, gynecologist from Gurgaon only, and she is the director Pasricha Hospital with a keen interest in the high-risk obstetrics, and really she is a great academician when I talk about our younger generation, and we are looking upon her that she will take over our GOX in a very good way. And our third chairperson of this session is a great beauty and a winner of a beauty contestant also, Dr. Jyoti Yadav. And she has her own hospital, Kamla Hospital, and she is a fertility specialist also. She is a Mrs. India Universe 2020, brand influencer for COVID-19, Women Warrior 2021, brand ambassador for Kerala Fashion Festival. So over to the chairpersons to introduce our great teachers. Over to Reema to start.
Thank you, ma'am. Thank you for a very kind introduction. And I must congratulate you on the successful going of this Abhilasha CME, a wonderful CME being organized, and we all are being benefited academically. So to introduce our next, Dr. Savita Rani Singhal, she is our next speaker, and she's a senior professor and unit head PGIMS Rohtak, Haryana. She has 33 years of teaching experience. She is the convener of Haryana OBGYN Gynae, vice president Rohtak Foxy, and she has over 200 national and international publications to her credit, and she has written various chapters in various books. She has been awarded international fellowship by ICOG at New York, and she is a member of editorial board and reviewer for international journals. Field of interest is adolescent gynecology and oncology. So I welcome you, Dr. Savita Rani Singhal, to please present your talk on a very important topic, that is the Patwardhan maneuver.
Thank you, Dr. Reema, for kind words. And a very, very good evening to all who are still here and who has left. And I congratulate Dr. Ragini for having this wonderful CME and workshop for 2 days, saving the mother, which is our main motto as obstetrician. So topic lying to me is Patwardhan manure. I think all the obstetrician should be aware of Patwardhan manure because you don't know at which stage or at what time you have to go for the second stage cesarean section. And this second stage cesarean section can be done for unanticipated CPD in late labor, which you have not anticipated, or due to failed attempt at instrumental deliveries. So moreover, as the WHO has recommended that cesarean section rate should be lowered down to 10 to 15%, and more trials are being given for the normal delivery, leading to rise in second stage cesarean section to 2.1% as the Cochrane Review 2016. We know the second stage cesarean section, what is the condition? The LycoRed is mostly drained out, uterus is almost hugging the baby, head is deeply impacted, and very, very difficult to bring the head out of the pelvis. Sometimes situation is that due to very big caput or molding, head is just reaching the leading point, is reaching the middle of the vagina, and you're introducing your full hand or asking your assistant to push it from down, leading to various complication in the form of extension of uterine incision. And this extension uterine incision, they are associated with grave complications like injury to the surrounding structures, VVF, RVF, postpartum hemorrhage, broad ligament hematomas, need of the hysterectomy. So to some extent, this complication of injury or extension of incision can be minimized if we are very gentle in delivering these impacted heads or late second stage cesarean sections. So this delivery method, if we follow by the Patwardhan method, reverse breech extraction, fetal pillow, or the conventional method, that is general push method. So I feel my duties if I don't remember, we don't remember Dr. Balachandra Patwardhan, who is a pioneer, who is a father of Patwardhan technique, which was devised by him in 1957 to deliver a baby with deeply engaged head at the cesarean section. So basically this Patwardhan method is a shoulder first method, you say. Otherwise you delivery either the breech or the cephalic. But in this method, we deliver the shoulders as a first method. They deliver first, and there's little modifications are there in the Patwardhan method. If back is anterior, little modification is there. If occipital transfers, or it is back posterior. So most common position we know is the occipital transfers. So this is occipital transfer diagrammatic representation. This is a shoulder, anterior shoulder. In this technique, though the shoulders are delivered in all the techniques first. So anterior shoulder is being delivered, whichever is visible, followed by the posterior shoulder, then the trunk, legs, and finally the head. So we don't say head is delivered, we say head is lifted out because it comes very gently with the delivery of whole of the baby. Certain practical tips which should be taken into account while doing the cesarean section for second stage. As all of us know, the prolonged second stage, the lower uterine segment is very dilated, thinned out, and fragile. So it is more prone for the extensions. So incision should be given slightly higher at the level of the shoulders. If we give the lower incision, because the lower segment is too much dilated, if incision is given just or 2 to 3 centimeters above the bladder is already pushed very high up. So once the baby is delivered, the segment will slightly constrict. The incision, if extends, it might extend into the lower uterine segment to the bladder. It may be too near to the bladder. That stitching is very difficult at that point. So incision should be preferably curvilinear, U-shape or J-shape, so that even if extension is there, it is in the upper segment. So this is a small video, courtesy Dr. Mitra and Dr. Manjupuri. So this is cesarean section, but Patwardhan method is being practiced for a patient with second gravida who was in the second stage. Forceps have failed in this patient. You can see this, we're just opening the peritoneum. And now incision is being given little higher up. And we're extending the incision curvilinear fashion. Incision is being extended in curvilinear fashion so that even if slight extension is there, it goes into the upper segment and we can avoid the lateral extensions or the lower extensions. So just below the incision, you can note there the shoulder is lying. So with the index finger, we're just tracing the elbow, bringing out the shoulder. Anterior shoulder is taken out. So this is a right occipital. The left occipital transfer position is there. The right shoulder is being taken out. Now after doing slight rotation, another shoulder is taken out by hooking with the index finger. See how jammed up head is there. So it is not so easy, but it is easy to learn. The second shoulder is being taken out just with the index finger. Now both the shoulders are here. You have to pull with the trunk, keep your fingers parallel to the spine and provide the fundal pressure. Very, very important to give the fundal pressure, gentle fundal pressure. See the head comes itself automatically. So there's no need to do any manual for delivery of the head. So head is lifted out of the pelvis. So these are for the occipital lateral positions, but if its back is anterior position, then this is the method. If back is completely anterior, both the shoulders will like this. So both the hands will be used simultaneously. With the index fingers, both the hands are inserted into the uterus and both shoulders are taken out. This first step is not there, which we did in the transfer position, and then further follow the same procedure. Deliver the trunk followed by legs and the head. If it is a back posterior, what to be done? If back posterior is there, the posterior back is there, both shoulders are lying here, but they will not be visible under the line, under the incision line. So the procedure can be done, is a modified Patwardhan we say. First bring the shoulder, whichever is visible, maybe this shoulder or maybe this shoulder, followed by delivery of the same side of the leg, then followed by delivery of the contralateral leg. These three limbs are out, then fourthly shoulder will come, followed by the head. So the same procedure, either you can go with this if back is posterior, or one can go with the reverse breech extraction, which is a little easier. So both the two methods are for the back posterior. In this, we have to introduce our fingers high up near the fundus, bring one or two legs, whichever is visible, and then trunk is delivered by flexion. Continued fundal pressure is to be given by the assistant, followed by delivery of both the shoulders and the head is lifted up. Just one word about the abdominal routine conventional method, pushing the head from below mechanically by the assistant and delivering the baby. So I thought though is a Patwardhan method is the topic given to me, but just one line about the fetal disinfecting system. There's a fetal pillow. This is the latest one, though it's not available still in India. This fetal bag type of thing is there. Instead of doing the mechanical pressure by the assistant, this bag is introduced into the vagina. It is filled with 180 ml of saline after giving the uterine incision, and it usually raises the fetal head by 3 centimeters and followed by delivery of the head. So just comparing these 4 methods, Patwardhan method, reverse breech method, push method, or fetal pillow. So this Patwardhan and reverse breech method, both are very, very easy to do, easy to learn, has less operating time, extensions are very less, blood loss is less chances of fetal head injury. Though the fetal reps palsy can occur in Patwardhan method because you're dealing with the shoulders. If excessive traction to shoulder is given, there can be the reps palsy. Similarly, in reverse breech, if you're not very gentle, you're delivering extension of fetus is there, they can fracture female. Otherwise, both methods having more complications. The lower segment, as per latest 2019 studies, the Patwardhan method, we compare with the conventional pushing method, has a less morbidity and less mortality, both the fetal and the maternal. And Patwardhan method significantly reduce the risk of the extension as compared to the push or the breech extraction. So just to conclude, Patwardhan technique for extraction of deeply impacted head in second stage of LSCS when done skillfully leads to lesser complications and with better fetal-maternal outcome. Thank you.
Thank you, Dr. Savita ma'am. It was a wonderful presentation. And I was recalling my, senior residency days. Then we used to have so much of second stage cesareans done. Of lately, yes, second stage cesareans in private practices are definitely less, but yes, whenever, we encounter this, then we remember, yes, Patwardhan is the way which we can do and salvage both mother and the baby with minimal damage. Thank you. It was a very wonderful lecture. Yeah, welcome, Dr. Ishika. To introduce Dr. Ishika, she is MBBS from PGI Rohtak, our very own Haryana Rohtak, and OBGYN from Indore. And she's currently working as an assistant professor in Maharaja Agrawal, Agroha, Hisar. And she's Secretary Hisar HARObGyn Gynae Society 2020 and life member of FOXI, Hisar, IMA, and HARObGyn. And her areas of interest are high-risk obstetrics, vaginal surgeries, and preventive oncology. Over to you, Dr. Ishika.
Thank you, ma'am, for the kind introduction. Good evening, everyone, all the faculty and the delegates. At the outset, I would like to thank Dr. Ragini, ma'am, for giving me this opportunity in this great academic bonanza. The topic for today, the topic given to me is complete perineal tear. So to start with complete perineal tear, first we need to know the what is perineum, the anatomy of the perineum. Perineum is a diamond-shaped structure between the thighs, and it is bounded anteriorly by the pubic symphysis, on laterally by ischiopubic ramus, and posteriorly by coccyx and sacrotuberous ligament. What we are going to discuss today is about the perineal tears. So what is perineal body? The tear occurs at the perineal body. Perineal body is the central point of the perineum, where all the insertions of the muscles of the pelvic floor occurs. So superficially, this is a superficial transverse perineal muscle, and this is a bulbospongiosus muscle, and posteriorly the external anal sphincter inserts into the perineal body. And if we go deep, there is a perineal membrane, then there is levator ani muscle and the internal anal sphincter. So when we give episiotomy, we essentially cut the perineal body along with the vaginal mucosa and the perineal skin. And then there sometimes when we are not giving the episiotomy, perineal tear occurs. So how do we classify the perineal tears? The perineal tears are classified into 4 degrees, 1st degree, 2nd degree, 3rd degree, and 4th degree. As you can see, the 1st degree tear is confined only to the perineal skin. The 2nd degree tear involves the skin as well as the superficial perineal muscles. And in 3rd degree, it is classified further into A, B, and C. It involves the tear of the external anal sphincter. 3A is disruption of the external anal sphincter less than 50%. And 3B involves the disruption of the external anal sphincter more than 50%. And there is the internal anal sphincter is intact. And 3C is complete disruption of the external anal sphincter along with tear in the internal anal sphincter. As you can see, the complete perineal tear involves the complete disruption of the perineum along with the anorectal mucosa. That is, the external anal sphincter is being disrupted. There is tear in the internal anal sphincter as well as in the anorectal mucosa. So the obstetric anal sphincter injuries encompasses both the internal anal sphincter, 3rd degree tear and the 4th degree perineal tears. What are the risk factors for these tears? So OSS. For the OSS, the risk factor is the Asian ethnicity, nulliparity, birth weight greater than 4 kg, shoulder dystocia, occipito-posterior position, prolonged stage of labor, and ventouse or forceps delivery with or without episiotomy. Even short perineum is a risk factor for OSS. So what is the incidence and prevention? If we go into the incidence of OSS, it is in clinically detectable, it is up to 7% after mediolateral episiotomy and 17% after midline. But many of the OSS is being missed because of the incorrect diagnosis. And it can be prevented by the adoption of best practices, which may lead to reduction in OSS. So what are the best practices we can do? We can increase the utilization of vacuum extraction over forceps delivery. And if you are using forceps, you can disarticulate the forceps early. Then the conversion of occiput to posterior to NTA position. This is not being used nowadays by obstetrician. We are not well conversant with this thing. You can either do manual rotation of the occiput or by vacuum. You can do rotation, but it is not used generally. If there is persistent occiput to posterior, we do cesarean section. So use of restricted mediolateral rather than midline episiotomies if necessary. And at the time of delivery, certain things you can do is reduction of maternal effort at expulsion, perineal protection at crowning, and flexion of the fetal head and maintenance of excess traction. In certain studies, it has been also found that warm compression during second stage of labor helps in the prevention of OSS. Once OSS has occurred, the next step is the correct recognition of the injury. It is very important to identify the full extent of the injury and classify accordingly. And whenever you are in doubt, you have whether the degree of what is the degree of the third degree tear, it is always advisable to classify the degree as higher rather than the lower degree. Another special mention I want to tell you about rectal buttonhole tear. It is a tear which involves a rectal mucosa with an intact anal sphincter complex, and as such, it is not classified into 4th degree tear. This has to be documented separately as a rectal buttonhole tear, and if it is recognized, it should be repaired, and because this type of tear may lead to rectovaginal fistula later. So rectal examination is of paramount importance in OSS to correct identification of the type of the injury, and all the structures should be identified. For all this, you have to have an optimal surgical environment for this evaluation, which includes good lighting, sterile and appropriate surgical equipment, good maternal pain control, and experienced physician. Generally, this is available in our delivery room, so we can evaluate the injury in delivery room only. But if there is not good lighting or sterile equipment are not available, you should shift the patient to the operating room. Then we come to the primary repair. The first degree laceration should not are not always repaired, but if there is bleeding or you have to restore the anatomy, you can place some sutures. And the second degree laceration is essentially just like a midline or mediolateral episiotomy, and you repair it in the 3 similar steps, just like episiotomy. That is, to sum up, you can say that the vaginal mucosa is closed by continuous vical sutures. Then the deep muscle layer is closed, and then subcuticular stitches applied on the skin. What we are going to discuss today in detail about primary repair of 3rd and 4th degree tear. These are the general considerations for the repair of the 3rd and 4th degree tear. First, it should be conducted by an appropriately trained clinician or by a trainee under supervision of a trained clinician. So whenever, if you have never encountered a 4th degree tear, it is always advisable to call an expert obstetrician, because if you miss something in the repair is not done properly during the first chance, there's always more chances of fetal incontinence later, and the patient may suffer. So it should always take place in an operating theater under regional or general anesthesia with good lighting and with appropriate instruments. If there is excessive bleeding, a vaginal bag should be inserted and the woman should be taken to theater as soon as possible. Repair of the OSS in the delivery room may be performed in certain circumstances after discussion with a senior obstetrician. And when obstetric anal sphincter repairs are being performed, you have to be cautious that the burring of surgical knots beneath the superficial perineal muscle is recommended to minimize the risk of knot and suture migration to the skin, which can lead to perineal pain later on. And a rectal examination should be performed after the repair to ensure that the sutures have not been inadvertently inserted through the anorectal mucosa, and if the sutures are identified, it should be removed, because later on it may lead to rectovaginal fistula. So how do you repair 4th degree tear? First, you have to repair the anorectal mucosa, followed by internal anal sphincter. The torn anorectal mucosa should be repaired first with sutures using either the continuous or interrupted manner with a 2030 monofilament suture. You have to be cautious that the suture should not go into the anorectal lumen. It should only be from the muscularis layer. taken from the muscularis layer. After single layer closure is done, and then torn internal anal sphincter is identified. It is a shiny whitish sheath-like structure over the anorectal mucosa. You correctly identify it, and sometimes when it is retracted, you have to laterally hold it with the LEs and mobilize it. It is advisable to repair this separately, and interrupted or mattress sutures should be taken without any attempt to overlap the internal anal sphincter. We have to be cautious that we should not overlap the internal anal sphincter, and end-to-end suturing should be done. How to identify, I already told you, it is whitish sheath-like structure. By using Ellis forceps, you have to grasp the ends of the torn muscle, and 30 and 40 or 40 sutures is used to repair. Then is a repair of external anal sphincter. External anal sphincter is, first you have to identify this sphincter, then you have to hold it with the Ellis tissue forceps, and as muscle get retracted laterally, you have to mobilize the muscle first. You have to remove it from the ischiorectal fat and then stitch. For taking the sutures for making repair, there are two methods, end-to-end and overlapping. How the end-to-end repair is done? It is more commonly employed for 3A and 3B tears. And first the sphincter is identified and held with Ellis forceps. And then the most important thing, it is to incorporate the facial sheath surrounding the sphincter in the repair, because the strength of the repair comes from the facial sheath rather than the striated muscle. So we have to be very careful that facial sheath is correctly identified and taken into the sutures. The sheath is repaired at the first posteriorly, that is 3 o'clock position. A simple suture is placed. Then inferiorly, that is at 6 o'clock position, the next suture is placed. Then the muscle is stitched. The striated muscle fibers should be stitched using a figure of 8 suture. Then you will place a suture superiorly and then anteriorly. And what is another method is overlapping repair. In overlapping repair, this is mostly used when the 3C, that is a complete disruption of external anal sphincter, is present, or the 4th-degree OSS is there. Once the ends of the sphincter are identified and grasped with Ellis forceps, the muscle is mobilized laterally using sharp dissection. At least 2 centimeters of the muscle should be visible so that it can be overlapped. And the suture used again is 2-0 absorbable suture should be used to reapproximate the sphincter in a vest over pants fashion or the double-breasted fashion. 3 or 4 mattress sutures are placed, reapproximating both the deep and the superficial edges of the muscle. As you can see, this is double-breasted application of the sutures. Now we'll play a video. This is not my video, I've taken from net. Here you can see repair of the anorectal mucosa is being done. First, the correct identification of the mucosa is done, and now they are suturing it in continuous fashion using a 2-0 vicryl. Now they are identifying that the suturing is complete. This is the mobilization of the internal anal sphincter. This is a white sheath-like structure being identified and mobilized. This is the internal anal sphincter. Now they will suture it with using again a 2-0 vicryl in an interrupted manner. Care must be taken to stitch it in an end-to-end fashion rather than an overlapping fashion. Internal anal sphincter, correct. If you leave an internal anal sphincter and do not repair it, it can later lead to anal incontinence. Even if the external anal sphincter is repaired correctly, if you leave internal anal sphincter, there will be chances of anal incontinence later on. Patient may complain of flatus incontinence also. Now they are grasping the external sphincter, mobilizing it, separating it from the ischiorectal fat by sharp dissection. For current identification of external sphincter, crossover test is done. That is, the two muscles are crossed over the anal verge, and the tightening of the anal verge is seen. This is the correct external anal sphincter. Now they are mobilizing it. After identification, now they will close the anal verge first. External, they are using the overlapping technique or the double-breasted technique for suturing the external anal sphincter. The sutures are applied in a mattress fashion. The repair of the external sphincter is complete. After that, the tightness of the sphincter is confirmed, and then the repair of the pelvic floor muscles is done. The puborectalis muscle, transverse perineal muscle, and bulbous spongiosum are then sutured. And the further repair is again similar to the episiotomy repair. So in postpartum management, you will, after the repair, you will do copious irrigation of the wound to decrease the bacterial load. And according to ACOG, only a single shot of IV cephalosporin at the time of repair is recommended. And if the patient is allergic to penicillin, you can give clindamycin. It is followed by an oral course of metronidazole and amoxiclav for 5 to 7 days. The patient is advised for perineal care, that is his bath twice daily for 10 to 15 minutes. Laxative should be advised for a week. Diarrhea should be avoided, and bulking agent should not be given. Suppository and enema is also avoided. Pelvic floor physiotherapy is advised, and abstinence for 6 weeks is advised. The patient should be called for follow-up early than the 6 weeks and should be examined for any infection, wound disruption, and incontinence. And the woman, when at the time of discharge, and in her discharge card, the type of injury should be clearly mentioned, and she should be fully informed about the nature of her tear, and offer for the follow-up should be made. So what are the complications we can see is infection and wound breakdown in the immediate post-op period also. Fecal incontinence, later on the patient can complain of fecal incontinence. And if you have missed a suture, you have taken a suture and you didn't know, or you missed a rectal buttonhole tear, the patient can come to you with rectovaginal fistula. So what are prognosis of such injuries? The women is advised that 60 to 80% of women are asymptomatic at 12 months following delivery. Even if a repair is done by an experienced obstetrician, still the patient can have fecal incontinence later on because of the injury of the pelvic floor muscles as well as the pelvic nerves, perineal nerves. These can also lead to fecal incontinence later on. So all women who sustained OSS in a previous pregnancy, she should be counseled about the mode of delivery and should be told about that the role of prophylactic episiotomy is does not ensure the prevention of OSS. And all the pros and cons of the elective cesarean birth versus a vaginal delivery should be discussed with her, and the decision should be made accordingly. The women who have sustained OSS in a previous pregnancy and who are symptomatic or have abnormal endovenal ultrasonography or manometry should be counseled regarding the option of elective cesarean birth. So to sum up, I would like to say that first we have to avoid having OSS. And if OSS has occurred, the main thing is the correct recognition of the injury and the repair of the injury. For the new beginners or with the person who have never encountered such injuries, they should always call for an expert obstetrician experienced in such kind of injuries, and then the repair should be done. Thank you.
Unmute karo.
Thank you, Dr. Ishika. It was a lovely talk. You have covered all the aspects. It's only the preventive care we can also counsel, warm perineal compresses as the doulas are doing. And RCOG also recommends perineal massage, especially for the primaries. So this is small things which we are usually missing out in our OPD and, not telling our patients, all the primaries, if they do the perineal massage in the 35 weeks onwards, they are at a lesser chance, and, warm compresses also helps them. But it was a wonderful listening to you.
Thank you, ma'am.
Thank you, Ishika.
Thank you, ma'am.
Wonderful presentation, and it is very necessary to understand what changes has come for the perineal tear, and the language, how to write it, and what documentation we have to do. So these type of the updates are really necessary.
The next speaker is Dr. Ruby Bhatia, and she is from Maulana Ambala. She is having a lot of publications to her credentials, and she's ex-professor from Patiala. She's vice president and life member Society Fetal Medicine, ex-secretary of and life member Patiala Menopausal Society, ex-treasurer and associate member National Nabha HARObGyn Society, and many more. So can we start? And because as we're running late, so can we start the videos, please?
Yes, ma'am. Yes, ma'am.
I can say only one word about the professor and head of department, Maulana Dr. Ruby Bhatia. She's a great academician, and continuously she is doing the programs for the PGs. Excellent program and excellent teaching.
We welcome Dr. Ruby Bhatia.
Please start.
Welcome
the
you,
video,
ma'am.
Dr. Ruby.
Good afternoon, all. A very warm greetings. First of all, I would like to thank Dr. Ragini Agrawal and team for making me part of this great academic event, Abhilasha, for safe motherhood. My topic given today is intrauterine balloon tamponade for postpartum hemorrhage. As we all know that hemorrhage, along with hypertensive disorders and infection, is a direct cause for maternal mortality. And in hemorrhage, 80% of it is because of postpartum hemorrhage. And further, 80% of postpartum hemorrhage is atonic PPH. And all of us should be on red alert with the highest obstetricians to save the mother from clutches of atonic postpartum hemorrhage. 70 to 80% of maternal mortality due to hemorrhage is only because of postpartum hemorrhage. Globally, nearly 1/4 of all maternal deaths, they are associated with postpartum hemorrhage, and majority of these are in low-income group, and unfortunately, India is one of it. Risk of maternal death is highest in low-resource countries like India, Africa, due to postpartum hemorrhage. Now, to prevent postpartum hemorrhage, all of us must practice active management of third stage of labor with 10 units of oxytocin after the delivery of the shoulder of the baby, delayed cord clamping by 1 to 3 minutes, and controlled cord traction only by a skilled birth attendant, so it's optional. Uterine massage is no more recommended. However, a hand must be kept on fundus to check for the uterine tone. WHO in 2021 has recommended uterine balloon tamponade for treatment of atonic postpartum hemorrhage. due to uterine atony after vaginal birth and in women who have failed to respond to the standard first-line medical treatment provided. When should we put the tamponade in atonic PPH? If there is immediate recourse to surgical intervention and access to the blood products is available there and then, a primary postpartum hemorrhage where first-line modalities, uterotonics, tranexamic acids, and IV fluids are available. Other causes of postpartum hemorrhage, that is traumatic PPH and retained products of placental tissue, they have been excluded, and the procedure is performed by a health personnel who is skilled and trained in managing postpartum hemorrhage using uterine balloon tamponade. And it should only be done where maternal condition can be regularly and adequately monitored for prompt identification of any signs of deterioration. Uterine balloon tamponade use for PPH treatment is probably feasible and acceptable to all the women and providers and is cost effective too. Now, all of us know that management of postpartum hemorrhage is a sequential process. First, we should assess and immediately intervene. Always proceed from less invasive interventions to more invasive interventions. Hurried revision of management of PPH, if the blood loss is more than 1000 ml, maybe after cesarean or vaginal delivery, a call for help, never hesitate to call the senior most obstetrician. Resuscitative measures to proceed and monitoring and IV investigations with 2 wide-bore 14-gauge cannula and rush crystalloids and colloids and blood products with all the basic investigations. Then always start medical treatment as first line. Rub the uterine fundus. Uterine massage should be vigorous. Bladder should be empty. Oxytocin, slow IV, ergometrin 0.5 milligrams slowly, IV or intramuscular. Oxytocin infusion 40 units in 500 ml. If it fails, carbopros 0.25 milligram intramuscular every 15 minutes up to 8 times. And if needed, misoprostol 800 micrograms sublingual. And always consider tranexamic acid 1 gram intravenous. If it's still not controlled, shift the patient to the theater and please confirm if uterus is well retracted. Go for examination under anesthesia and let the clotting abnormalities be corrected. And then we can proceed on to intrauterine balloon tamponade. If it succeeds and patient starts improving, we can do away with many of the more invasive procedures. Otherwise, we proceed further for brace sutures or interventional radiology or stepwise devascularization with bilateral internal ligation. And the last resort is hysterectomy. And high dependency unit services must be available. So tamponade with an intrauterine balloon tamponade is a stopgap after the medical management and before we go on for invasive surgical management. The other modalities are uterine artery ligation or embolization, uterine compression sutures, and last and life-saving is hysterectomy, where all conservative measures have failed. Uterine tamponade, since time memorial, had been done by plain gauze or laparotomy sponges or by hemostatic gauze or by compressed mini sponges. Lately, we are doing it with the vacuum-induced tamponade, and this remains the preferred method of balloon tamponade. The various types of balloons available to create intrauterine tamponade in atonic postpartum hemorrhage. They range from a simple condom catheter to a Foley's catheter. Then we can have a silicone Foley's catheter, Sangstaken backmore tube, BT cath, Bakri balloon, which is very good but very expensive, and the air balloon. Now, the mechanism of action is there is exertion of inward pressure from the catheter to the balloon, and there is manifestation to outward pressure which exceeds systemic arterial pressure to counter the uterine bleeding. So we should have, before we do a intrauterine balloon tamponade, patient should be in operation theatre with adequate light positioning. Bladder must be empty and never hesitate to call for assistance. Earlier, we were doing gauze packing for tamponade, but inserting gauze for a longer time, there is risk of retained foreign body, risk of infection, and sometimes what happens that there is ongoing bleeding which gets absorbed in the fabric and we may be misled. And expertise for even for the gauze packing is a must. So where should we use balloon tamponade in atonic BPH? Wherever patient with a postpartum hemorrhage due to uterine atony and traumatic PPH has been ruled out, coagulopathy has been corrected, and uterine atony which is not controlled by first-line medical management with uterotonic drugs, they are the candidates for balloon tamponade. In patients with the lower uterine segment bleeding, especially in placenta previa or with the low-lying placenta, and you are going for doing a cesarean section, and there are bleeders which cannot be controlled with hemostatic sutures, there also you can go for balloon tamponade. Now, remember, PPH tray, or I will call it a life-saving tray, should always be ready in the operation theatre and in the labor room scenes. Now, remember, for this tray, for the balloon tamponade, we should have a Foley's catheter with number 22. This is very, very essential. Only then there will be free flow of saline, a bottle of saline, Euro bag, syringes, 20 cc syringes, mesoprost, carboprost, oxytocin, and all life-saving drugs with all the speculum, sponge holder, retractor, vaginal wall retractor, scissors. And so always be on red alert, calling senior obstetricians whenever there is atonic PPH. Perform tamponade before coagulopathy sets in. Continue concurrent medical management of postpartum hemorrhage. That with infusion of oxytocin 40 units in 500 ml, which should be continued for up to 24 hours to maintain the uterine tone. Tranexamic acid 1 to 2 gram intravenous must be given for clot cell stabilization. And if even after uterine balloon tamponade, the bleeding continues and the patient is deteriorating, we can go on to compression sutures, stepwise devascularization, or peripartum hysterectomy. For intrauterine balloon placement, have a balloon catheter, Foley's catheter number 22, sterile fluid 500 ml, 2 large Luer-Lock syringes, atraumatic forceps, antiseptic solution in form of betadine, povidone, iodine. Indwelling bladder catheter, separate from the Foley's catheter for tamponade, a urine collection bag with urometer, portable ultrasound machine, and gauze or vaginal packing. Now, remember, it's always best to do the intrauterine balloon tamponade under the guidance of ultrasound if available in OT. To place the balloon after vaginal birth closure or vaginal birth for atonic PPH, or even if there is an atonic postpartum hemorrhage in cesarean section scenarios, we can place an intrauterine balloon during cesarean section. So patient is placed in lithotomy position, and whenever visible, it should always be ultrasound guided. Clean and drape the part, grasp the anterior lip with ring forceps, apply dental traction for cervical canal and uterine cavity alignment, and place the catheter in the intrauterine position. So this is, we have placed the catheter, and this space near the fundus should be empty because we have to inflate the balloon. We can use a ring forceps for insertion of the balloon as high in the cavity as possible without using excessive force, or the catheter or the balloon can be placed manually. If patient is having atonic postpartum hemorrhage at the time of cesarean section, then again place the patient in a butterfly or lithotomy position, insert the balloon through the lower segment in a cesarean incision into the uterine cavity, and pass the stem of the catheter and distal end of the Foley's catheter through the cervix into the vagina. Carefully close the uterine incision after putting about 50 to 100 ml of saline in the balloon, and then you close the incision so that there is no puncturing of the balloon prior to the fluid installation more than 100 ml. And if still she is bleeding, along with, we can also apply uterine compression sutures along with the balloon tamponade. Advantages of balloon tamponade: this is an easy procedure which can be taught to every basic MBBS doctor or a skilled birth attendant. There is a relative ease of insertion. It is ability to use a single device, and it stops bleeding from the lower segment of the uterus in placenta previa in cesarean section, apart from atonic BPH in vaginal deliveries. Balloon tamponade under transabdominal ultrasound prevents any risk of perforation. Now, patient, we have done this. How do we insert it? And now, you should remember that vaginal packing is must to keep the balloon in position, and attach a collection bag with a flow meter for the drainage port so that we can see how much bleeding is occurring, and always mark the level of the fundus and put the patient on antibiotic cover. So if the tamponade test is positive, the bleeding stops, and we can keep it from 4 hours up to 24 hours. And oxytocin infusion must be continued for 12 hours, and always watch for signs and symptoms of any ongoing loss by observing pallor, dizziness, hypotension, tachycardia. The deflation of the balloon should be gradual, and if there is patient is stable and no further bleeding, you can remove it anytime after 4 hours up to 24 hours. The risks are infection or the scar descents in case of cesarean section, cervical trauma, and very, very rarely uterine perforation. Now, I just want to tell, we make a CT balloon with Foley's catheter number 22, and this is, we are doing it in and day out practice in vaginal delivery and cesarean section wherever we encounter atonic BPH not responding to medical management. Now, from the distal end of the Foley's catheter, you cut 2 rings. These are called rubber bands. So we cut, these are the 2 rubber bands from the distal end of the Foley's catheter. And then you inflate the bulb of the catheter with 2 to 5 ml of air. And you give an incision at the distended end of the catheter. Now you put the condom over the catheter, and you place the rings which you have cut from the distal end of the Foley's, one about 1.5 to 2 centimeters from the tip of the catheter, and the other at the where the condom is at the distal end of the condom. And the tip of the catheter is cut, leaving behind 1.5 centimeter area beyond the rubber band. Now, then you start inflating it with the normal saline after inserting it to the uterine cavity, and we can put up to 300 ml and maximum up to 500 ml. And usually the bleeding stops by 300 ml in a vaginal delivery and by distending up to 500 ml in a cesarean section. And remember, the results are beautiful, and the need for the more invasive procedure is very, very less. And this is something which is recommended by the WHO. Never put more than 500 ml. Now, this is the balloon is kept in uterus. Maybe we can keep it up to 24 hours. And when you deflate it gradually, you must keep it in for some time to watch for the bleeding. A very important, another advantage of tamponade is that we can also insert it in vaginal lacerations. They continue to bleed despite suturing, or paravaginal hematomas with no discrete bleeding points. So there we can do a vaginal packing with gauze, or we can do a balloon tamponade, and this has also been found to be very effective. If we have nothing else, we can put a blood pressure cuff in the vagina, which is put in a surgical glove and inserted into the vagina where the bleeding, from where the blood is oozing. So intrauterine balloon tamponade for atonic postpartum hemorrhage is safe, cost-effective, non-invasive, with a high success rate of 80 to 95%, especially in low resource settings, and can prevent the need for the more invasive surgical intervention. It is a high success rate for treating severe atonic PPH and is safe. Balloon tamponade is an effective non-invasive modality in atonic PPH to reduce maternal mortality ratio, a step forward to achieve SDG goal 2030. Thank you. Thank you all.
So very nice presentation from Dr. Ruby.
I'm sorry to interrupt you, but we have very short videos of Ruby ma'am also, 2 videos. Those are the practical videos. If you
Non-toxic agents fail to control hemorrhage. Uterus still remains atonic. Balloon tamponade may save the women from death and may also prevent the morbidity due to peripartum hysterectomy and nephrotomy. And many times when the patient is at periphery, where only single doctor, maybe not even a gynecologist is there, so it is a wonderful modality before she shifts the patient to the tertiary care, and it may totally stop the bleeding, or it may give you a stopgap time when she can be taken to tertiary care for more invasive surgical procedures. Now for this, we should have speculum, ring forceps, vaginal retractor, a scissor. Then we should have Foley's catheter number 20 or number 22, and normal saline, IV set, a Eurobag, and 20 cc syringe. Now we open in all high-risk cases, wherever we suspect postpartum hemorrhage, these things should be near the delivery terrain so that immediately we can perform the balloon tamponade. Now usually the patient is in operation theatre and we have done examination under anesthesia and no obvious traumatic cause is found. So we should give a trial for balloon tamponade. Now this is number 20 Foley's catheter. You open the catheter as well as the condom.
It's done.
Okay, thank you. So now we are going to the last part. I think Jyoti is not there.
Ma'am, she has gone. Jyoti and Reema are not here.
Yeah. So we invite Dr. Bindu Yadav, who is a professor of OBGYN in HSD Medical College, Gurgaon. And she has a special interest in teaching and training. And she has worked as a senior consultant at Monica also and prepared modules on the maternal health for peripheral health worker. Welcome, Dr. Bindu. The biggest emergency of the obstetrics is going to be unveiled.
Thank you, Dr. Ragini. Thank you so much for inviting me to this very intense academic activity. And the topic that you have given to me is uterine rupture. Needless to say, we all know that uterine rupture is disruption in the continuity of the uterine layers, which can be complete or incomplete. When we say it is complete, then all the uterine contents, or when most of them, can escape from the uterine cavity, resulting in fetal death. When it is an incomplete rupture, the visceral peritoneum is intact, the fetus lies in the uterine cavity. Now, there are some other terms which are sometimes used interchangeably, that is uterine dehiscence or uterine scar rupture. Uterine dehiscence is when, as you can see in this picture, when the myometrial separation is at the site of uterine scar from previous surgery. Uterine dehiscence, as was just showing the slide, that there is separation at the site of uterine scar from previous surgery and the uterine serosa remains intact. When we have uterine rupture, then myometrial separation involves the entire thickness of the uterine wall, resulting in communication between the uterus and peritoneal cavity. Why talk on uterine rupture? So this is because there is an increase in the incidence of cesarean section, which has also resulted in an increase in the need for trial of labor following cesarean sections. And the greatest complication following TOLAC is a foil TOLAC. We know that the incidence in uterine rupture after previous lower segment cesarean section is 0.8 to 1%, whereas it has always been, we have tried to remember that following classical cesarean section scar, the uterine rupture rate is much more than 5%. But what we have to remember is that when one cesarean section, the incidence is just 1%, but after more than one, the incidence goes up to 3.9 to 4%, increasing not only the morbidity, but also sometimes the mortality. The incidence all over the world is different. In developing countries, it is much more than that in the developed countries, and the cause also is slightly different. The developed countries more often encounter uterine rupture following trial of labor on a scarred uterus, but in countries like India, we have a higher rate of uterine rupture, which is as much as 0.62 per 1,000 births. And the rate may be higher because of neglected labor, mismanaged labor, and sometimes late referral, poor infrastructure at the periphery. Coming to the classification, most often rupture is in the pregnant uterus, but sometimes it may happen also in a non-pregnant uterus, maybe due to trauma, infection, or malignancy. The pregnant uterus may undergo rupture spontaneously. There may be rupture during labor, during pregnancy. There may be a scar rupture again during pregnancy or labor, or maybe even iatrogenic following trauma. And sometimes when we are doing some procedures like versions, we all know that for a good success rate, we need relaxation. But not only does neuraxial anesthesia improve the success rate, but it also masks the pain. So many times, and most of us, we avoid neuraxial anesthesia because the uterine rupture may be missed. The causes of rupture during pregnancy, labor, and post-delivery are much similar to what I've just said. Most often it is due to previous scar rupture. Sometimes it may be due to certain accidents during pregnancy, placenta accretia, Mullerian anomalies. During labor, it may happen because of, again, previous scar, malpresentations, unrecognized cephalopelvic disproportion, obstructed labor. As you can see here, here the uterus, that it's getting thinned out because it is a overstretched uterus in a multiparous woman who has delivered earlier, resulting in the formation of a Bandel's ring, which is one of the signs of obstructed labor, which can subsequently result in rupture. Instrumental tear which sometimes extends to the cervix, sometimes to the vagina. This can again result in uterine rupture. Rarely, tumors obstructing the birth canal, pelvic deformities may also result in uterine rupture. Post-delivery again, we sometimes encounter uterine rupture, especially when there is hemorrhage and we are just exploring the uterus and we find that, yes, the uterus is ruptured. Or sometimes when after delivery of the baby, rather than seeing a lengthening of the cord, we find that it's getting shortened, which is a sign that maybe rupture has happened. So coming to the most important cause, that is TOLAC or trial of labor, we find that myometrial thinning in the person who has had a previous cesarean section is observed in 0.2 to 4.3% of the cases. And the methods to check the integrity of the previous cesarean section scar include interval hysterography, MRI imaging, and ultrasound. The lower uterine segment morphologically, on the basis of thickness, has been categorized into 4 grades. It is grade 3 and grade 4, where we have to become alert. Grade 3 is scar dehiscence, grade 4 is the ruptured uterus. So but what we have to remember is that while the cutoff value of thickness in different studies has been reported to be between 2 to 3.5 millimeters, the chances of uterine rupture, regarding the chances of uterine rupture, they're said to be much less if it is more than that. But there is no consensus regarding this diagnostic criteria. So we have to be clinically alert when we are managing such cases. So symptoms of uterine rupture during labor, it is definitely a clinical diagnosis. So the contractions which have become slower or less intense. A woman who was having good uterine contractions has now started not having pain of contractions, but in between she's feeling abnormal abdominal pain, and there may be vaginal bleeding. On examination, we find that she's showing features of tachycardia, low blood pressure, and shock. Fetal heart has become abnormal, and there is loss of muscle tone, uterine muscle tone. On vaginal examination, there may be slight bleeding, and very importantly, recession of the baby's presenting part in the birth canal. So when rupture occurs during labor, it may cause contractions to slow down or lose intensity. The diagnostic triad for uterine rupture during pregnancy includes acute abdominal pain, painful third trimester bleeding with unstable vitals, and non-reassuring fetal heart sound. So in such a case, when we have a woman in the 2nd or 3rd trimester who has come with bleeding per vagina, and so we think of some differential diagnosis, we have to remember that the differential diagnosis could be abruptioplacentary, preterm labor with excessive show, and maybe even placenta previa, though generally placenta previa is not associated with pain, but occasionally patient may have slight pain. In a woman who is stable and she's having a possible minor rupture, ultrasound can help. But we think of differential diagnosis, then in abruptioplacentary, the uterus will be technically contracted, whereas in uterine rupture, we will not see the increased tone. We will feel a very flabby uterus, superficial fetal parts. So it is generally a clinical diagnosis, but if a woman is stable and if we are not sure, then maybe ultrasound can help. If the scar has given way, then the early presentation includes late decelerations on CTG, persistent maternal tachycardia, suprapubic discomfort, or scar tenderness. And if it is not attended to, patient is deteriorating, then she may have vaginal bleeding with hematuria. So a uterine rupture should be considered in all women undergoing a TOLAC who have hypotension, change in contraction pattern, fetal bradycardia, abdominal pain, hematuria, loss of fetal station, or vaginal bleeding. Management, this is something that it has to be very fast. It includes 2 things, resuscitation and damage control surgery. There is an extremely short window of time to respond to the above injury to the mother and the baby. Uterine rupture requires both these things simultaneously, delivery and treatment of the mother maternal hemorrhage. So coming to the resuscitation and treatment priorities, we check for the maternal responsiveness and call for help. Airway and breathing have to be looked into. we should ensure that the woman is breathing, give her oxygen, ensure circulation by starting 2 large IV cannulas, green or gray, 14 or 16 cans. So ensure that we can do lateral positioning to minimize the outer cable compression. We send the blood for counting, hemoglobin estimation, grouping, cross-matching, electrolytes, kidney function test, venous blood gas and coagulation screen, because we have to remember the 3 lethal triad, which may be detrimental to our health, which are hypothermia, coagulopathy, and acidosis. Because if the patient is not kept warm, her peripheral circulation will get jeopardized. So the general resuscitative measures include, of course, as I said, we start the circulation. The aim is to replace the blood loss. We can start by giving the crystalloids, which, as you know, have a transient effect. But till the time the blood is arranged, we will give the crystalloids, normal saline preferably. And of course, we have to monitor the urine output and by inserting a catheter. Central venous pressure will also help in the resuscitative process. The goal of appropriate blood product transfusion is to maintain blood circulation and improve the tissue oxygenation and prevent or reverse coagulability. So we attend to all the 3 components of lethal triad, that is the hypothermia, coagulopathy, and acidosis. And after that, we start with the damage control surgery. So the surgical management depends upon the woman's general condition, depends upon the type of rupture, obstetric history, and the site of rupture. So you can see that the site here, it's an upper uterine segment rupture, which I've only seen once. Then there is a lower uterine segment rupture. Yes, we do get them very often. Obstructed labor, I did see, and is still now coming in multiparous women. And this is a picture from the net where it was said to be from a posterior wall rupture following instrumental delivery. So the hysterectomy, if we plan for a cesarean hysterectomy, then the procedure, the steps are more or less the same as gynecological hysterectomy. However, there are certain pitfalls. Why? Because we should open the abdomen by a longitudinal incision for better exposure. If inadvertently we are opened by the transverse, we may need to do division of the muscle. There may be scarring from previous surgery, so bladder must be dissected. Sharp dissection. If it's a scar rupture, then after delivery of the baby, we will exteriorize the uterus for better handling of the situation. Most important problem or intraoperative complication is hemorrhage. This may be because of edema of the ventricles and massively increased vasculature of the uterus. So in that situation, given the size of the uterus, the pedicles, we may have to make several pedicles, small pedicles, and also important that we should also put pedicle on the uterine side. Avoid vigorous suction. Sometimes there may be a broad ligament hematoma, especially if the extension has extended laterally, the tear has extended laterally, then we may need to resort to internal iliac ligation. Now, here is what some people have a little doubt about, whether we should go in for total versus subtotal. We are doing total hysterectomy because we work as a team. So with 2 people experienced, we can do total hysterectomy, though it takes more time, maybe more blood loss, and the cervix is removed. However, if the patient is unstable, then subtotal hysterectomy may be needed. If it is a case of scar dehiscence, sometimes the repair of scar is difficult because the thinned out scar uterus makes it very difficult to repair. And while delivering the baby, the lower uterine segment, the wound can extend both downwardly or transversely. So in that situation, it is important to make an incision safe, which may sometimes have to be vertical also, and then repair it. This is one such picture which I've taken from the net. Here they have shown a thinned out lower segment scar. And after doing the dissection of the urinary bladder flap, it is advocated that we can put a stitch on the lower uterine segment for identification after the lower uterine segment after the delivery of the baby. So this will facilitate the identification and repair of the uterus. The repair of the scar depends again upon where it is situated. We normally like to do the first layer continuous, but if it is a fundal rupture, then many a times interrupted sutures may have to be taken. We can use Weichel number 0 followed by the second layer, which can be interrupted mattress. Hemostasis has to be maintained. That is very important. And it is important that we dissect the bladder away with sharp dissection so that there is the injury to the bladder can be avoided. Coming to the internal iliac ligation, if there is a broad ligament hematoma, we have to open the interior leaf of the broad ligament and identify the ureter by peristalsis and look for the common iliac artery 2 to 3 centimeters below the division of the common iliac. We will, with the help of a mixture, we will apply the knots, but it is important that we palpate the femoral so that we are sure we have not done ligation of the posterior branch of the internal iliac artery. So the complications, as I said, for during the cesarean hysterectomy, hemorrhage is important. So these bleeding can arise from the pedicles. So we have to be very careful when we're applying the pedicles, and also apply the clamp on the uterine side. Then another important complication that has been noted is urinary tract injury. 16%, as high as 16% urinary tract injury has been reported following ruptured uterus. So integrity should be checked by retrograde filling of the bladder. Coming to the ureter, which can be ligated at or injured at 3 points. Sometimes if there is any hematoma in the adnexal structure, then infundal pelvic ligament ligation may have to be done. So after identifying the ureter, then we are more careful. Exteriorizing the uterus also will help in reducing the injury of the urinary tract. Postoperative complications can be to the mother and the fetus both. So the mother, of course, hypovolemic shock and fistulas, psychological trauma, and sometimes even death. Fetal outcome, most often if it's a complete ruptured IUD, but if it's a scar dehiscence, then there may be low Apgar score. So rupture of the unscarred uterus, they are associated with greater blood loss, higher incidence of hysterectomy and maternal morbidity as compared to the rupture of the scarred uteri. So with good surgical intervention and resuscitation, most women may survive a uterine rupture, but maternal mortality associated with rupture of an unscarred uterus is higher than that with a scarred uterus. And what I would like to emphasize upon is how to prevent uterine rupture. So first of all, that I would like to advocate is the use of an partograph, especially at the peripheral health centers, so that the undue delay in the progress of labor, especially in a multipara, who has had previous uneventful deliveries, they should be taken, they should be looked upon and referred to the center where appropriate management may be done. Selection of cases and careful watch during oxytocin infusion, either for augmentation or induction, will be helpful in preventing uterine rupture. And if the LycoRed has drained out, then all uterine manipulations should be avoided. Instrumental delivery should only be performed when all prerequisites are fulfilled. Selection of cases for TLAC, this is a very important aspect of preventing uterine ruptures. So as I said earlier, if TOLAC fails, then there is need for emergency cesarean, and that is associated with high morbidity and mortality as compared to the compared to an elective cesarean section. So for outcome, it is better that we should know about the number of scars, the site of scars, the shape of the scar, because as you can see here, classical scar and T-shaped scar associated with 4 to 9% uterine rupture. Low vertical has 1 to 7% uterine rupture. Previous normal vaginal delivery, and very importantly, the resources. If the center where we are carrying out TOLAC, that center should have all the prerequisites for carrying out an emergency cesarean section the moment we have signs which are suggestive of scar dehiscence. So due to the risk, it is a level 5 evidence as per RCOG that this should be performed in locations. TOLAC should be performed in locations where emergent cesarean section delivery is offered. So in cases of obstructed or threatened labor, immediate cesarean section should be performed. All intrauterine manipulations avoided. Forced and difficult external cephalic version should be avoided, and manual removal of a morbidly adherent placenta should be performed carefully by an experienced obstetrician. Now coming to another topic, which is part of the uterine rupture, that is pregnancy after repair. Most often we have women who come with uterine dehiscence, scar dehiscence, and we do the repair and then we do the ligation. But nowadays we're getting more and more women who do not give consent for ligation. So postpartum consultation with ultrasound for looking at the quality of the scar, advising them to delay pregnancy for at least 6 months to 1 year. If now pregnant, explain the risk of uterine rupture, explain the risk of placenta accreta, and monitoring by monthly ultrasound for fetal well-being and for the size of the thickness of the scar. Inpatient monitoring is very important. So admission 2 to 3 weeks before the previous time of uterine rupture, and if less than 34 weeks, role of corticosteroids should be discussed with the family. And of course, an elective planned cesarean will help in the outcome of the mother and the baby. To summarize, uterine rupture is a preventable obstetric complication. Even if the women survive, future reproductive potential activity is reduced. And the important positive factors are grand multiparity, injudicious use of oxytocics, neglected obstructed labor. So health education of rural people, training and supervision of the skilled birth attendants, availability of emergency transport, and timely referral may reduce the incidence. Thank you.
Thank you, Bindu ma'am. It was a very exhaustive topic and you've covered it very nicely. And yes, uterine rupture is indeed a nightmare which we all dread, and we have to act fast whenever we anticipate any rupture. Thank you so much.
Thank you.
Thank you, Dr. Bindu.
Thank you,
and thank you everyone who are still here and enjoying this academic feast. Dr. Promila, are you there? Please propose vote of thanks.
Okay. So first of all, I'd like to congratulate Dr. Ragini, all speakers and panelists for this great academic feast. And a big thanks to all the delegates for sparing their valuable time on Sunday. Hope all of you must have enjoyed all sessions, as they were all very practical and useful in our day-to-day. If you don't thank all our sponsors. Thanks to Ankit and Deepika for coordinating the entire CME so well. Thanks to Jagsonpal, Fusion, Nutrilo, LifeCell, Bayer, Blisson, Fujinkami, Morepen, ART IVF, Radicon Lab, and GSK. A big thanks to all.
Yes, madam, a great conference. Congratulations, Ragini madam, Jyoti madam, and all the organizers and conveners. Great conference. Nice experience. Thank you very much.
Thank you, Dr. Ajay, for your wonderful medical legal practical tips.
Yes,
thank you, ma'am.
Yes.
Thank you.
And thanks for joining and remaining there.
Thank you, Promila, ma'am.
Thank you, Dr. Ajay. Thank you.
We will come to the end. Over to you, Deepika.
Thank you.
So
Thank you.
close the meeting now, ma'am.
Yeah.
Okay, Deepika, thank you.
All right. Thank you very much. Bye-bye.
Ankit and Deepika both. You coordinated the meeting so well without any technical glitches.
So
Thank you,
Mr. Amit
Sonika.
Saxena is our digital head. Amit, please close the meeting.